outcomes. It's not just about giving patients medication and saying, you give a new medication, go home. It's giving them medication that are able to help them continue becoming productive citizens of our nation, becoming productive family members, and being able to, fulfill their full potentials, and even reintegrating them fully to society. Statistics have shown that 1 in every 4 Kenyans, and I like when I say this, or Dr. Njuguna may also say it when he stands here, even Dr. Janet, that 1 in every 4 Kenyan is likely to experience a mental health disorder in their lifetime. When I say this, most people start counting. Tuko wangapi kwa hilo? Na nishaona watu hapo wakifanya hivyo. It's good. It's good to be aware. And when we say 1 in 4 Kenyans experiencing a mental disorder, it doesn't mean that they are automatically disabled for the rest of their lives. It says that people get ill, but they get better and go back to work and continue to function. Yeah? All right. So it could be people who are amongst us who have gone through a mental illness, but they got better and they got care and support and they were able to continue being productive. Mental illnesses are also a leading cause of morbidity and mortality. Sorry. And we also know that suicide is one of the top leading cause of deaths, especially amongst young people. So there is a high, we are finding that ikitu inanikata. It's also, okay, good. Yeah, so as I was saying, 1 in 4 Kenyans, and it's one of the leading causes of disability. And as we've seen, it's really, really affecting our young people. The determinants of mental health have really changed with the trends we have currently in society. We can no longer just speak about genetics, biological factors. We can no longer just speak about environmental factors without talking about the digital space that we are in currently, the influence of technology, the globalization that we are having that is really even changing the cultural aspects we used to embrace as a society and are becoming a deep cause of the mental health of people in our society, especially the youth. And this is something that we're encountering every day. You hear somebody has died by suicide, or you see young girls, young boys, and in schools having habits that are likely to have been influenced by something that they are copying from the digital space, and it's affecting their mental health. And again, it's not something that is isolated to our mental health facilities. It is something that we've seen across all health services. Even when it comes to physical conditions, people who have cancer, they struggle a lot with depression. People with NCDs also struggle a lot with the other mental health conditions. So it is no longer something that is to be in isolation just across the mental health spaces. Unfortunately, despite this heavy burden, only about 15% of people who need care. So the 4 of you who you counted yourselves amongst you, maybe that even one person who is suffering from that mental health illness will not even access care. You can imagine, even in the marginalized areas within our country alone, you find that people have to travel long distances to find even a psychiatric nurse, a psychologist. Getting a psychiatrist is even a tall order, because we don't have sufficient mental health providers. We do not have enough, we don't have adequate facilities. In this country, we have less than 20 inpatient government-owned mental health wards. We have about 700 beds. So if it's 1 out of 4 Kenyans, and there are 700 beds for mental health services, and all these people need care, imagine how many people are going to access service when they need it at any one point. So moving further, beyond the limited access to services, this cursor keeps moving all the way it wants. The workforce constraint, stigma has been one of the leading causes of reduced access to care. If somebody told you they have cancer today, you'll be very compassionate to them. Is that true? And we'll even contribute in our M-Pesa, WhatsApp groups, and ensure they get appropriate care. But when you hear somebody has severe depression, people start saying, sasa huyo, simpeleke akaombewe. Isn't it? When you hear somebody has addiction and substance use disorder and they need to go to rehab, not many people will even say, why should we contribute for him? He brought it upon himself. Have you ever seen a WhatsApp group created for someone going to rehab? Aha, that is good. That is encouraging. And I hope guys changad. And even when he relapsed and had to go back, people were able to, up on your shida. But when somebody has cancer and, comes back, do we still say, hatuwezi changa the second time? No, we don't. So stigma, and then when you hear that this guy comes and declares and needs to be employed, that he has history of mental illness, sometimes you say, huyu labda tumpatie desk job, haezi enda field. True or false? So even when they want to come and renter their job after going to hospital for admission for mental illness, at workplaces we stigmatize them. Even at the OPD, when you are I'm sure here there are people who are maybe working in the A&E. When a person is brought to the A&E and they are seemingly psychotic, but they have a fracture, they are likely to be told, call the psychiatrists first, instead of attending to the bleeding. So they face a lot of stigma across society and even in our healthcare systems. We also have poor data, very weak data that does not allow the people who are responsible for planning, for financing, and for policy making to make appropriate decisions for prioritization. So mental health is often under prioritized. I have not taken a tour of this hospital, but I would like to know the bed capacity of the mental health ward and the corner it was put. If you go to many hospitals, for most of us here who are doctors and went to do internship in the county referral hospitals, and they had a mental health ward, it was placed somewhere very close to the mortuary. True or false? Hidden and forgotten. Yeah? People rarely, even when the hospital tours are done, they are never, yeah. And then when the wards are being renovated, it is never renovated like the others. So what do we need to do? Because of these gaps, and we can't solve all these problems overnight. We may not have enough psychiatrists. We may not have enough psychologists. We will not have enough psychiatric nurses. We will not have enough psychiatric wards. We need to look at where we need to prioritize service delivery. A lot of people, we need to concentrate more on self-care and self-management. And this means that we need to improve promoting mental health within our communities, within our families, to prevent the need of people to go to hospital, and improving even early detection. So if you look at this pyramid, we are talking about making sure that mental health needs are met at the base of the system. And that is where I'm talking about integration of mental health into all systems, especially primary health care and all the other systems. So what we need to do here is empower families, empower schools, empower communities to be aware of how to preserve mental health. Then beyond that, then we go to the primary health care and maybe train our community health promoters, train our healthcare providers in the primary health care to be able to identify and manage most of the mental health conditions that are common, and refer only the necessary cases to the higher levels. And this model of approach really promotes that people first focus on promoting health before we have to go to building very, very expensive structures of mental health care. So integration of mental health means more than building facilities or teaching cardiologists how to manage mental illnesses. It means talking to the communities on health promotion, going to the primary health care providers, and then especially ensuring that everybody who gets into contact with the person who has presented themselves to hospital, they can at least screen for mental illness. Up to about 40% of patients who are admitted in our wards are suffering from a mental illness. 25% of those who come to our OPDs, the same. But most of them are not even detected. They are sent home because they'll come with them. They talk about headaches, back pain, recurring, maybe, pains and other symptoms that really you cannot put a diagnosis on it. And I know ENT specialists see a lot of these people in our clinics, and pain specialists also, sleep specialists the same. But what do? We'll prescribe maybe a painkiller, and then this person will go to another person, another doctor, they'll be told it is H. pylori, and the list goes on. But if we empower all these people to be able to also screen for mental health conditions, then we'll have more people diagnosed correctly. And so we've had different approaches in the integration of mental health services. The all-time and the most common one is separate services in different facilities. So you have KU teaching, training, and research. Did I get it correctly? That one here. And then you have Mathare. Then you'll refer, let me use Kiambu Hospital. And then they refer to Mathare without having their own central mental health facility or services. And then there is a co-located care where it's in the same place, but still separate. So it's in a corner somewhere near the mortuary. So Dr. Janet will be there, and you'll be sending the patients there, but it's all within KU. This is better because at least you're within the same facility and the referral can be quick. But when we talk about integration, is when you have one team, one plan. When you're doing that major ward round, do you have a psychologist in your team? Do you have a psychiatric nurse in your team? Do you have the psychiatrist in your team? And then you can actually manage that person as a whole. You assess the person as a whole, as a team, and you manage as a team as well. All right? So this would be the best approach where you have one care team, shared treatment plan, and holistic care. But we do know that there is a lot of systemic issues, and it's also expensive. So let us embrace what it is that we can and ensure that every patient is able to get the service, be it through the coordinated care model, co-located care model, but integrated care model is the best approach. And when we are talking about mental health care, we must look at the continuum. The person who comes into contact with your healthcare services may not have an illness yet, but they may be in the process of even becoming, having a mental health condition or a mental illness. For instance, if you diagnose somebody with a chronic illness today, that already poses as a risk factor to a mental health condition. So it is important to also ensure that we are also talking about promoting well-being, preventing and reducing the risk, and then treatment and rehabilitation. And how we do this is by promoting we create mental health literacy and reduce stigma in the community and ensure community wellness. By prevention is that when we are screening people for routine health care, we screen also for mental illness, and specifically focusing on groups that are more vulnerable. And then, of course, treatment is where you actually are deliberate to manage the conditions as you can or by referral. We use a WHO intervention guide called MHGAP to train primary healthcare workers on how to manage common mental health conditions. That is what we are doing at the Ministry of Health using this MHGAP. It's a simplified version of training people how to manage common mental disorders at primary health care. And then, of course, ensuring in the community beyond treatment, the same way you ensure that a person who has had a fracture, they've had surgery, they undergo physiotherapy, then also ensure that this person also gets continued care at the community through rehabilitation. Now, beyond the health systems, we must also be deliberate about promoting mental health within our communities. And that is beyond even our hospitals. And we go to the schools, we go to the workforce, we go to the criminal justice system, social protection. Every place has a role to play to ensuring that we promote mental wellness. When I was driving in here, I saw a sign saying Wellness Center. And I asked myself, is that wellness center for staff or is for everybody? Because some hospitals, some institutions are very deliberate on also promoting the well-being of their staff. So it's also imperative that workplaces are deliberate about promoting mental wellness of their workers. You spend most of your time in the workplace. 8 hours of your day you spend here. Yeah? So most of your lifetime will be spent in the workplaces. Our children spend most of their times in schools. So promoting mental well-being in schools, in the workplaces, and other spaces to ensure that the whole society is taken care of. So integration matters because, number one, when you integrate mental health into all the systems, we'll reduce stigma. When you normalize talking about mental health, and this person is not always being sent to the psychiatrist, to the psychologist, but their surgeon is asking them about their mental well-being. Their gynecologist is asking about their mental well-being. Their physician is asking them about their mental well-being. Then it becomes something that is not feared. It is something that is actually promoted, and people feel free to talk about mental health. It becomes part of routine care. The other thing is that if we do integrate, now we have a whole person care. Health is defined as the state of physical, mental, and social well-being. If you're taking care of the physical aspect of your patient, you cannot tell somebody, I'm going to give you a wheelchair because now you're not able to walk. And then you don't care about their social environment. Maybe they live on the 6th floor of a building that has no lift. Have you taken care of their social well-being in providing for them health? Have you? Yes or no? You have not factored that in. So the same way, you must also factor in their mental well-being. So when you look at a person as a whole, then that helps in ensuring integrated care. Then, of course, it improves outcome. Your patients will refuse to take medication, no matter how good it is for their other physical conditions, if they are struggling mentally. So the outcomes will be poor. We've seen people who have been doing very well on ART for HIV, but then suddenly their viral load rises, and it's because they've stopped taking their medication because of certain stressor they are facing in their life. And maybe they've started using drugs or alcohol to cope with that stressor. So better outcomes improves adherence and reduces complication. It's also cost effective. It is actually cheaper to have the physician know that this is an anxiety disorder and I can manage it. Unless it's very severe, then I need to refer to a psychiatrist. All right? Sort of a one-stop model. Then increases access. Services are closer to the people. If that woman in the village who is going for antenatal care is able to go and see their, during the antenatal care, they will be seen by the nurse, they'll be assessed, and they'll be talked about their whatever they are facing in terms of their stress or depression. It is easier for them to access care other than being told, oh, now, since you're talking about feeling depressed, you'll have to wait until I book you an appointment with a psychiatrist who is hundreds of miles away. So if we integrate, we increase access. So at the Ministry of Health, we are deliberate about integration. And if you look at our Mental Health Act of 2022, we have actually talked more of increasing integration of mental health into primary health care and not focusing on specialized hospitals alone, and even moving away from institutionalization. Then our primary health care reforms as a ministry show that primary health care should be the entry point for care for all health conditions. We are rolling out the MHCAP, as I said, to train primary health care workers to be able to manage common mental disorders. We have developed and have disseminated the national guidelines on workplace mental wellness. We are embracing digital health, and we have also improved our data collection mechanism in KHIS. If you go to Mathare now, and I hope that I'm speaking the truth, Dr. Njuguna and Dr. Tahir, that we are soon going to have a state-of-the-art telemental health center which will improve access. In SHA, there is actually a mental health benefits package that is aligned to UHC. I know it may not be the best, but it is a step in the right direction, and we are pushing for it to be improved. And we've developed also national clinical guidelines for management of common mental health disorders that are really accessible to all healthcare workers, and are a quick reference on how to manage mental health conditions that are common in our society. Then, of course, we are also training the CHPs and on how to screen and refer common mental health conditions. And as we speak, we are completing our school mental health guidelines, which we hope to roll out soon, to be able to also ensure our learners are well taken care of. So our journey is from policy to intent to routine, and to ensuring that there is reliable and accessible services for everyone. So what we must do is embed mental health into primary health care, strengthen the workforce, build referral and follow-up, and use data for decisions. In fact, I want to challenge the researchers who are here, the scientists, that give us more data on how do we improve our healthcare systems in mental health? How do we improve financing? How do we do effective integration that is aligned with our systems here in Kenya? So at the end of the day, mental health is central to UHC, and therefore our task is to build integrated, inclusive, and resilient systems that promote well-being, prevent illness, provide timely care, and support recovery. And that will be mental health care without gaps. Thank you very much.
Thank you so much, Dr. Hari. Amazing presentation. For those who have just joined or have been walking in, this was the first speaker and presentation of the day. This is Dr. Karanja. She's from the division. She's the head of the Division of Mental Health and a consultant psychiatrist as well. So, first of all, welcome everyone. To those who are late. I know in my school days we used to call this weather together. We appreciate all the presenters today. We also appreciate all those who are attending, because to overcome weather together, we early morning, and then to be here to seek knowledge, it's amazing. So asanteni sana for attending this, and as we move on to the next speaker, we have Dr. Janet Muia. Dr. Janet Muia is a consultant psychiatrist with over 6 years of experience in providing comprehensive, evidence-based, and patient-centered care to patients of all ages. She currently heads the mental health unit at Kenyatta University Teaching Referral and Research Hospital, with a commitment to deliver holistic care through multidisciplinary collaborations. She has a keen professional interest in neuropsychiatry and child and adolescent psychiatry. As a mental health advocate, she is passionate about reducing stigma, promoting mental health awareness, advancing research, and strengthening mental health services within the hospital and community. Beyond her professional work, Dr. Muia enjoys mentoring the youth with a personal vision of changing the future of the world one mind at a time. Dr. Muia, we welcome you here, but I'll tell you something. She left me alone on the stage. She was supposed to co-chair with me. I felt very, very alone on this stage, eh? Tafadhali, don't do that.
Okay. Pole Daktari, let me apologize in the presence of witnesses. I hope you found my presentation. So essentially, what we are seeking to do is to build on what Dr. Karanja talked about and to give evidence on the ground on how we are able to integrate mental health into the health system and into the hospital to make a difference directly to the patients. At the end of the discussion, the presenters on the sub-theme of mental health will welcome questions. So if you have questions, you can write them down and we'll get to ask after all the presentations have happened. So I will make a presentation or a discussion on a holistic brain and mind care model, which is integrating neurology and psychiatry. This is something we've been able to implement in the hospital. Dr. Karanja talked into policy and guidelines. So essentially, you will hear a lot of integration of mental health into the health systems. So this forms the basis of the concept that we've been able to implement in this hospital. The Constitution of Kenya 2010, the Article 43 talks into every Kenyan has a right to the highest attainable standard of care. So this is what we are seeking to achieve for the patients who get to be seen here, and we are hoping this concept can be replicated in the various facilities. When you look at the various documents that the Ministry of Health and the Division of Mental Health have been able to put as guidelines for us, the Kenya Mental Health Policy 2014-2030, the Kenya Mental Health Policy, also the Mental Health Act, they all speak into integration of mental health into the primary health care and also into the national health systems. So this is something we are seeking to achieve and implement. And then they are also very big on multidisciplinary collaborative care that allows the various medical disciplines and specialties to work together in a collaborative aspect of it. Mental Health Action Plan actually specifically says a comprehensive and integrated and a responsive mental health care. And this also strengthens the referral system, because once you're integrated, it's easy to have a smooth referral of patients to each other. And essentially, patient-centered care is able to improve the quality of life and reduce the disability that might be experienced. Universal health reforms are very big on patient-centered care, where there's an emphasis on putting the patient at the center of care rather than putting the disease at the center of care. So when you do this, you improve the quality of care that is given to the patients. Go back to why we are integrating neurology and mental health. So what's the burden of mental health disorders? What's the burden of neurological disorder? To make us understand why this concept will make a difference to the population. So the neurological and mental health disorders account for more than 10% of the global burden of diseases. This is globally. This gives us a picture why this is such a huge or a key mental health challenge or concern. Looking into the data from the World Health Organization in 2021 gives about 3.4 billion individuals living with neurological disorders and about 1.2 billion people living with mental illness. That gives the strength and the burden that people globally are dealing with. When we go down to practically, what's the burden of disease when we use the Daly years? For neurological disorders, it's about 18%. And for mental health disorder, it's 10 to 12%. That tells you why this will make a difference, and it's very key. We come back to Kenya. What's the burden of neurological disorders? What's the burden of mental health disorders? Mental health disorders, neurological and substance use disorders account for 16% of the burden of disease in the country, in Kenya. And out of this, 11% can be contributed by the neurological disorders. And building on the data, Dr. Karanja alluded that we are likely to all say this, because we need to accept and agree that mental health is a major public health concern. And when you look at the data, this is a study that was done in a general hospital, not in a psychiatric facility. And these patients hadn't come to hospital due to mental health care. They had come for other reasons. So out of that, 25% of the patients in outpatient were found to have a mental illness. Key to note is they didn't come to hospital because of the mental illness. They came for other reasons. That gives us a 1 to 4. That always is a big data. And 40% of the ones in the wards for other reasons, surgical and medical reasons, that is 2 to 5 were found to have mental illness. That tells us there is a lot of undiagnosed mental illness, and one way of being able to identify early is when mental health is integrated into the other disciplines, so that we are able, one, to screen and elicit mental illnesses early. So the concept of the brain and mind center is an integrated, holistic patient care model, which was initially started from the University of Sydney. Initially, they had a research institute encompassing the neurologist and the mental health team, and it was named as this concept in 2015. In the country, one of the hospitals that has been able to integrate mental health and neurology is the Aga Khan Hospital. They have a center of excellence in the Brain and Mind Institute. So it brings in together these aspects together. So why is it important for us to have a neurological and a mental health institute? You'll realize there's quite a lot of intersect, and you realize it's not possible to separate the two disciplines. One, we are dealing with the same organ. We are dealing with the brain. So when there is any issues in that organ, it will present in either the two aspects. And then we also have shared brain pathology. When you look at the pathophysiology of neurological disorders and psychiatric disorder, you'll realize there is quite an intersect. When we talk of neurodegeneration, that is the progressive decrease in the structure of the brain, it will occur in the neurological disorders like Parkinson's, Huntington's, and the Alzheimer's. But we also see the same in schizophrenia. And you'll notice these conditions have an overlap even in the presentation. So it's hard to have a clear line of this is neurological, this is mental health. When you go down into the neuroinflammatory, the increase of the inflammatory cytokines, it occurs on both sides of the divide. And then we also have neurotransmitters. We share the same organ, we share the same neurotransmitters. We see a change or a dysfunction in dopamine in the Parkinson's patient. And it's still the same concept in the psychotic disorders for mental illness, given the basis why most of our medication deal with the same neurotransmitters or target the same neurotransmitters. When you look at a change or a dysfunction in GABA, it will present in anxiety, but it will also be the same in the neurological disorders like in epilepsy. There will be an imbalance in GABA. And then there is quite an overlap in comorbidity of the neurological disorders and in the comorbid mental health presentation. And then, like I said, there's an overlap in the clinical presentation, and also there's shared genetic factors for the neurological disorders and the psychiatric disorder. You'll find part of the cause of mental illness, part of the cause of neurological disorder is a history, a genetic aspect, linking the individual and predisposing the individual to either of these conditions. And both neurological and psychiatric or mental health disorder approach disease using the biopsychosocial model of disease. So where biological factors, like I said, there's genetics in both aspects. There's change in the brain pathology in both aspects. And then also the psychological factors, the change in the psychological issues, the thought process, the coping, the trauma, cuts across on both sides. In the social aspect, they touch on the family, they touch on the culture, they touch on the environment. So that is why it is not possible to put a definite divide between the neurological disorders and the mental health disorders. So, like I said, the psychiatric department has been able to merge with the neurology department. So we run our brain and mind center where we are all in one space. So to answer Dr. Karanja's question, no, we are not near the morgue. We are in the main hospital building, right at the entrance. When you walk straight in, you will end up at the Brain and Mind Center. So it's a place where we are running both clinics at the same place. All patients are seen in the same place. So we are seeking to provide an holistic patient-centered care. We are providing early detection. So on Mondays, we run the epilepsy clinic, that is the neurologist, but the psychiatric nurse is able to screen all patients who've come for treatment for epilepsy, for mental illness. We know in epilepsy, mental illness can be found. So we do a screening tool using the PHQ-9, and we are able to detect if an individual has mental illness, and they're able to be referred to the mental health side to get care. Also, we are able to talk to the caregivers, because you find chronic illnesses, people who are unseen are the people taking care of the patients. So even patients or caregivers of patients with epilepsy get to be screened, and we're able to pick and offer the necessary care for them. So this concept is bringing early detection for comorbid mental illness for the patients who are coming for the neurological disorders. And you can tell we are working as a team. The neurotechnician, the neurologist, and the psychiatrist, the psychologist, to be able to provide the highest quality of care to the patients who walk to our facility. This gives continuity of care and follow-up for the patients we get to see. And we seek to have family and community engagement. This year, during the World Epilepsy Day, we were able to bring in the families of individuals who have lived with epilepsy, and both the psychiatric and the neurology team was able to have a session with them and create awareness of both epilepsy and mental illness. And we are hoping to do this even beyond the walls of the hospital to the community, so that it makes an impact and a difference to the community. So that's how the setup is. You're welcome to walk in and see. So we run an epilepsy clinic, we run a psychiatric clinic, we have the neurology clinic, and then we have the psychologist running the psychotherapy sessions for the patients. And then we have a neurotechnician who's able to do the diagnostic investigation. So for now, we are able to do the EEGs that allow us to monitor the brain activity, and we are able to make diagnosis of patients with epilepsy. And EMG, which checks on the health of the muscles, and the nerve conduction studies are also being able to be done. These two allow us to make diagnosis of the neuromuscular disorders. So the clinic setup has all those services under one roof, one corridor. So this is the team that is is the multidisciplinary team that is involved in the Brain and Mind Center at the hospital. We have the psychiatrists, the neurologists, the psychiatry nurses and the neurology nurses. We have the neurotechnician. We are hoping to get a speech therapist, especially to help with the patients with CVA and also with the children with neurodevelopmental disorders like autism spectrum disorders. But in the hospital, we have an able team of the occupational therapists who we are able to send to. We are not in the same department, but they're on the first floor. So they really help us with the patients, especially the children with the neurodevelopmental disorders and also the patients who've experienced stroke, and they're able to rehabilitate them well. We also work in collaboration with the social work department, with the pharmacy, and in the community health workers. So you see this model will brings in a collaboration of various disciplines so that each has an input to the patient care, and the outcome definitely for the patients become much better. I'll walk us through the journey. We've been able to run this clinic for about 8 months. So I'll give us real life examples of the patients we've been able to see and we've been able to make a difference. So the first patient is a young man who is 15 years old, who had been admitted in the hospital late 2025, around October. He had come in with a history of convulsion, was investigated. We couldn't find the reason of the convulsion. It was a one-off convulsion. Then was, at the time, he was noted to have auditory hallucinations. So we had started him on treatment, and was also, the convulsions were also treated by the neurologist, but sent home to both clinics. So when he came in, he happened to come in when we were starting the EEG services. So after I reviewed him, the auditory hallucinations seemed to have been persistent, and they seemed to be the main complaints, with no convulsion even after discharge. So the EEG was starting on that day. So he was able to have the EEG done, and we detected that, yes, there was abnormal brain activity. He was lucky enough, the neurologist was also present, so was able to interpret and give him a holistic care, same day, same place. So of course it doesn't happen like that all through, but the patients are able to be get the service in one stop, and the boy right now, he's well controlled. Both the epilepsy and the psychotic aspect is well controlled, is in grade 9 and has been stable for the period. Another example of a patient, there's a 63-year-old man who was in public service, a teacher, doing very well, was good in public speaking. Then was referred to us from a peripheral facility where he had been diagnosed with schizophrenia, because he had this perceptual disturbance, he had this cognitive decline, he had become a shadow of the person he was. So he was sent to the psychiatric unit. And knowing the natural history of schizophrenia, one, it doesn't progress that fast. In 3 years, he had lost speech, he had slurred speech, his judgment was completely impaired. And from the history, you'd have assumed this is someone who's lived all his life with schizophrenia. But when I asked, it was a 2-3 year history, which didn't make sense. So schizophrenia alone can't explain that progression for this patient. And then on further review, I noticed he had bradykinesia, he had this slowing, the gait had changed, he's stooping. So I was like, this is likely neurological with a secondary presentation of psychiatry. So I was able to be seen by the neurologist, and a diagnosis of Parkinson's was made. So, and was started on treatment, and the cognitive aspect now started improving. So had we not seen him from all those aspects, he would have stayed for so long with a diagnosis of schizophrenia alone, yet that wasn't his primary issue. So that made a difference by looking at him from all the angles. Then we also see a lot of patients with brain tumors. One of the patients who come to mind, we've had a 25-year-old patient, male, who had been managed for major depressive disorder without much improvement. So he was sent to us so that he can get comprehensive care. And at the point when he came in from casualty, all the investigations were done. And when an MRI of the brain was done, it was picked that he had a pineal gland tumor. So why the diagnosis of major depression that had been persistent is in pineal gland tumor, there is severe disruption in sleep, there is disruption in mood patterns, especially depressive episodes. So when you screen him without investigation, you can easily say this is major depressive disorder. But when he was looked at comprehensively, we were able to pick this brain tumor is the reason that he has this main psychiatric presentation, the depression. He also had psychotic features that were majorly a paranoid delusion and also the visual impairment due to the point where the tumor was located. So he's a patient we've been able to follow up. The neurosurgeon also got to see him, and he's now had his surgery, and the neurologist also see him. So this brings into picture, at times, we can easily assume a presentation is purely neurological or it's purely psychiatric, but the primary reason is something else. So when we are able to integrate care and look at a patient with multiple discipline, we are able to pick the right diagnosis and provide the right care for the patients. We see a lot of patients with dementia, with traumatic brain injuries and stroke, and they have psychotic features, the mood symptoms, the anxieties, the depression. So we are able to provide care using the various discipline, and we get a better outcome of disease. So what we are getting as benefits to the patients is, one, the early intervention, which stems from the early diagnosis. We are also getting improved access, because if a patient is able to be seen by the psychiatrist, by the neurologist, get their EEG and EMG done from one place, it's much better than when you're being sent to various places and you give up along the way. We have to admit, there is stigma against towards mental health. When someone is told to go to the psychiatric facility, you're hesitant. But now when we are seeing all these patients, the neurological patients, the mental health patients who are purely seeking diagnostic care, we are finding they are more receptive. I know of a patient who had been sent to me by the cardiologist and took 1 year to come to me. And when she finally came, she was like, I couldn't fathom being sent to a psychiatrist. Until when things were so thick, that's when they came to me. And when they found you and me waiting out the waiting bay, their perception changed, because she thought she'd find quite a different audience waiting to see me. But from that, she was able to say, I will follow up on care. And that individual stigma was reduced because of that concept. And then the enhanced continuity of care and better outcomes to patients. For the health system, we are able to improve the coordinated patient care. This increases efficiency and cost effectiveness. There is also collaboration in the management of complex patients. We hold MDTs with the physician and the other departments, so that we are able to have the various input on this patient, both who are outpatient and also inpatient. Again, stigma reduction, which is very key. Universal health care, which is very key on patient-centered care, which is what we are seeking or are doing with this model. And then this is such a huge base for research for both neurological and psychiatry. And we are hoping to build into the data of mental illness and also neurological disorder. And it will enhance training and education for both spheres. So in conclusion, the future of brain health is in the integration of neurology, psychiatry, psychology, and neuroscience. And the brain and the mind are inseparable. So patient care should reflect this concept. And there is no psychiatry without neurology. Same way, there is no neurology without psychiatry. And patient-centered multidisciplinary care improves outcomes, the quality of life, and the health system efficiency. I'll dare to say that there is no health without brain and mental health. Thank you.
Thank you so much, Dr. There. Thank you so much, Dr. Muya. I think an amazing presentation. Just a small recap. I think it is important that as we moderate, we have a small recap on the presentation so that whoever is coming in late or not, they can at least catch the major points. So I'll just do a very 2-point recap of what Dr. Karan just said. And I think what I picked up was integration is key, and also the elements of the figures that she pointed out. 85% of people who need care are not receiving care, and one in every four patients who come to the hospital tend to have a mental, I'm not going to say a mental disorder, but they have symptoms of a mental disorder. Can be depression, can be anxiety. So those are very important points to take home, that one in every four is going to go through this, and 85% are unable to get care. So how do we bridge the gap? And that is what the whole point of integration is, which has been very efficiently and very well portrayed by Dr. Janet Muya in terms of the brain and mind, and what the brain and mind concept and what they do at Kenyatta, at KUTRRH, right? Yes, KUTRRH. So amazing work. We really appreciate this. I think this is brilliant. A sidebar, we used to go to conferences. We used to sit at the back. Uko mwisho. The reason is, unaangalia, kama uko home party, unaangalia which nice ladies have come away. Unaweza kutupa line towards the tea time and that. And we're approaching that time, so whoever has come for that. Sidebar. Also, I think it's nice seeing people coming in and enjoying this in terms of education, and there's a lot of knowledge to gain. Also, a sidebar. Dr. Karanja had said that we have psychiatric facilities in near mortuaries. Yeah. Do you know why, Doc? So it's planned. The mortuaries is where people have passed away. They're closest to God. Psychiatric facilities, hapo ndio tunaombewa. The aim is, ukiombewa, you're closest to God. The distance is reduced. The prayers will be answered. People will be healed. The next speaker today is he's a personal mentor. He's someone I look up to very much. He goes by the name of Dr. Simon Njuguna. He's a distinguished psychiatrist, a leader dedicated to advancing mental health care in Kenya. He currently leads the School of Mental Health and Research at Mathare National Teaching and Referral Hospital with a mission to deliver innovative training and cutting-edge research in mental health. He also has a keen interest in developing client-centered and impactful child and adolescent mental health services. A strong advocate for clinical governance and human rights, he is committed to translating policy into tangible actions that strengthen health systems. Beyond his professional work, Dr. Njuguna enjoys reading widely on science, technology, history, and culture, and maintains balance through passion for sports and music. He deeply values family time and community engagement. Ladies and gentlemen, Dr. Simon Njuguna.
So, good morning, ladies and gentlemen. Yeah, so today I'm here to talk about integration of mental health care. But before I start my presentation, I'd like to appreciate Kenyatta University Teaching, Referral and Research Hospital for organizing this event, and also for inviting me and my colleagues and having this session on mental health. I think we need to clap for the organizing team. So I've also looked at the theme. You know, whenever you're organizing an event like this, a theme is something the team really sit down and think, rethink, that actually they get something which really fits and carries the entire team, because we are here to share. People who are working in different areas, in medicine, in research, in teaching, and to inform something which will make this institution grow. So they said care without gaps. Very simple. Again, also you have to choose a theme which is catching, you know. Care without gaps. So they are just trying to make sure that we have continuity in care. So for us to achieve what we are calling universal health coverage, then we must have care without gaps. That's not my presentation. I think I've talked about this and someone have assumed that's my presentation. So universal health coverage, as I have said, I know it's something we have been talking for almost the last 10 years. And there are key words whenever we talk of universality. That you need health to be universal. So you need the coverage in terms of healthcare to be universal. And so we always ask ourselves this question, how can you make it universal? That everyone gets the care. And not only just care, is care without gaps, is care which is quality. And we know when we talk about health systems, and I know most of you are aware of those health systems have gaps in HR, in finance, in infrastructure, in service delivery. So we must be very innovative in a way. So I'm imagining the team which is working around this conference is trying to see then how can we, despite all these, and I don't think there's any time we'll ever say that we will not have gaps. However much we keep on bridging the gaps, we'll always have gaps. Then the question is, there must be something else we need to do to ensure we move smoother, and I think that's why we are talking about this integration. Probably that is the innovation. So one of the areas, like what my colleague have just talked to Dr. Janet, is around integration, how they're integrating neurology and psychiatry. And I like to say that in the early days, the people who started in medicine people would go to certain centers, work with mentors, you have apprenticeships. You'd have doctors who are all around. I was surprised to tell you Sigmund Freud, who came up with the psychoanalysis, and he created these many centers on psychoanalysis across the world. It's like the father of psychology was a neurologist. You'll find doctors who were also conducting postmortems. They would treat their patients, and if their patients were to succumb, they would go ahead and even do the dissections. And you look at people like Karl Wernicke. He was a physician, but he was also a guy who was interested in neuropathology. So he did not only treat the patient. And so he would have this series of patients, and then he would see what actually caused the death. So and by doing this, they contributed so much to the science. So I've been asked today to talk about reimagining holistic health system for universal health coverage. So when I was sent this program by Dr. Janet, with this big word, reimagining, I tried to ask myself, what is this reimagining? And as psychiatrists, we do study a lot around thinking. I realized imagining is an aspect of thinking. And we take our time to read around science and psychopathology of thinking. That's why we talk around, we see some of our patients who will have issues around delusions. These are abnormal beliefs. And I know naturally, most of the time, we don't take seriously that when you are seated there, you are seeing, you are hearing, you are thinking, you are interpreting what is all that. That's your brain. That's your brain at work. And it's working to ensure even what you had for breakfast is being taken through the process. So the brain is the core of a human being. And that's why I said even the science of thinking. Whether you are thinking in terms of, as we say, strategic thinking, critical thinking, imaginative thinking, you talk of fantasizing. It's all about networks within your brain. I like saying when you think about the brain, think about what can come close to a brain in today's world with technology is a computer. The very advanced computers. And now we are going to an era where we'll start having what we are calling brain-computer interfaces. Where we are calling them BCIs, brain-computer interfaces. This is where the people in the technology world, they are moving more forward than us, trying to understand how the brain works and putting the same in a machine, what we call a computer. And that's why you are finding right now when we are talking about artificial intelligence and machine learning, there are people who are trying to understand the networking in the brain and trying. But they still can't get to where the brain is. Because we are talking about imagining. There are millions of networks. So now, what is reimagining? And then I went further to understand what is reimagining. Because first, what is imagining? You know, we always talk, you say, imagine. Are you imagining? Eh? We are in KU. Eh? We are having this conference. Now, what is reimagining? Reimagining is where you think of something which already exists. That's why the word re. That's why there is a prefix re. And think, how can you make it better? So what I've been asked by the organizing team when they asked me to have this topic, and I don't know where it has disappeared to, is to rethink how can we recreate a scenario where a holistic health system can be redone to ensure that there is universality of mental health care. There's a system. So let's go to the next slide. So, no, we are moving quite fast, my friend. So I hope you can see this. So I thought I would talk of only one model, what is called collaborative care model. And I will explain why this model. This is not our model. It's a copyright of the University of Washington, but it's universally available for people to work on it. I will ask why that model, and how can we adapt it as we are reimagining on what we can do about collaborative care in this country. So the next slide. So there is a collaborative care model. I got to know about it some time back. We had a bit of collaboration with the University of Washington. I know most of you have worked probably in various programs with the university. They are doing mental health work, child health, a lot of research work. And it's an integrated model which has been specifically used to treat mental health conditions. And it has been tested. They have conducted very many trials to try and see how it's work, not only in the University of Washington, but also in other places. And so what they have done, they have tried to, when they are doing one of their major trials is what is called the impact trial or the impact study. The impact study, which normally stands for improving mood and promoting collaborative care treatment. You can see there's a lot of publications around that. And their aim is to see, they try it in different scenario. They try it with a different age cohort. They try it in different care setting. They try it in with different mental conditions. And majority of the time, they have shown better results. And so most of the states in the USA and even other parts of the world are adapting it. So what are the components of this model? This model normally has 4 components. There's a trained primary care provider. Someone probably in US will be their GP in their system, will be a general practitioner. So this is a person who is running clinics, is treating all kinds of conditions. And the second player is the person they call behavioral care manager. This is a person who coordinates the orchestra around this model. Most of the time in US, it will be a psychologist or a social worker. So this is a guy who is a case manager, if we want to call them, or a care manager. Let's not use the word case. Patients are not cases. So this is a person who coordinates everything. And the third player is a psychiatrist. So the whole essence of this is because there are fewer psychiatrists, and we are seeing this treatment gap, which is standing at 85%. That 85% of people in need don't get care because of various reasons, probably because of these gaps. We are saying care without gaps. So how can we reimagine that we have care without gaps? Probably this is a solution, and this is a tested model. So then they have what we call a registry. A registry is where all clients are recorded, and then they are tracked with specific indicators they are tracking. And then the care manager is the one between the primary care provider, the patient, and the psychiatrist. So it's a triangle. So once you have been seen, you came to hospital, you don't have to go to the primary care provider because you have a psychiatric problem. They do a lot of screening. Screening is part of the model. So you are seen, you went there, you had a cardiovascular issues, you had a gastroenterological issue, you had a surgical issues, you are screened, and you need mental health care. Then you get into the registry. Then the care manager is the one who is monitoring and is conducting meeting probably on a weekly basis, on fortnight, to review all the cases. They have now this multidisciplinary team meet, and they do use technology to see that they are meeting to see what is happening. So by doing so, they ensure that this model is patient-centered, is population-based. They're not just looking for the patient. They're just looking at the screening process, ensure it's population-based. They have embedded screening culture within their primary care setting. There is measurement being done, because once you get into the registry, they're using screening tool assessment tools, and they're putting goals. They would say, this person scored PHQ. This is PHQ, which is a measure for a screening tool for depression, 27. And 6 months down the line, they had PHQ4, or they had PHQ2, which indicates they are most doing well. So they will assess the quality of life. So they have actual tools to do measurements. So we are not just providing care as usual. You are also monitoring. And then it makes people accountable. Next slide. So using this model, it has made more people access care, despite of the gaps in resources. It has made outcomes better. You have seen 80 randomized control trials in various multi-sites. I think this is part of the IMPACT trial. There was significant reduction in symptoms in depression, anxiety, PTSD. And there are many studies which have been done around this. The stigma reduction, as Dr. Muya mentioned, because this is not someone seated there. This is someone who is a primary care provider. He is seeing all medical conditions. All patients are coming to them. Then they subject them to screening. And then those who are found to have a mental health problem, their issues are addressed. There's a human resource sharing, there is capacity building, and then there is leverage on technology. Because the psychiatrist may be seated here in KU, the primary care manager, we have different care managers, probably one in Kiambu, another one in Mulanga, who hold meeting on weekly basis with Dr. Janet on patients who are being managed in Mulanga. at the same time, they can organize training to the primary care providers who eventually, actually it improves confidence. Some of the studies done actually on the primary care providers, it showed that they were having more confidence. They felt even better and they were able to provide better care because they know there's someone behind at their back whom they can ask, who is mentoring them, who is supervising what they are doing. So they are not scared of making any mistakes because there's this backup around them. So let's go to the next slide. So I thought probably as we are imagining, probably this is the best way to reimagine. How can we have mental health, integration of mental health services in Kenya? This is an open source platform by what you call the University of Washington. They have a whole center dedicated to this called AIM Center. Is a center which they call Advancing Integration of Mental Health Solutions. It's an open source. You can work with them as a country. We can work as them as Kutrrh to implement this model and conduct research, conduct training around it. And so we just need to see. They also have an implementation gap which has 5 steps. The implementation guide normally talks about is URE foundation on how we need to go about this. This is setting the concept. This is getting the buy-in. Then after that is bringing the culture of change. You know, for us to reimagine, we must bring change. Creating the culture of change. We must tell people it's not treatment as usual. You know, when we are doing research, we always talk of, we compared treatment as usual and the intervention. And then after that is build skills. You know, that's build skills. So these primary care providers, you must train them on screening. You must train them on monitorings, coming up with indicators. Then we must invest in digital technology. Because you are talking of fast areas. You are talking of innovations to address the gaps, care without gaps. We want to remove gaps. And we are talking of a primary care provider who is seated in Washingizu, and you are here in Nairobi. But you need to take care of one patient. So technology, teleconsultation must be there. We must have dashboard, which everyone is seeing whatever is happening, wherever you are seated within the registry. Then we must ensure there is the essential health products, so that these medicines are available across board, so that even Dr. Muya suggests that this patient need to be put on a aripiprazole and is in somewhere in Bomet. Then they'll get that aripiprazole in Bomet. Whether it will be taken from here by courier or we make it's available in Bomet. So someone has gotten the service of Dr. Muya, where Dr. Muya is seated here at Kutrrh, and they are in Bomet with a clinical officer in Bomet. Then we must ensure there is healthcare financing. There is money for everything. We said one of the elements of UHC is removing catastrophic financial burden to patients and their family members. So we must ensure that all these things is covered by a system. And for us to achieve this, we must ensure we get the buy-in from all stakeholders. We have the necessary framework to be able to carry out this. So for me, I think what you asked me is how can we reimagine the coming up with a holistic system for universal health coverage is having collaborative care model. And one of the best collaborative care model available is what has been developed by the University of Washington. It's an open source. It means it's available for use by other people, has been tested, and that's the best way we can imagine giving holistic solutions to universal health coverage. Thank you.
Thank you so much, Dr. Njuguna. I think it's very important for us to appreciate him as for me, I appreciate him as a mentor, but for his service and to the mental health of Kenya in different capacities, and also to his knowledge that he has in terms of policy and implementation. So asante sana daktari. Going forward, we're going to change our schedule slightly. We're supposed to go for a tea break, but that's going to wait for one more presentation, and then we can go and interact at tea time. We're going to have the presentation by Professor Paul Odula. Professor Paul Odula, I'm going to smile because when going through his bio, he's an associate professor of human anatomy at University of Nairobi. Human anatomy was one of the scariest subjects in whoever has gone to University of Nairobi knows how anatomy was. So associate professor of human anatomy at the University of Nairobi and consultant general and a laparoscopic surgeon with more than 30 years of combined clinical, academic and teaching experience across 4 medical schools in 3 African countries, founding chair of the Faculty of Health Science, University of Nairobi Quality Assurance Committee. He's the immediate past president of the Surgical Society of Kenya, a fellow of the College of Surgeons of East, Central and Southern Africa, COSEXA. He's a fellow of the American College of Surgeons and a founder of chairs of Surgical Society of Kenya in February 2024. He provided national leadership in surgical policy as support team lead on the steering committee of the Ministry of Health Technical Working Group that developed and successfully delivered Kenya's first National Surgical Service Strategic Plan in April 2026. He's an author of more than 60 peer-reviewed publications. He's also successfully supervised 3 PhD candidates and 16 MMed MSc theses to completion. He secured more than $75,000 in strategic training and equipment partnership for the Nairobi Surgical Skills Center in 2024, following appointment as Strategic Program Area Lead of Human Anatomy, Department of Human Anatomy and Medical Physiology in 2023. He serves at the Proximi Global Health Steering Committee, the MOH Technical Working Group on Violence and Injury Prevention, and the MOH Technical Working Groups that developed and currently drafting the National Surgical Service Guidelines. Professor Paul Odula, the stage is yours. Asante sana.
Good morning. All right. Good morning once again. I saw Dr. Karanja struggling with this, so I just want to make sure it's working. Great. It's nice to be here. Thank you very much for inviting me to this conference, Dr. Abeid, and thank you for organizing this important conference. This is my second time here. The last time I was here, I was actually at that time the president of the Surgical Society of Kenya, and he did a small presentation. The difference between that time and this time is that Dr. Abeid took time to get someone to show me around the whole place, and I must say, the place is massive, and it's incredible what's happening here in Nairobi, and you guys are doing a great job, the management, administration, the staff. Before I go to this bit, fine, I'm a surgeon, a general surgeon. I'm also an anatomist, so I do both. I also do a lot of research. I'm also in the industry practicing surgery. I saw this beautiful presentation by Dr. Muya on integration, holistic, one spot, neurology, psychology, and then I noticed something was missing. And then once in a while, she threw this patient to the neurosurgeon. I'm like, okay, where's the neurosurgeon in all this? That's on a light note. I'm sure they're not easy to get anyway, but yeah. I think once in a while, she tell him to come once in a week just to see what you guys are doing. So, what is this all about? It's all about care without gaps. And okay, it's the other way. Great. So we all know that surgery is essential. It's not optional. Surgery is essential, and that about a third of all global disease burden is treatable by surgery. A third, 33%. It's a population pillar, not a niche specialty. We also know that in many low and middle income countries, deaths from surgical treatable diseases exceed the three combined: HIV, TB, and malaria. However, reality on the ground is different. When you go to MOH, and Dr. Aria can confirm, they have silos. They work, this is the HIV program, this for malaria. There's a lot of money being pumped into all sorts of NCDs, etc., or communicable diseases. But there was nothing surgical really. There was maternal health, yeah. Now we're in PPH. But I came to realize when I became the president of SSK that there was nothing quite surgical as a unit. In fact, if you asked, when I went to meet Shah, I asked them, how are you guys able to come up with all these charges? Where did you get all these things you're talking about? They said, we asked MOH, they said, they don't know, so they sent us to KNH and NHIF, and we know what NHIF was, and that's what they just implemented. Yet, virtually every specialty somewhere, surgery is needed somehow. And Treasury do not know surgeons. They're like, who are those guys? We know malaria, yeah, we know TB. There's no vote for surgery. So I said, okay, let me go to KEMSA. What drugs do you have here? Do you have surgical consumables? They're like, what's that? Don't know what you're talking about. This was 2024. So I'm like, okay, there's a problem. We need everyone to realize that surgery, and then I also remember when we were launching this, the PS came on board and said, surgeons, you're the ones who take all the SHA money. It was an accusation. Because the fact of the matter is surgery is expensive. It costs. So you need to look at it and see how best is going to serve the population. It's not just one of those things you push under the rug. Because when you fall sick and you need surgery, that's when you realize that you need to not push it under the rug, but take it seriously. You're playing hide and seek here. So fine. The Kenyan reality is that 70% of Kenyans lack access to safe and timely and affordable surgical care. We also know that the National Strategic Surgical Program providers are very few per 100,000. There are about 3.8 surgical providers per 100,000. Okay. And about 2,000 specialists per 100,000. Against a recommended, when you're talking about providers, you need at least 20 to 40 per 100,000. We also know that there are differences in surgical workforce between counties, and this varies up to 7 times. Access depends on where you live. In the recently launched national commitment, this was on the 24th of April this year, Kenya's first national surgical strategic plan was launched. This is a bold, costed roadmap for universal health coverage. It was launched on the 24th of April at the 26th Surgical Society of Kenya Annual Scientific Conference at Mombasa. And it's supposed to span a time period of 2026 till 2031. A 5-year costed implementation roadmap, which is going to have a total investment of 33.7 billion shillings over 5 years, financed within Kenya's universal healthcare coverage reforms. So, what is the plan and why now? We know that globally, if you remember the WHO 68.15, emergency and essential surgery as part of UHC is part of the national, global, and SOP movement. Nationally, we know the Vision 2030 is a Kenya Health Policy 2014 to 2030, which pushes for sustainable development goals, the UHC agenda. The plan is to operationalize it. This surgical plan is these commitments into a costed and county level action. So where's the North Star? What is the plan and why now? We want a Kenya free from the burden of surgical conditions. We want the mission is to provide the highest accessible, affordable, and attainable quality of surgical service to Kenya in a responsive manner. Why? Because everybody needs an affordable, accessible, safe, timely, and standardized surgical services at all levels in line with UHC. And this must be built by the surgical community for Kenya. The participatory process is this national stakeholders workshop, which we had at Pride in Machakos in June 2024, where we got all partners on board. And this, we're talking about the partners involved in the surgical ecosystem. We had Ministry of Health, we had representatives from public, private, and faith-based hospitals. County government sent their representative. We had WHO, health economists, pathology and forensics, clinical clinicians, Operations Smile Train, Nursing Council, KMA. All these guys came together to see what we can do in trying to get this thing moving. If you can see at the top in the yellow, there's something represent from CCSS. So who are the members of CCSS? CCSS stands for the Council of Chiefs of Surgical Societies of Kenya. At one time, we had a small issue which came up in February. The Kenya Medical Practitioners Dentists Council posted something which sort of like caused a bit of discomfort in the surgical world. At that time, I was the president of SSK, and my executive said, "Hey, boss, here, you need to call for a town hall meeting. There's a problem. We are not speaking the same language as KMPDC and maybe even MOH." So I said, okay, fine. This was a Friday. I said, on Monday, let's have a town hall meeting virtually and for the surgeons, SSK. I thought I'd meet 30, 40 people. And when I logged in, I saw numbers swelling. Within 10 minutes, 300, 400 people are like, who are these guys? What are they doing here? And yeah, it wasn't just SSK. All the specialties, gynecologists, they all jumped to board and said, want to hear what you're going to do. What are you going to do about this story? So like, okay, we can't speak with 300 people online. Let's tell your chiefs. Each of you have an association. We come together. I'll host them for some chai at SSK offices in Menelik, and we can see what we can do about it. And that's how CCSS was born. And I was appointed as a founding chair. It consists of all those associations: obstetrics, ophthalmology, ENT, cardiothoracic, maxillofacial, urology, neurology, orthopedics, pediatric surgery, plastics. And we had our first meeting. And it was quite interesting that we all agreed that it's high time as surgeons we should come together and speak as one voice. If we're going to move surgery forward, let them know that there's a voice here and you go and represent us in having those conversations. As soon as the meeting was over, I got a phone call from the chair of the Kenya Society of Anesthesiologists. He said, surgeons, we think you can operate without us. We need to be part of that group. So like, oh yeah, actually you have a point. So we included them into this group. And Those are the members of that group. You can see some of the chairs, the urologists, some of them have handed over. And we took a photo, a commemorative photo, just to remember our meeting. Ironically, within 24 hours, I got a phone call from MOH. Somebody told me, is that Dr. Paul Odula? Yeah. Can you come at 7:30 to my office at MOH? I'm like, so what has happened overnight? What are people saying? So when I arrived there, I was like curious. Why am I being called within 24 hours? I've hardly even settled in to know what we're going to do. And this was a call from the head of clinical services, Manasseh Boka. In attendance were people from Operation Smile. And the agenda was simple. How can I assist MOH in my capacity to reach out to all the surgeons to participate in the writing of National Surgical Strategic Plan, Services Strategic Plan? So what they're telling me in turn is that we've been thinking about this, but you guys are so fragmented, but finally you're speaking in one voice. I'm like, okay, then let's get this show going. So the idea was simple. Can we set up this NSSP developing it, and the national guidelines for NS surgical services, so that we can have a roadmap for the realization of these health policy goals with clear implementation, monitoring, and evaluation framework. While the guidelines would also stipulate what services and resources be available at each level of care. While we are having this conversation, then somebody mentioned on a light note that people have no clue how to set up a surgical unit. When the devolution came, people got money from healthcare. They said some counties even set up a theater with sofa sets where people can sit on them, because there were no guidelines from the MOH. This is how you're supposed to set this and that and the other. So we're like, okay, finally, we are here. Can we get these two documents going? Because these two documents will guide investment both at national and county government. We'd end up, sometimes you find people coming from abroad, like WHO, saying, want to pump money in your surgical ecosystem. And they say, we have Operation Smile, we have this. There's no document, but this would be something they can be told, here it is, look at it, and see how you can help us. It's also supposed to strengthen referral systems and inform healthcare financing models to be integrated in line with UHC. That was the first stakeholders meeting. We had it in Pride Inn. In there you have all those guys I mentioned, Smile Train, Operation Smile, anesthesiologists, urologists, etc. They're all there. The plan was, can we kick off starting the process of developing these two documents? First, get an outline how we're going to address this story, collect supporting policies and reference materials that will inform these two documents, discuss on the next steps, identify who the other key stakeholders are, and exploring other funding opportunities. So we ended up having a second stakeholders meeting in August 2024 in Naivasha, and there we managed to set up the timelines. August, we set another one for September, while we had a steering committee which was going to continuously review the progress. In October, we're supposed to compile those two documents, and then by end of October, have a validation meeting for internal and external stakeholders, so that in the first quarter of 2025, we launch these two documents. Yeah, that was the plan. But yes, towards the end of 2024, we had a few setbacks. A key member of the steering committee just retired. That's the person who gave me the phone call, and he was on driving the process. I think his idea was, can I at least put this in my bucket list by the time I leave? It didn't happen. The new person who took over suddenly realized the funds are dried up, and we had to look for funds. And this is some of the things we have to understand. Every now and again, you have an ambitious plan, and suddenly when funds dry up, everything gets slowed down a bit. So we had to think of plan B. One day I got a call, Operation Smile told me, hey, we're giving you a ticket in a week's time, come to Rwanda. There's a major conference taking place, the first Pan-African surgical conference. It has never happened, and it's going to happen here in Rwanda. I was wondering, why do they want me to give a talk there? Then it dawned upon me that the country directors of Operation Smile wanted me to meet the owners, the founders of Operation Smile and pitch. And they said they've tried that, but they realized that they were not making any progress. And that's how I ended up there. And after the presentation, I was taken to a room somewhere and actually met those who started Operation Smile. Very nice people. We talked and I pitched. And after a while, they looked at me and said, yeah, it's okay. Go ahead. We'll give you money. And I was excited because finally, I could give a report to all those surgeons, the Council of Chiefs of Surgical Society, and tell, hey, we have some money. We have a go ahead. And do I have your support? And they said, yeah, go ahead. We are happy to see the progress. And we finally had the internal validation meeting for this National Surgical Service Strategic Plan on the 16th of October 2025. Slightly behind schedule. 1 year, I think for some of these documents, is slightly behind schedule. We met at A&L Hotel in Machakos. And in December, we finally did the external validation meeting with, it was virtual. 2 further meetings. We got a consultant on board to edit the document. It costed us again a bit of money, but here we are. Eventually, we launched it successfully and delivered the document on the 24th of April this year. It was a very exciting moment, and it meant finally we have a document. So, if you look at the Kenya surgical systems at a glance, we have about 17,109 health facilities nationally. 42% are public, 50% private, and the remaining are 8%. It's arranged in levels, level 1 to 6, community primary care. The blue one is, the light blue is primary hospitals, then the deep one, county referral, before you reach national, like KTURH, KNH, MTRH, and now JTRH. What are we saying? There are 6 levels of care. The apex, which includes KUTRRH, carries the most complex care at a national level. But there are 5 chronic bottlenecks that we have. We all know this. We keep saying there's workforce shortage. Is that true? 4,000 doctors unemployed. Is that true? Yeah, it's not just workforce shortage. Maybe it's financing, isn't it? But anyway, there are 4,000 employed. To tell the truth, we have a lot of specialists. But the problem is they're badly maldistributed. You can go to Kiambu and have 20 surgeons and 2 theaters. While some places don't even have 1 surgeon. So it's just a maldistribution of the specialists. Supply chain delays, procurement, lead times take up to 8 months. I'm sure you guys see that here. Infrastructure gaps. 54% of public facilities, only 54% have electricity. The others don't. Fragmented data, disconnected health information system, and weak referrals. So, what is the evidence that told us this? The strength is definitely devolution, a dedicated workforce, and a strong training institutions like here. Weaknesses, we talked about the infrastructure, referral system, and data. Opportunities, UHC and SHA supposed to help us, and medical tourism has taken around and has told there was an attempt to have some medical tourism some time ago, and there's even space allocated for that. And there's aggressive marketing. But the story of why it hasn't picked up, I don't know. Maybe one of you will tell me over tea time. Because thousands of Kenyans go to India for medical tourism. This place was supposed to attract people from the region. Isn't it? So why aren't we doing that? At one of the big hospitals I work, Nairobi Hospital, I get people coming to see me from all over the region. As far as Zimbabwe, Rwanda, Congo. Because they're the Nairobi Hospital. But why can't they come here? What is it? I guess that's a conversation for another. So what are the threats? Yes, we're exporting labor, instability. Now we have an election coming here and people are like, okay, what's going to happen then? Inflation, disasters, fuel, the Hormuz Strait which was closed, etc., etc. What are the 5 strategic objectives that you're looking at? Leadership and governance. And these are embedded in the strategic plan. Leadership and governance. Number 2, surgical workforce. Number 3, infrastructure and equipment. Number 4, service deliveries. Number 5, health information and research. We need to have a dedicated budget. When we're talking about leadership and governance and coordination, we need to have a 5-year target dedicated surgical line budget in all 47 counties. Establish a national and county surgical coordination structures and units from level 4 to 6. Integrate surgical in all national disaster preparedness frameworks. There's recently some fracas about who the members of this disaster preparedness group are, but that's not a conversation for now. Integrate surgeons there. We also have to create a dedicated surgical budget line, like I told, raising this allocation from 10% towards 40% by 2030. We need a competent, well-distributed workforce. Competent and well-distributed workforce. And this needs assessment by cadre, level, and county. We need to recruit and deploy specialists to underserved counties. Enforce minimum staffing standards. Expand training. Like I hear COSEXA people are now coming around in Kutrrh. Fellowships. Institutionalize mentorship and continuous professional development nationwide. We know the role of Kutrrh is it's a national engine for training, mentorship, and skills transfer. So we need full surgical teams in all the 47 counties. Full surgical teams in all the 47 counties. Infrastructure, equipment, and technology. We need to audit and upgrade all level 3 and 4 theaters, sterilization, imaging. We need to give them reliable power, water, and oxygen in all these surgical facilities. We need to get pool procurement and standardization to cut lead time and also preventative maintenance and biomedical capacity. There was a time one of our leaders had this great idea 10 years ago to just bring a lot of equipment to all the 4 counties. We all know proper consultation was not done. Most of these things were vandalized. Some were not working. Some are outdated now. Some are just getting cobwebs because it was not thought through properly, and we are paying for them every so often. So we are now incorporating telemedicine, telesurgery, and minimally invasive surgery. The investment here is about 5.3 billion. 5.3 billion, where 16% of the total plan funding the whole chain, not just the kit. Okay? Infrastructure, equipment, and technology. Give reliable power, upgrade the facilities in each county, make sure the procurement is seamless, and make sure you have a biomedical capacity to maintain all your facilities. We also need to expand this equitable access, make sure there's a proper digital surgical referral and feedback mechanism linking all levels. This bit has the largest investment of up to 72%, where access is delivered and made safe. We must make sure that minor surgery can be done at level 3 to decongest the referrals. Surgical outreach should be available, and the blood services at national level should be strengthened. And must always make sure you apply the WHO Safe Surgery Standards and Audits and Safety Committee. Information system and M&E research, you can't manage what you don't measure. So you need to integrate all those indicators across the dashboards. We know there are counties which have live dashboards, like in Murang'a, Kisumu, where at the highest level, even at the governor level, you can just go straight away and know what's happening right down to level 1 facilities in terms of data. How many patients seeing? Are there any bottlenecks? What can you do about it? We need to have this in all the counties, not just a few counties. Research agenda is a must. Whether you like it or not, all this data must be transformed into research so that we can do better. So, One accountable chain, like I said. By having this plan, we'll have at the top a multi-sectoral advisory steering committee. We discussed this in April, so we are still setting up. There are a few bottlenecks, but we're setting up that level. I guess once we set that, then we'll have now the National Surgical Strategic Services Secretariat. We'll have the county TWGs and focal persons, and also the sub-county and ward surgical multidisciplinary teams. This is embedded in the plan. So MOH have this, and I'm sure our colleagues in MOH are looking at this. It will eventually be set up so that we can get this thing going. Shared responsibility from the national, county, teaching hospitals, partners, and communities. And you have to track this. We need to track this monthly, quarterly, and have an annual review in all 47 counties. We must make sure that we at least get 80% compliance with the WHO safe surgery standards. Look at the investments. 2027, we should have put in at least 2.4. By 2028, 5.8. The biggest investment is 2028, 2029, 9.2 billion. Total, we are going to allocate 33.7 billion shillings. And the highest is going to service delivery, about 72%. Anticipated impact, governance, we'll have a good foundation. Systems will have an efficient and equitable and safe surgical systems, meaning care without gaps. Impact, safe, timely, affordable, and equitable surgical care for all Kenyans, and fewer preventable deaths. So what can this room do? We need to champion county surgical budget lines. I'm sure some of you, some are involved and called upon to give your comments about the surgical budget line. Feed the National Surgical Research Agenda. One day we had a meeting, sometime late last year, just to discuss a surgical, MOH called me for a meeting about the research agenda in cancer. Abeid, were you there? Don't know whether, maybe they forgot to call you. But they were to discuss, they had a research agenda in MOH, but after a few years, there was nothing to show for it, and they're wondering how we're supposed to move this story. So they invited a lot of us to come and discuss and see how to move that agenda forward. Host mentorship and training rotations, enforce WHO safety standards. Those are the key contributors. That's how the plan looks like. Those are members of the surgical team after one of the camps. That's a little boost. But the music goes on. Thank you very much, ladies and gentlemen.
Let's appreciate Prof once more. I'll kindly request the presenters for the morning section, Dr. Simon, Dr. Karanja, to kindly come on stage. What I've picked from all the sessions is the importance of collaboration. And there's a phrase that says, when you want to go fast, go alone. When you want to go far, go together. So in the surgical and in the mental health space, all the speakers have spoken into the importance of collaboration, the teams working together. So we'll have a session where you can get to ask questions to the panelists. Okay, let me see. I have 2 hands. Do we have an extra mic for this? We'll start with Dr. Onyimbo, and then we come to Dr. Muya.
Thank you. Good morning, sir. Dr. Dula was my teacher when I joined first year. He was teaching us anatomy. And so that image still remains in my mind up to today. I'm happy to see you, sir. Thank you. My contribution is on 2 points. Number one is about surgery, actually on surgery only. One of the things we have noted here in Kutrrh is the variability of costing. So we find Dr. Ajanja will do a hemorrhoid using technologies, energy devices, and SHA would cost the surgery, say, at 66,000. But the total output of that particular surgery by Dr. 1 using energy devices is 200,000, and Dr. 2 is probably using a different, maybe whatever they use, it becomes about 150,000. And the third one. So one of the biggest challenges, Dr. Dula, is I think we need a national conversation on what is standard adoption of technology, especially for UHC. I think listening to all the work you have done, I think that, in my opinion, is a strategic direction to consider. Number two, one of the biggest challenges is that the financing of surgery today is using packages. Now, not all packages end or by day 5 or by day 3. Some of them, especially say neurosurgery or orthopedics, the patient ends up being in the hospital for a long stay. There is the current daily rebate to the long stays is not consistent with the daily consumption. And so that puts a lot of pressure on either out-of-pocket expenditures or waivers. So these are my 2 contributions, and hopefully as the conversation of surgery continues, these 2, in my opinion, are strategic. Thank you.
Yeah, I'll take it as contributions because you're on the same page. I got so frustrated initially as I tried talking to the SHA, people of SHA, those early days, 2024, as I tried to pitch and said, this is what it costs. So there's some things you can look as minimum surgical things which at least you can put in as a package. By the time we're having our second meeting, I realized I was blowing hot air and those things. No one was listening to me. It had been decided. This is what we'll do, and that's how it is. So I hear you, and with regards to packages, yes, we need to have packages. At the end of the day, it's back to that medical tourism story. Somebody will come from India and tell Dr. Bade, for your patient with cancer of the colon stage 2, this is the total cost from the airport, plane, place to stay, a post-op surgery, post-op care, back in 2 weeks' time, and you find it's cheaper, probably half of what they'll pay if they went to Nairobi Hospital. Packages is the way to go. And all of us can participate in this, but not everything will fit into a package. Surgery is one of those areas you think you're going to do a normal circumcision and things just become elephant. I know of a guy, when I was a young surgeon, I was told of this story where someone was going to do a thyroidectomy. And I think they either did not check the thyroid functions test well or something. But as the doctor was trying to put the patient, give a patient anesthesia, the patient's blood pressure dropped. Ironically, they invited the patient's brother, who's a medical student, to come and watch the surgery. So the surgeon did not even put a knife on the patient, and the patient died. The brother saw his brother dying. He took off and ran for 10 kilometers before they could stop him. All you're saying is surgery is unpredictable. You can do all the best you can, but not everything fits in a package. You can say, okay, circumcision, this is a package, but anything which goes beyond is not package anymore. But you can package a few things. So we're on the same place, same boat, and it's back to demand and supply, isn't it? As we produce more surgeons, the cost comes down, isn't it? As we have more facilities, the cost comes down. Now, the issue of technology, that's now to the device companies. It's not the surgeon. is the companies. So for example, robotic is going to come. Professor Dula has to go for further training in robotic surgery. So he has better skills, isn't it, than how he was before the robotic. Now, for an appendicectomy, which probably could have costed 100 or 150,000, now you're going to use a robot. The cost doubles because Professor Dula has spent his money, so his charges also will go up a bit, isn't it? But then John will come and say, no, I don't need prof operating on me on a robot. Let's do the old style, cut here and remove it. No need for laparoscopy. The cost is low. It will remain low. You get it? So it's a demand, supply, and patient-centered custom, the way patient custom kind of treatment. But if you're going to use insurance, they'll dictate and say, no, a bed is coming. Going to give an example. Thyroidectomy. I love doing thyroidectomy. I also do laser anal surgery. Those are my favorite. And those are energy devices. A thyroidectomy, when I was a young surgeon, I take like a big goiter, I take 3 hours. Now with these energy devices, I take less than an hour. Pop, 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 I'm done. Outcome is faster, patient is better, fewer injuries, he recovery is good. By day 2, I can even discharge the patient. But now the insurance comes and says, hey, prof, you're too expensive, don't use ligature, just do the old style way of doing things. Who suffers here? Prof says, I'm not doing that, give it to my senior registrar. This young consultant graduated the other day. You can struggle with it for another 3 hours. Recovery is a struggle, you may get an injury somewhere. You choose, you get it. But because he can't afford insurance, is refused, so you end up getting suboptimal treatment. If you want optimal treatment, it costs a bit more. You get it. So, but with time, as the cost of the ligature comes down, and by the time I train more people how to use it, and the numbers is demand and supply, the cost will come down. A classical example is India. India, oh, there's so many specialists. That's why the cost is down. Thank you.
Thank you, Prof. All right, thank you. My name is William Muyandavi. I'm one of the consultants here in internal medicine. And it's to the presentations which were essentially about mental health and a lot of the collaborative efforts that are there now to make sure care is integrated. I think mine is simply a comment and just a few questions also. So the first one has to deal with, I like the fact that in Dr. Karanja's presentation, she had actually put that issue of integrated care also for HIV patients. Because I think the fact that we have a prevalence in this country as of last year that was about 3.22%, for females about 4%, for the males about 2% in terms of HIV. I think that is something that really has a major gap. And on that note, I wanted to find out if, there was this joint program which was being released by the National Endemic Disease Control Council. And I was trying to remember if the Division of Mental Health was actually given the platform to speak about their experiences. And there were presentations which were given by a variety of counties. And I realized that was one thing that was not put into the program. And I just felt, as he stated, there's the likelihood of people working in silos. And there are such sensitive and very important aspects of HIV care. And then for us, as a referral facility, because we end up getting patients with advanced HIV, one of the targets they are setting is that reducing AIDS-related mortality by 2030 by 50%. So the role of both mental health with regard to looking after the patients with NCDs, I'm happy that the surgeons are starting to create some noise. Correct me if I'm wrong, is it the task shifting that made you wake up? Or it is something else? Because it all seems all aligned. But one thing I will say is that there tends to be also a lack of coordination and cooperation, whether it is nationally or even within facilities. So I guess this whole thing of integrated care is something that is really close to me. So I just felt I should mention that. The other was just the science. So there was something that was very interesting there where we were talking about with regard to the brain and the mind and how the health also is associated with the communicable diseases. The one thing I always like saying is that we must not forget to mention the fact that the heart-brain axis and the gut-brain axis are such pivotal parts now of mental health. There's a lot of research that is going into how is it that many of these patients, how can we look after them, how can we optimize their care? Even the simple thing like bipolar disorder, knowing that they are more likely to develop cardiovascular-related illnesses, heart disease, diabetes, and all these things. So I'm glad that we've had these particular discussions, and I just wanted to thank each and every one of you for your presentations. Santi.
Thank you so much, Dr. Muya. And I know you are thanking us mostly about the progress, but just to comment and allow my colleagues to comment on the other areas. On the guidelines, you talked about the HIV care, mental health care in HIV, and also whether we participated in the NSDCC conference or summit. So what I can say, because we within the Ministry of Health, we participate a lot in the internal be it development of guidelines, policy documents across the different programs where mental health, there is a requirement for input on mental health, but also even when they organize such scientific conferences and summits, we do participate. I may not recall the specific one you're talking about, because there also have been some that have been organized by NASCOP. However, we also have developed, we've supported NASCOP develop guidelines on management of mental health conditions in persons living with HIV. And even further, even some for in special populations, right? We do understand that especially the key populations, the youth and adolescents, there are unique challenges when it comes to HIV care because of the chronicity of the illness. So we've worked very closely with NASCOP and by extension with the NSDCC on integration of mental health care within HIV care. And a lot of the work we did in 2023 when Dr. Njuguna was the director of mental health actually originated from the need to integrate mental health into HIV care. And as a division, we decided to ride on that and make it even go beyond HIV into other national healthcare services. And Dr. Njuguna maybe will also add on to that. So we do work collaboratively within the ministry, and we participate to ensure that mental health is not left behind. And we have been very aggressive recently in adding our voice in every space so that we are not left behind in a silo as has been in the past. Thank you.
Yeah, so I think most of that issue has been handled, but I will talk around the concept around what is happening right now in psychiatry. I think it's the most exciting time in psychiatry. Like now we are talking of, remember, earlier on, psychiatry and neurology were together. Then they went different way. And people started talking about organicity and functionality. And people couldn't understand what is happening when people have whatever happens in terms of mental illness. They couldn't pick the neurocorrelates. You are doing this, what is this? But the neuroscience right now is, that's what I'm saying, is exciting time. That I know what are the connectivities when seated there and you are just mind-wandering. What we call, that you're just there, you're thinking. They are like what was done some time back in the Human Genomics Project. There's a Human Connectome Project, trying to pick the actual sensors of the brain, from the single cells to the entire connectivity of the brain, so that there's nothing anymore functionality and anything organic. But when we did the basic sciences in Chiromo, when we did neuroanatomy and the rest, and things have changed, and I think the teaching should also change. The enteric nervous system was never mentioned. The nervous system across the body, as you're saying, even with the heart. The heart itself has like its own nervous system. You know, the heart is automatic on its own, the way it runs. It has its own nervous system and how it runs. So once we are now trying to go to the depth of trying to pick what are these pieces which makes human being be there. And now everything is being seen really connected. Like we are talking of neuroendocrine metabolic syndrome. When we talk about diabetes, we're also talking about mental health. It's no longer just endocrine thing. You're talking of neuroendocrine metabolic system. Because the whole system is connected, the whole body is connected. Eh? So the future is, will we continue having specialists? Or we have these specialists who think about the entire body? What we are doing in Mathare Hospital, we have right now 3 physicians working with us at the hospital. We have an emergency medicine specialist. And now consultation liaison and geriatric psychiatry is a whole unit we want to set up, where we'll be sitting all of us together, just like where they're having Brain and Mind Institutes. So psychiatry right now is quite an exciting field. We are working with the endocrinologists, with the metabolic experts, with cardiologists, because actually when we talk about what kills the patients with mental illness, especially severe mental illness, their life is reduced by 2 decades. If generally our lifespan is about 57 years, they'll die 2 decades earlier. And what kills them is cardiovascular diseases. It's metabolic syndromes. And now that's the question, why are they being killed more by metabolic syndromes? Actually, whenever I'm interacting with the registrars, to me right now, what is more important is, have they checked on the physical condition, the blood pressure of this patient, the lipid profile of these patients, the HbA1c. Those are my concern now, because I know that's what will kill these patients, will reduce their lifespan and will increase their impairment in life than actually the mental illness and how all these work. So it's becoming very exciting. We are happy that science is bringing this. The technology is coming around also to make even life even better. And I think we need to start thinking holistically and working as teams.
Yeah, neuroscience. It's good you mentioned it. In 1990, I did my first BSc intercalated. I graduated with the BSc intercalated program, went back to teach as a graduate assistant in University of Nairobi. We had our first SONA conference, Society of Neuroscientists of Africa. I think you remember Professor Kimani, James Kirum Kimani. So he was one of my supervisors at that time. So at that time, I was an active participant. I was just a young medical student. And I think I was in 5th year, 4th year. What am I putting across? That yes, in University of Nairobi, we don't say neurophysiology or neuroanatomy. We look at it as neuroscience. And for the past 15 years, psychiatry students come for a course in anatomy, and we teach them. Things have changed a lot. Yes, before maybe, as Dr. Arias said, we didn't hear much about enteric system, but there's a lot happening in neuroscience. It reached a point that one of my mentees, I taught him BSc anatomy, master's, even got a PhD now. He's a neurosurgeon. He's actually the first editor-in-chief of the magazine, the journal for neuroscience, in case you people are not aware. So, and it's domiciled in our department in University of Nairobi for the time being until they can get their premises. But the idea here is that one holistic approach, like we talked about, neurology, psychology, neuroscience, whether anatomy, physiology, and neurosurgeons, all should be housed in one block. And there is a journal. We even have the editor-in-chief. And we even are going to launch the first Master of Science in Neuroscience in anatomy. So for those of you who are interested, you can talk to me, Kando. Thanks.
Thank you so much to the panelists. Thank you so much to the audience. I think it's very important. There's one more question on that end. But I think that will be the last question that we're going to take, because I think everybody is hungry and wants a break as well. The gut-brain axis, yes. And then the heart-brain is not limited to mapenzi and breakup.
Okay, thank you. It's going to be a brief one. So my name is Dr. Anne Monyaka from the Department of Food, Nutrition and Dietetics. And as I was listening to the different speakers, they talked about the healthcare teams that are involved in taking care of people with mental illnesses or ensuring that mental health remains intact. And one of the things I missed is the presence of a nutritionist in that team. I don't know whether it's me who missed or it was skipped. And yet we know the food that we eat affects even our mood. It affects the diseases that we will manifest. For instance, I've heard Dr. Jogona talked about people with mental illnesses also suffering from diabetes and the other non-communicable diseases. So I wanted to get some clarification on the place of the nutritionist in the mental health team. Thank you.
I think I would start here and apologize that we didn't mention one of our key stakeholder or part of the multidisciplinary team. For those who may have visited Madari Hospital of late, whenever we are doing MDT ward routes, nutrition is key part of mental health. There's a very simple question I've always asked many people when we talk about, there's something we call medical detoxification. I don't like that term. And I remember some time back when we were making guidelines, I tried to see whether we may not use that term. Most of the time when patients who come to us with alcohol use disorder, they're having nutritional deficiencies. And mainly the key one is thiamine. And one of the main medicines we give, also in surgical wards, patients who have been done surgical resections, patients who are chronically ill, we are always doing this thiamine prophylaxis or thiamine management. And people say that this thing is removing toxin from the body. You know, that orange-like color, yellowish, Pabrinex, you know, all those vitamins. One of the things I always make sure our nutritionists, and we are also having very many nutritionists coming for attachments from the university. That's one thing they need to understand. And again, what we are taught in biochemistry about those essentials, elements and mineral metabolism pathways, they have also been shown the key elements in most of these psychopathology. Tryptophan, you are talking of kyurenin metabolic pathways, and so we haven't forgotten you. It's central now. These days we are talking of microbiotas transfers when you talk of brain gut. Actually, they have been shown to be part of treatment for autism. You get other people's gut ecology and transfer to someone else, because that's all what is causing all this mess in the person. Those are some of the treatments we are coming up, getting microbiomes from one individual and transfer to another human being to control that microbiome environment. So together.
Asante sana Daktari. He's simplifying. He's saying in depression, you eat ice cream. And then when we are tired right now with our brains, we need chai. So we'd like to close, to end this session on that note. I would request the speakers to stay on stage so we can just have a photograph with all of them, and the rest of us can proceed for chai and a break.
Thank you so much. Let us make it as brief as possible. Let us keep warm by taking tea and mandazi out there. It's too much. Please eat enough so that we can have more energy and generate a lot of heat. Today weather imeamua inataka ile kufanya ile mambo. Yeah, so pia sisi tutaionyesha. Please 20 minutes we are coming back here to proceed. Tea is going to be served out there. We have our vendors. Please go through our vendors and talk to them. We have our posters. Amazing research has been done. Please go through at the poster booth and have a look at these posters. Enjoy your tea break. Good afternoon. Good afternoon. Welcome back from the tea break. I hope you are now warmer. Are you warmer? Random blood glucose imeenda juu? You have the energy to continue the next 1.5 hours? Okay, thank you so much for coming back. We are going to start our second session, the plenary sessions. There will be some few changes, but we are asking and requesting all our speakers, please let us maintain time. We are 1.5 hours behind. If you keep your time, and if you can even save time, we'll appreciate you. So please let us try to keep time so that we can end on time and proceed for lunch. KU ni mahali kwa mashakura. Kwa hivyo tutalisha mashakura mingi. Nataka tumalize on time tuende kwa mashakura. So my first speaker I'm going to introduce will be Evans. So apology from the head of cancer registry, from the head of cancer registry Cambridge. She has sent her representative, who is going to be Evans. So Evans is going to take us through the cancer burden in Nairobi, the Nairobi Cancer Registry. Please, welcome on stage. So I will cut down the bios. Please bear with me so that we save much time, because reading bio here will take 5 minutes. Speakers, please allow me to do that. Thank you. Makofi kwake.
Thank you, Dr. Adman, and everybody. Good afternoon. So I'm waiting for the slides. Yeah, all right. So thank you very much. My name is Evans Kiptanui, as mentioned. I work at the Nairobi Cancer Registry, which is based at the Kenya Medical Research Institute. It's one of the population-based cancer registries. One of the two that we have in the country, and another one in Eldoret. So I will be focusing on the cancer burden in Nairobi County, but also mention also some of the activities that we do, just to build on some of the collaborative opportunities that probably we can collaborate on, and also at this point also to specifically appreciate the team for the conference and for giving us the opportunity to share and present on this conference. So maybe just as a way of introduction, just for those ones that probably might not have knowledge of what cancer registration is. So cancer registration normally is a systematic and continuous collection of data on occurrence, characteristics, and also on the outcomes of reportable neoplasms in any given population or any hospital, depending on the type of the registry that we are focusing on. And the main aim is really to give us data to inform cancer control and planning in our different areas. So we have quite around three main categories of cancer registration. We have what we call population-based cancer registry. We have what we call hospital-based, and we have what we call specialized cancer registry, which is normally inclusive of disease-specific registries, which also includes something like childhood cancer registries or any other disease-specific registry. Like you can be able to run even a registry on that specific cancer, one cancer. But also we have what is very famous in some jurisdiction, what we call pathology-based cancer registry, which really focuses on reporting cancers diagnosed through the pathology labs and all that. And some countries have really done so well in terms of pathology-based. But the gold standard, the one that is really recommended by WHO, is population-based cancer registry, which really gives us more information and more population data that can be that can inform cancer control programming in that specific population. But the other one is also the hospital-based, which is normally more or less of just documenting data within that specific population. They want diagnosed within that specific population, regardless of the residents. But the population-based is just focusing specifically on cancers diagnosed and or managed within that specific population. So it can be someone who is a resident of Nairobi but seeking care elsewhere, even in Eldoret or different other areas, or the regional cancer centers. And those was really automatically form data in the population-based cancer registries. Yes, okay. So so there is the rationale for cancer registration. As you can see, this is the global map of the world, and you can see there is the map is shaded in different colors. The deep blue one is indicating the regions in the world that have population-based cancer registries, and also those ones that have high-quality data. High-quality data means those ones that meet some set standards to inform cancer control, and that have been evaluated to inform and included in what we call CI5, Cancer in 5 Continents, which is normally published after evaluation by technical teams from WHO. And if you look at the African one, we have quite a number of yellow and gray indicating that we don't have any activity of cancer registration completely. But the yellow ones also, they have some activity of registration, but really not fitting the quality that we can really say it can be able to be used to inform policy. So, but if you look at it, we have quite some few countries like Kenya, Uganda, and South Africa, and some part of the southern part, I think that's Zimbabwe. Those ones are the only ones that really meet that criteria and have consistently generated data to inform these cancer prevention in the region. So what we rely on majorly are the estimates, and we are not really doing so well in terms of cancer data in our region. And understanding the burden and really the need for this population really is indication of some efforts that really have to be done. So so with that cap and all those challenges, it informed some of these efforts towards even supporting and making sure that we in the sub-Saharan Africa region can be able to have data that we can really comfortably say it can inform something. So, and through all the partners, WHO, IAC, through what we call Global Initiative for Cancer Registry Development, they designated centers of expertise in different regions to make sure that we can be able to build capacity of registries. We can be able to make sure that we can push some of these countries that do not have cancer registration to establish one, but also operationalize. So I think it's one thing having a registry, but also it's another different thing having it functional in terms of allocating resources and all that. So that's the work that we do nowadays, supporting in terms of leadership, mentorship, giving technical support in terms of the establishment, talking with the governments in the region. And so far we have really done so well. I think we are present in around 30 countries in the region, and we have trained over 500 cancer surveillance officers, and we still continue doing it in our region. So that is all, and that has been one of the major things that we have really done, and that designation was done in 2022 by the DG of from the Ministry of Health, and we really consistently do that, not just supporting within the region, but also locally supporting through the registries that have been established. So maybe someone will just be asking themselves also, where are we getting this data from? So these are some of the major sources of data for the population-based cancer registry. So all of these ones should really be included so that you qualify as a population-based cancer registry. In absence of one, then probably you will be under-reporting because you are really focusing on a specific population. So we really have to collect from all these potential sources where you can be able to diagnose or you can be able to manage cancer patients. But also the key one is also the death certificates only, which is the one that we call CRS, the Civil Registration Services, where we also have to document and confirm the mortality data from that aspect. So, and we collect from around 30 facilities in Nairobi, and we utilize our trained staff, HRIOs, but also we do this in strict adherence with the data protection guidelines by the ODPC, where we have been registered as a data processor and also as data handlers. So what are the uses of this data from population-based cancer registry? I just mentioned that we are using this to assess cancer burden in the population by describing the present or also the future burden of cancer, how it will look like. And most of us, I think we have really utilized GloboCan, and there's something called Cancer Today, Cancer Tomorrow, where we do predictive analysis and all that. And this data that we are collecting from all these population-based cancer registries normally go to WHO and inform generation of those estimates to give the picture of cancer burden in country. Guiding cancer control actions, where we this will guide planning services, monitoring, control measures, prevention, early detection, treatment, evaluation, and also exploring answers through research, informing research hypotheses. And we have really been supporting a lot of research projects, people who are doing some maybe research concepts, or they are doing, they want some baseline information to justify or to really understand what is happening in the population. So we have really supported most of these ones, most of the researchers as well, including also students at different levels, whether they are PhD or those ones who are doing their masters. So this is just a summary of the uses of the data, just in that picture, informing cancer burden and trends, formulating research hypotheses about cancer etiology, guiding cancer research, guiding patient care, evaluating of interventions like the current one, the 90, 70, 90 WHO target for elimination of cervical cancer. So those ones are also what really population-based cancer registry informs. For example, now we are working towards the 90, 70, 90 targets, and we need our population-based data to inform us whether we are close to elimination or we are quite far from elimination. And the definition of elimination is countries should be able to achieve a rate of 4 per 100,000 cases. And for us, I think we are still around 33, 34, thereabout. I think previously it was 46, thereabout. But now those ones are really basis of what population-based cancer registry should really inform. Then also informing cancer research, and some of these ones, these are just 2 research projects that we are currently doing that I just picked, and these were really informed by the data that we have at the registry. I will not dwell on those ones much because of time. And also this is what I just mentioned on the Global Cancer Observatory, the Global Can, where we publish most of these data. And also the last part, which is the cancer in 5 continents, which is the prestigious volume that is publishing data from high-performing registries within globally in 5 continents. And Eldoret Cancer Registry and Nairobi Cancer Registry have gotten the opportunity to be published twice in that prestigious volume. So this is how the data looks like. Sorry, I think the numbers are not quite visible, but yeah, okay. But that is how the rates look like. So I felt the rates will be more informative as opposed to the absolute numbers. So we picked for a duration 2015 to 2022. Those are some of the most complete years. And I mean most complete years really is informed by how we do our processes. We collect the data retrospectively. And with a lot of these challenges, transitions within the healthcare system, the COVID and all that, those are really affected most of their work. But we are really trying to catch up and push for the most current years. But the data that we can present for this one is 2015, 2022. And that's how the rates look like. Among the men, the one shaded what color is that? Is that that is pink? Sorry, men are tricky. But those ones who went to group of schools, you know, there are people who went to group of schools, and those ones that went to schools in groups. So some of us who went to school in groups, we struggle with the colors. So but you'll see the ones in that color. That color is the pink color. Those ones are is that pink? Purple. Sorry, yes, the purple color. So those ones are the female. Then the blue ones are the male. So you will see the rates as it is for the highest one in that section among the females are the breast cancers, which is accounting for 36.5% per 100,000, followed by cervical cancer accounting for 24 per 100,000, and those are the leading ones among the females. But also, if you look at the among the males, you have prostate with 34.4 per 100,000 as the most common one. But we also have, if you look at our previous data, we were not seeing much of the colorectal cancer. Yes, was among the top 10, but it was somewhere there around 10 or somewhere. But nowadays we are seeing it being diagnosed among the top 3, the top 4 cancer sites in both gender. So which is quite worrying, and yeah, it's being informed by the data. And also we have also esophageal cancers. And if you look at this one as well and cross-tabulate even with or cross-check with what we are seeing even in Eldoret or the other regions, so you'll see esophageal cancer among the males, I think, is coming around 4th, yeah. And but if you go to Eldoret and analyze the data, you also see another different picture for those ones. And this is just a having them separate. It's the same case with the first one, but having them side by side for males and females separate. So you'll see also the numbers of the top 10 for each of these cancer sites. So you have for among the males, the prostate, colorectal coming second, esophageal cancer being the third among the males, but also being the fourth among the women, and mouth and pharynx, lymphoma, stomach, all the way to larynx. But also among the males, you'll see we have among the females, sorry, we have breast, we have cervix, colorectal, esophageal, all the way to the last one being pancreas, and all of these ones are the rates per 100,000. Just for comparison, if we need to compare across different other population. Then, sorry, in terms of age at diagnosis, so you have these two. For the first one is for males, among the males, and also the second one among the female. Sorry, I was not able to do the mean age for each of these ones, but we can be able to just use the proportions displayed. So we have majority of the cancers among diagnosed between the ages 30 to 69, and these account for a bigger proportion, around 66%, and among the males, and around 80% among the females in the same cohort. That is yes, around in the same cohort. That is 50 to not 50 to 30 to 69, but also for among the young adults. I think young adults between 30 to 49, accounting for 39%, and all the way. And also these ones also for the males also displaying almost the same picture. Yeah. So, but it's really worrying as well because the trends also keep on changing, and we are seeing even early onset of these diseases among the early diagnosis among even some of the different cancer sites like colorectal, where we are seeing some younger diagnoses being made, and I think even the oncologists can even attest to the same with something we are seeing from the data. So this is also the trends, how it looks like, and we, as you look at it, we have diagnoses among these different top 5 sites being made at late years, probably around 50 years, and so yeah, you see the diagnosis just being made as the age increases. In conclusion, so cancer really remains a major public health challenge in not just in Nairobi but the whole country, and looking at it keenly from this age, the economically productive segment of the population is really affected, and this really call for interventions and strategies of combating this, and really using some of the strategies that are existing, like promoting early diagnosis, screenings for the screenable cancers, and all the strategies of early prevention, and also sustaining collaboration across all the stakeholders, from the ministries, the healthcare providers, academia, and all the partners involved, so that we can be able to really streamline this and make sure that we are able to reduce this ever-growing incidence. So, and I have just a quote there that if we cannot count every cancer case, so we cannot fully understand the burden. So really justifying why we really need to strengthen the registries and make sure that we can be able to utilize all the data from these registries to inform cancer control and prevention efforts in the countries. So thank you very much for your attention.
Thank you very much, Evans. Actually, this data is very highlighting. I don't know if you guys, you really appreciate it. For me, as an oncologist, it means a lot. Another round of applause for him, please. So usually they say data is gold. Actually, data now is the new gold. Without data, there's nothing you can do about it. It is informing us in terms of planning and everything. And what Evans has shown here, I don't know if you guys were paying attention. If you look at the age group of cancers, 40%, this was the age group of 30 to 39. I don't know if you guys you paid attention. 30 to 39. So what does that mean? It means a lot of young people are dying of cancers or they are being diagnosed with cancers. So it means all of us here, we are at very high risk. The other second group was at the age of 50 to the age of 69, which was forming around 30%. So it means if we add the age group of 30 until 69, we have around 70% of people being diagnosed with cancer. And if you look in female part, more than half, nearly half were women diagnosed under the age of 40 with cancers. So it means our sisters here, we have to do something, whether in terms of screening, in terms of getting vaccination for HPV. I think that is another topic which is going to be discussed tomorrow. Let me not take much of your time. We are already behind. I would like to invite our second speaker, who is going to show us how is our data comparing to the Nairobi Cancer Registry. This will be my close friend, Mercy Kahari. She is the head of the Health Information Management Department. She is a health information management specialist and healthcare leader with extensive experience in health records, data management, and health system strengthening. She currently serves as the head of Department of Health Records and Information Management Department at KU Referral Hospital and the regional director of IFHIMA, inakaka majina la Kiarabu. Imeitwa IFHIMA. So as well as the board member of the Health Record and Information Managers. She holds a master's degree in health system management. You know, I've always been calling her doctor. She keeps on telling me I'm not a doctor. But the reality, she's now the candidate of PhD. Makofi kwake. Sinafaa nimwite doctor, si ndio? Welcome on stage, Mercy Kahari.
Thank you. Thank you, Dr. Bates. I want to give an history where oncology clinic started at KU TRRH. The hospital started in 2019, and we had so many inquiries on the patients seeking services for oncology clinic. And our first clinic to be opened the doors for the patients is oncology clinic in 2019. And I want to say that my presentation is not different from the Evans. I have seen that what we have is just the same as the one for Evans. Globally, this is a report from Ajax. It has been mentioned by Evans. 2022 report is showing that 20 million new cases have been reported, 9.7 million deaths globally. And I want to say that the leading cause globally is lung and breast cancer. It is also projected that by the year 2050, 35 million cases will be reported, and this is an highlight that there is need for improved healthcare infrastructure and access to cost-effective cancer services. The Kenyan situation, and this is a report from GlobalCan, and it is also captured in the Kenya Cancer Control Program Strategic Plan 2023-2027. It says that new cases are reported yearly, and this is 44,000 plus new cases for cancer. And also we have deaths reported yearly, 29,317. For the past 3 years, we have 102 plus thousand people living with cancer. KUTRH, we have the top 10 cancers that are reported in our hospital, and this is from the beginning of the hospital 2019. We have the CA prostates for the male, not different from Evans. For the female is breast cancer, followed by esophageal cancer. And for the male, we have CA prostate. It is the one that is leading. We can also see that number 3 for the female is CA cervix. Among the patients that are seeking oncology services, in terms of the age, we can see that for the female, it's between 52 and 61. And for the male side, the highest that are seeking medical services is between 62 and 71. So the ladies are leading and seeking medical oncology services. For the gender distribution among the patients that are seeking oncology services, we have the female that are the ones who are leading with 66% and the male 34%. One of the things that we noted in our hospital is when patients are coming to the hospital, majority, that is 90%, are unstaged. So it takes time for them to be staged. Unlike the ones who come already staged, they get services. Our waiting time is 1 day if you have all the requirements for the services. KUTRH is a national referral hospital, so it has been giving services to all the counties, and the highest leading is Kiambu, followed by Nairobi, Murang'a, Nyeri, all the way to Wajir, and even outside the country. I want to say that 95% of our clients are covered by SHA, and 5% other services. So yes, SHA is working. So numbers have been growing throughout the years. As we can see on the presentation, the indicators of the new oncology patients, up to date, we've seen 11,000 plus. The chemo clinic revisits, it shows that patients have been coming back for the services, and these are 81,000 plus. The chemo sessions, we have 62 plus sessions that has been given to our clients, and the admissions are 11,000 plus. Utilization of our inpatient services, we have the bed occupancy, 68%, and our patients do not take long. It's 15 days for the treatment, and then we have the death rate, which is very low compared to the whole country's 12%. The recommendations, I want to say that most of the recommendations our speakers have talked about, we've seen that breast cancer is leading in the female. So we need to increase screening for early diagnosis, improved outcomes, and also we cut the cost. Evans and Dr. Kutrrh, we need to strengthen cancer registry. We need to train more cancer registrars. We need to get more data in the cancer registries. I appreciate that we have the cancer registries, but the reporting rate is very low. On digital oncology dashboard was mentioned by Professor that we need to have digital dashboards for us to complete data, to have accurate data. We need to use predictive analytics for resource mobilization and early detection and also prevention. Research collaboration. We have Professor Njoroge here. We know him. He has been doing very well in research. We need to collaborate national referral hospitals and international agents so that we share knowledge. The future is bright. We need to incorporate AI in healthcare. We focus on population health surveillance, national interoperability exchange. If a patient is seen in Moi referral, comes to seek services in our hospital, we need to be able to see all what has been done in MTRH. And I want to say that Dr. Bede has talked about the importance of data. I echo the words of Edward Demin that without data, we are just another person with an opinion. Thank you.
Thank you very much for keeping time. That was wonderful. Makofi kwake. So mwona vile candidate wanavyopresent wanajua kuweka time. Na nyinyi pia mkuwe ma candidates. So we are going to move to the next presenter. I think for those of us in the sphere of oncology, she doesn't need an introduction. But because being a special day, I will just have to mention briefly. Next speaker will be Dr. Sitna Ali Mwanzi. She's the head of oncology at the Kenyatta National Hospital. We have been having very good collaboration between the two hospitals, the KU TRLH and KNH. She's also serving as the Secretary General of the IOTIC. IOTIC is the whole body combining all oncologists and researchers in Africa. Makofi kwake. So this is going to be a sponsored talk by our silver partner, Roche. She's going to talk about new approval in hormone receptor positive, HER2 negative breast cancer. Even though this is a sponsored talk, it's going to be free from adverts, so it is pure science. We are going to learn what is new in the field of breast cancer management, metastatic hormone receptor positive. We all know that breast cancer is not one disease, it's a group of disease. So we'll not go into details, so we are going to focus on one small area of breast cancer. Remember, we said women are the most affected. Macho kwenu.
Thank you, Dr. Abeid, for the warm welcome. Good afternoon, everyone. We had tea, so some energy. Good afternoon, everyone. Alafu kuna maji na kuna sweet pia. So thank you for the kind introduction. I think our main screen is not working, but if you just look at the side screens, you should be okay. My talk is going to be very technical, so forgive me. I'll try and make it as relevant as possible. But I'm going to be talking about the commonest type of breast cancer, which is the hormone positive, HER2 negative breast cancer. Not sure why this is not working. You can go to the next slide. These are the disclosures that are relevant to my topic today. I think this is not working. Okay. We can go to the next slide as we sort that out. Okay, all right. So we've already heard about the prevalence of cancer, thanks to Tanui and the speaker from KU. So breast cancer is the most common cancer that we are going to see in women. So for women, 1 in 4 cancers will be breast cancer. And I think that is relevant because even in our oncology clinics, they are the majority of the patients. We do have breast cancer in men, so it's not a disease of women. So about 4%, 2 to 4% of our patients will be male. So I think it's quite important for us not to go out of here thinking it's a disease of women only. It is a disease of both men and women. So breast cancer, many people think about it as one disease, but actually it's multiple diseases labeled under the breast because the cancer starts from the breast. But there are different subtypes of breast cancer, and that's important because the treatment for each different subtype can be very different. And that's why it's very difficult for us to quantify. If you ask me, what is the cost of treating breast cancer? I'll tell you it can range between 100,000 to 10 million, depending on the molecule I'm going to be using. So whenever we think about it, just think about it as multiple diseases. So we have enough data from Kenya to say that the most common type of breast cancer is the hormone-positive breast cancer. In the past, people thought that it was a triple negative that was more common, but actually it is the hormone positive. So 6 out of 10 patients with breast cancer will be hormone positive. So this is a large group of patients for us. And the mechanisms of the drugs are related to, this is back to physiology, are related to the pathways in which estrogen and progesterone affect the estrogen receptor, and the pathways of resistance are based on the same molecules. And what we have done in science is we have utilized these pathways to develop drugs related to these pathways. So we block estrogen production using aromatase inhibitors. We block the transcription from estrogen by blocking the attachment of estrogen to its receptor. And then we also block the pathways of resistance using different molecules. So in breast cancer, we always say that there is 2 major groups. There are the people who have early stages, which is from stage 1 to 3. And then we have patients who have metastatic disease, and that's stage 4. And the treatment really varies between those 2 groups. In the early stage, most of the patients will get a combination of surgery, chemotherapy, radiotherapy, and dependent on the type of breast cancer, they'll either have hormonal therapy or they'll have directed therapy towards the HER2 positive breast cancer. So in the metastatic setting, we use less surgery because surgery hasn't been shown to be beneficial in terms of improving survival. So we'll use more medicines in that case. So many times when we look at hormone positive breast cancer, we think that even if it's hormone positive, they're the same. But if you come to the clinic, someone with hormone positive breast cancer is supposed to do well, but actually some patients don't do as well as we expect. And so risk stratification of these patients is important so that you do not overtreat the low risk patients and you do not undertreat the high risk patients. And so that differentiator is important. And like I mentioned, we would use endocrine therapies, which are usually oral. We use chemotherapy in a subset of patients, but what we haven't really characterized are those high-risk patients that we need to do more beyond the endocrine therapy. And so the things that we use to define high-risk patients are younger patients, in our experience, tend to do a little bit worse than the older patients. And I think the data from KEMRI and from KU shows that for women, majority of those patients will be younger patients. So then it means our populations are the women who are at high risk. And we see that a lot in clinic. And then if you come with a larger tumor, if you have more lymph nodes in the armpit, and if it's high grade, then that is increases the risk. And those are the people we see in clinic. We see people with large tumors, some with fungating tumors as their initial presentation with large lymph nodes. So our population really fits into this high-risk population. And something that we are not doing here is gene expression signatures, but this really helps us to determine what kind of treatment we would do. And then the role of the pathologist is very important for us. The pathologist needs to tell us not only the size of the tumor or the lymph nodes, they need to tell us the grade, the percentage of ER positivity, and also, other things that whether it is luminal B or HER2 or basal-like. So the pathologist's role in breast cancer is very, very key because they can give us information that will risk stratify our patients. So for early breast cancer, we have always been doing tamoxifen for the premenopausal women, and we've been doing the aromatase inhibitors for the patients who are postmenopausal. And tamoxifen is a drug that's readily available. It does have its own limitations, and for people who have achieved menopause, the aromatase inhibitors are more effective, and because they're available, we should use them more. And then there are other strategies such as switching between the two, and then also extending the duration of treatment. So in clinic, you'll find everyone is told you're going to get 5 years of treatment, but the high-risk patients need to get longer treatment. With longer treatment, it means we get cardiovascular side effects, we get increased menopausal symptoms, so we increased bone loss. So we need to work with our endocrinologists also when we are giving these patients prolonged treatment. And the other things we can do is we can make the premenopausal patients menopausal, either surgically by doing ovarian ablation, or oophorectomy, or we can do radiotherapy to reduce the function of the ovaries, or we can give them drugs. More often than not, we're giving them drugs because they're covered by SHA. We've been told SHA is working, but they're easier to use, and if a patient finishes their 5 years, then it can be reversed. And so many of our patients will require this because we've said our patients are younger and they tend to remain premenopausal after chemotherapy. Then the other class of drugs we can add is the cyclin-dependent kinase inhibitors. And there's a lot of literature already showing that 2 of those drugs improve the outcomes based on the studies. I know the graphs don't look very good when they're separating, but for oncologists like Abeid and Dr. Kungu, they are happy when they see curves separating, even if it's by 1 millimeter. They say that there is improvement in outcomes. But I think the other drug shows about a 7% difference, which is very significant for us in oncology. So we know that many of our patients will come with advanced disease, whether they are treated and then they have a recurrence or their first presentation is stage 4 disease. And there are so many new molecules in this group that are being developed. So for us as oncologists, it's like we have to learn a new language regarding the treatments, and there are so many options. So the question is, which kind of drug will you use for which patient? And we've seen a huge evolution. So in the beginning, we were only using limited drugs, and towards the end of 2019, more targeted treatments have been used. And the treatment considerations then become, what is the clinical state of the patient? What's the menopausal status? What treatment did they receive before? And the thing that maybe KU and KNH can work on is to look at molecular profiling. So having next generation sequencing in our labs, because targeted treatment is where we are going. Precision oncology is where we are going. So a lot of our patients are not getting adequate treatment because we are not able to do these tests. And we're not able to do these tests because they cost between $3,000 and $5,000 USD for a single test before you start a drug that will cost you just as much per month for you. So, but I think if we increase the volume of patients who require these tests, then the price actually comes down more. And so there's the element of patients becoming resistant to treatment due to different pathways, such as the ESR1 mutation. And for those patients, we know that adding the cyclin-dependent kinase inhibitors in the first line really improves the outcomes by up to 2 years. And also in the second line also improves the outcome by another year. So addition of other treatments, targeted treatments, really help in improving outcomes. One of the important things about the hormone-positive breast cancer in stage 4 disease, you do not necessarily need to give chemotherapy first. You can give them oral treatments that actually have fewer side effects, and they can be comfortable on those treatments for 2 to 3 years before you even need to use chemotherapy. And then other targets such as the PIK3CA mutations, there are approvals for drugs in that area. And more recently, 2 FDA approvals for ESR mutation for oral treatments have been made. Of course, our graphs are separating, but the progression-free survival difference is about 3 to 8 months. So these drugs are improving outcomes, even though they may not look so great on the curves. And this is a drug that's just been approved last month, which is also like a targeted treatment for breast cancer. And there are many, many more that are coming up. So our pathways have changed. So this was the guideline for ESMO. I know I'm not sure. Oh yeah, it's much better here. So we had fewer agents that were approved in 2021. And you can see that the role of next generation sequencing becomes important, because now the guidelines say you need to test for these mutations so that you can guide the treatment. And this is even becoming more, because the number of mutations, if you look at this slide, there are only 2 mutations you're testing for. If you look at this slide, there are almost 6 mutations that you're testing for, which means that we are being left behind because we are not doing these tests and our patients are not benefiting from those treatments. And if you do not have them, then you need to remember your old standard chemotherapies are still effective, and those are the treatments that we will continue to use. Just as a summary, majority of our patients will be hormone positive, so we need to be able to use endocrine therapy for them. We need to be able to risk stratify them. We need to look at the duration and additional treatments. More importantly, we need to up our game in terms of molecular profiling, and so that we can be able to use the new treatments. So thank you very much, and happy to take questions.
Okay, thank you. Dr. Sitna, she's on call. Maybe we'll just take one question before she steps down on the podium. Mwanzo makofi kwake. Just one question so we can proceed with the program to allow her to step down. Microphone?
I can come and bring you the microphone.
Thank you very much. Okay, let me stand. Yeah, you described very well the need for precision oncology. And just a follow-up question, where are we in terms of immunotherapy?
In terms of immunotherapy? Yeah. I think immunotherapy is readily available, but is it affordable and accessible is the question. So the first thing for immunotherapy, there are some tests that need to be done to see whether patients can benefit from immunotherapy. Currently, I don't even think that there's any lab doing them in-house, that test. But more and more labs are looking to do the test in-house. So that's the first step. The second thing is that because these are difficult to make molecules, the cost that they come into the country is on the higher side. So for example, a standard drug like pembrolizumab, if you're buying the original pembrolizumab, it will cost you $8,000 for one cycle. Is that? Yeah. Yeah, which is about $1 million shillings per cycle. And if you're using the biosimilar, it costs about $500,000. So you can see that the medicine is available, but is it affordable and accessible to all our patients? If we are using, as you've seen from the presentation, most of the patients do not have other insurance apart from SHA. So if you're using your SHA limit of $850,000 for cancer, then only 2 cycles of immunotherapy and it's done. So for in the private practice, we use it a lot. There are some cancers that really do well on immunotherapy, such as melanoma, which is skin cancer. Patients with lung cancer tend to do really well on immunotherapy. The indications from immunotherapy have really improved, have really expanded across different cancer types. But that challenge will be diagnostic. To do the test costs you about $50,000, and then to use the treatment, it will cost you about $500,000 to $1 million per cycle. And these are long-term treatments. The minimum number of years for immunotherapy is 1 year. So you can imagine. So that's how many millions? A few plots somewhere. So people have to choose between, in addition to that, most of the immunotherapy you have to combine with other treatments. But what has happened, what we have learned, for example, with targeted therapy, is that over time, the price of the molecules go down. For example, one of the drugs that we use for breast cancer called trastuzumab, when it came into the market, it was very expensive, but through partnerships with the ministry, that cost has significantly reduced, and so the drug is readily available and accessible to all patients. So it's also about a time factor. With time, it will be available to more people. Thank you.
Thank you. They say time heals everything, so even time reduces the prices. So, Dr. Sitna, before you leave, I know some of these molecules you have been actively involved in doing research, because once we hear about clinical trials or research, we feel this is something only for Wazungu or abroad. But here in Kenya, we have Kenyatta National Hospital, which is a government hospital. Some of these molecules, they were tested in our patients here in Kenya, and Dr. Sidna, she is the researcher who has been doing this research. Makofi kwake. So please tell us, what are you doing now so we can support you?
Yeah, so we had the opportunity to do one of the drugs that I presented here. We are actually still doing the clinical trial, and we are looking at patients with hormone positive and HER2 positive breast cancer, and looking at the PIK3CA mutation. So the first thing that the study does, it checks the patient to see whether they have one of these mutations. So what the clinical trial has done, it's given us access to doing the testing. So we were able to do the testing for the patients who were enrolled in the study. And those with a PIK3CA mutation, we were giving them a targeted treatment called inavolisib. And then we were combining that with the CDK4/6 inhibitor and anti-HER2 therapy. So the study is still ongoing, so we do not have the final analysis, but it has closed for recruitment, which means we are waiting for the minimum number of events before it's reported, and the expectation is that the results will be announced in the large meeting called ESMO, which is going to happen in October this year. So it's really telling us that we have the capacity to do the studies. We just need to be organized, because one of the things we struggled with was recruitment. So we've been given the opportunity to do the study, but then clinicians are not willing to refer patients, because if you refer a patient, you lose the income for treating that patient. And then there are lots of myths and misconceptions amongst patients about what clinical research is. So basically, we also need to continue with engaging with healthcare providers and with patients and advocate groups to tell them the value of doing clinical trials. And one of the biggest values is that we always extrapolate data from outside. Side effect profile we think will be the same, and we know even from using chemotherapy that certain drugs have different side effects depending on the ethnic group that you belong to. So that gives us an opportunity to participate and see whether there are differences within our population compared to other populations. So that's just one. We have another study for hormone positive breast cancer, but that has closed globally for recruitment. And we previously had a study on hepatocellular carcinoma, which really was an important study at that time. And we are grateful. Actually, some of our patients on the study came from KU. So when he says we collaborate, it's a true collaboration. We work very well together, and we hope that in the next few months, KU will start their research unit so that we can have more centers participating in the trials. Thank you.
Okay. Thank you very much. Makofi kwake. Naweza kumwachilia? Okay, sawa. They say the future is woman, women. So the future is woman. Our next speaker is another brilliant, wonderful lady. She is my co-head of department at Kenyatta University Referral Hospital, Dr. Wambui Kungu Gertrude. We happened to school together in our master's level, where we went the same school. She was 1 year ahead of me. She'll be talking to us about the role of SBRT. SBRT stands for stereotactic body surgery. If you guys, know bodyguards, she knows stereotactic body surgery. So you need to be careful with her when you meet her. So this is one of the amazing things we have been doing here in KU. I know you guys, know it with a bigger name. We call it CyberKnife. So Dr. Kungu is going to present to us our CyberKnife data and how we are performing here in KU Referral Hospital. Welcome.
Thank you, Dr. Bate, for the introduction. As you all heard, my name is Dr. Kongo. I'm a clinical and radiation oncologist working here at KU. And I've had the opportunity to present this important topic that is very close to my heart. So I'm going to present to you the title, Brain and Spine Radiosurgery. So I have got no disclosures. I'm hoping at the end of this session that we're going to understand the definition of SRS, SBRT, that is stereotactic radiosurgery, what it is, and also the radiobiology to it, the complications that come up with radiosurgery, and how to manage the complications. So to start with, if you could kindly move to the next slide. When we're talking about radiosurgery, the most important thing that we're going to talk about, of course, is our founder, basically, Lars Leksell, who was a Swedish neurosurgeon that actually combined stereotactic methodology with radiation therapy. In 1951, actually, he was able to perform radiosurgery, and then he continued with this work until 1968 when he built the first radiosurgery by using gamma knife. Thereafter, because of that, we've had lots of machines that are able to perform radiosurgery, the Linac machine and the CyberKnife machine. So when you're talking about the principles of SRS and SBRT, we are going to talk about the definition, radiobiology, and of course comparing this with external beam radiotherapy or the old traditional conventional radiotherapy. So stereotactic radiosurgery is basically a precise focused delivery of a single high dose of radiation to a very critical small organ that is normally close to critical organs, and at that time you also spare the normal structures. Fractionated stereotactic radiosurgery, on the other hand, is similar to radiosurgery, but then in this time you're using a lot of fractions, between 2 to 5 fractions. Now, stereotactic body radiotherapy, on the other hand, is when you're having similar stereotactic radiosurgery, but it's extracranial sites. So trying to differentiate between these, I would want us to go through the conventional radiotherapy and stereotactic radiosurgery. So I would just like to explain the differences between the two. The conventional is the old type of radiotherapy. We're using a lot of fractions, say close to 35 fractions, while SRS and SBR2, you're using less fractions. For SRS, you just use a single shot, and fractionated SRS and SBRT, you're using about 2 to 5 fractions. The grays that you give in conventional fractionation is about 1.8 to 2 grays per fraction, while in SRS, you're using a very huge dose, about 18 gray, even 79 grays to 90 grays in trigeminal neuralgia or functional disorders. Nonetheless, when you're talking about the margins that we normally give in conventional radiotherapy, we find that there are cases that we can even give margins to up to 1.5 to 2 cm, even 4 cm in some. But with stereotactic radiosurgery, we have very tight margins. As you can see, in stereotactic radiosurgery, we have about 0 to 1 mm, while in fractionated kind, we have about 2 to 5 millimeters. So one of the important things that I would love to talk about is the radiobiology of SRS and SBRT. If we've got physicists and RTTs in the audience, maybe they would appreciate this much. So when you're talking about radiobiology in SRS, it's a little bit different from conventional radiotherapy in that with SRS, what happens is that you have massive vascular damage causing indirect tumor death. We have endothelial inflammation, and then we have microvascular dysfunction that are basically the triggers of tumor cell death. When you're talking about the 4 R's of radiotherapy, is very different from conventional radiotherapy. In this case, we do not have repair. Why? Because we have massive destruction because of the ablative dose that we use. We've got no reoxygenation because of the treatment period. It's a really short that doesn't give you the time for reoxygenation and reperfusion of these cells. Redistribution also doesn't really occur here as you have massive destruction of these endothelial cells. Some of the indications for brain and spine SRS, we've got the vascular functions, like the AVMs, we've got benign and malignant functions. So the tumors that we have, especially for benign ones that we get a lot from the neurosurgeons and the ENT, we've got vestibular schwannomas, we've got meningiomas, pituitary adenomas, and of course, majority of the time for metastatic lesions, we have those in the spine and those in the brain. And we also do a lot of re-irradiation for gliomas. So the next part that I wanted us to discuss is just a couple of case presentations that we've had. I chose about 3 cases that are quite significant to us. So we've got 2 cases on the brain, and then 1 case will be in the spine. So the first case was a non-small cell lung cancer. So we had one 62-year-old female who was had being EGFR being positive non-small cell lung cancer, was on osimertinib for about a year, and then now she came presenting with onset of headache and convulsions. At that time in time, her echo performance status was 1, her GCS was good. We had an MRI that was done and showed a 2.4 centimeter left occipital lesion and with minimal edema. It was confirmed from the MRI to be brain metastasis. Of course, at this point in time, one of the options that was given to the patients was to perform surgery. Unfortunately, the patient declined surgery because of one reason or the other. So we had an MDT on this case and decided to do SRS to the patient. So we gave 27 gray in 3 fractions for this patient. So whatever you're seeing there is on the left-hand side is basically the scan that we did prior to stereotactic radiosurgery in January this year. And then after that, 3 months later, after the session, we did another MR. Whatever you can see there on the left side, you can completely see the lesion has resolved. And this was just after 3 months. So we really had very good response in regards to the stereotactic radiosurgery. Okay, so I just wanted to mention one of the trials also that really supports radiosurgery, and especially in such cases. So we have one huge trial, the Japanese trial by Aoyama that was done in Japan. They used about 160 patients, and in these patients they had about 1 to 4 brain metastases, and each of these brain metastases had to be less than 3 centimeters on MR. So they divided them into 2 cohorts. Cohort 1 got whole brain radiotherapy with SRS, while the cohort 2 got SRS alone. The dosing was basically in regards to the tumor volume. So those who had a tumor volume of about less than 2 cm got about 22 grays, while those who had a tumor volume of more than 2 centimeters got about 18 to 20 grays. The primary endpoint of this trial was overall survival, and what we can see from the graphs there is that there was no difference in overall survival between the 2 cohorts. Nonetheless, what we found is that those patients who got stereotactic radiosurgery had a higher chance of developing new brain metastases. What I need you to note is that even if they got these new brain metastases, they were quite distant from the area that was irradiated before, and they had similarly worse local control than the others. So we also had some predictors for the same. So we had predictors of survival and those of brain distant failure. So we found that if you had your age less than 65 years, if you had a stable primary tumor and a stable extracranial tumors, then of course you had a better chance of survival compared to having an active extracranial disease. Now, based on this data and this trial also, it informed us on the importance of SRS, especially in oligometastasis or solitary lesions. And of course, you have to be very careful on how you select these patients. So the next thing that I wanted us also to look at is brain metastases where you have multiple brain metastases vis-a-vis a solitary metastases. So there's this important trial also, still a Japanese trial that used about 1,194 patients. These patients had about 1 to 10 brain metastases, and one of the inclusion criteria was that you should have had a single tumor that was less than 10 cc in terms of volume, and it had to be less than 3 centimeters in diameter. If you had to have multiple metastases, then the tumor cumulative volume should have been less than 15 cc, must have not had whole brain radiotherapy prior, and the dosing as well was in relation to the tumor volume, as you can see from there. Now, the primary endpoint, again, was overall survival. It was actually met in the fact that there was no difference in overall survival between the 2 cohorts, whether you had 2 to 4 brain metastases versus whether you had 5 to 10 brain metastases. And this actually helps us to make a decision. And this is where we understand that with multiple brain metastases, it does not matter the number that you have. What matters is basically the volume of the accumulated brain metastases. So the other case that I also wanted to talk about and just show you is a case of vestibular schwannoma. Is one of the cases that we've gotten a lot in our training and basically with our patients here. So what you see on the left-hand side is a scan that was done in January last year. So it's a patient who had about a 3.5 centimeter lesion in the vestibular region. So we gave SRS as well for this patient. Then 1 year later, we did a scan on the right-hand side. As you can see, there's a slight reduction in the size of that lesion. And the importance of this is to understand that there is not robust change with the vestibular schwannoma if you compare with what we had with the brain metastases. And of course, that comes hand in hand with what we call alpha-beta ratio. It's basically a lot of bit of physics. And this actually helps us to understand that when you have benign lesions like vestibular schwannomas, do not rush into doing MRs. You can take a little bit of time, a year, 2 years, before you evaluate your patients. So this is just course grading system that I just decided to throw in there for you to understand the, the grading and how we choose our patients in regard to stereotactic radiosurgery. And what we decide is that if you're in between grade 1 to grade 3, these are the patients who are liable to get stereotactic radiosurgery. If you have a grade 4 because of deformation of the brainstem, we prefer that they go in for surgery. So with that, I wanted to just show you some data that was done by UCLA that showed the outcomes of stereotactic radiosurgery vis-a-vis conventional radiotherapy in vestibular schwannoma. They actually won an award at the Cinder Skull-based surgery. So they took about 138 patients. Now, the 35 patients among the 138 patients got SRS as a single shot of 12 gray. And the others got about a mean dose of 48 to 54 grays in a couple of fractions. And the primary objective in this case was to review the effectiveness and safety of SRS and external beam radio in vestibular schwannoma. So what you can see here is basically 2 graphs showing hearing preservation. The one on the left is the single shot of SRS. The one on the right is conventional RT. What you can realize with this is that with SRS, the hearing preservation was much lower at 60% compared to the conventional radiotherapy. And what this informed us was like, if you have a disease that is getting into the cochlea or very close to the cochlea, then it is better for you to do external beam radiotherapy rather than SRS. So with this, actually, the authors wanted to understand why we had a difference in the hearing preservation between SRS and EBRT, and they went back and reviewed the plans again. So they took each and every CT plan of these patients, and they contoured the cochlea, as you can see on the screen, and they fused this CT with the MR to ensure that you had proper delineation of these cochleas. What they did is that they looked at the dose that was getting into each and every cochlea, and they realized that for patients whose the mean dose to the cochlea was 8 gray or less than 8 gray, then they had better preservation of hearing compared to those who had a dose higher than 8 gray. And this actually informed the team to the importance of really doing your targets pretty well, looking at your plans in terms of approval so that you can make sure at least the cochlear dose is pretty less for you to preserve hearing, especially in a patient whose hearing is still intact. So they went ahead and still published data on the same. If you could move to the next slide, that's just the trial. We could go next. So the next case that I wanted to present to you is an important lesion, that is melanoma. So we all know what melanoma is. It's basically cancer of the skin. So it's a patient who was on treatment for melanoma with one of the immunotherapies for a year, and then they developed spine metastasis to the level of T11. So as you can see, there's a lesion there that is attaching the vertebral body. On the right-hand side is going to to the pedicle. So at this point in time, the patient was meant to do surgery, but unfortunately, because of cardiac issues and comorbidities, patients was not able to do surgery. So we went ahead and did stereotactic radiosurgery to this patient. So for this patient, we did a pretty higher dose than what we would do from other stereotactic radiosurgery cases. And this is basically what I would like you to see. Whatever you see on the left side in red, that is basically the gross tumor. Whatever you see in the middle of that vertebra is basically where we've contoured the spinal cord. And the right-hand side, that is just a CTV where we contour the entire vertebrae, the contralateral pedicle, and the ipsilateral transverse process. So basically, this is, whatever you're seeing next is basically a plan of what we were able to do. What you see in blue is basically 80% isodose curve that we prescribe the dose to. And then next to it, we were able to spare our spinal cord that was quite intensive for us, but that is how we were able to do our plan. And then patient was actually treated and he did well. 6 months later, we repeated a scan again. And as what you can see on the right-hand side is basically after the stereotactic radiosurgery, we can just see scar tissue forming on that side. So, I mean, the response was quite good. Patient is still doing well to date. So I wanted to just attach one of the guidelines that we use as oncologists, that is the NCCN guidelines. And as you can see, stereotactic radiosurgery is normally the preferred method of treatment for patients, especially if you've got a more life expectancy of more than 3 months. And especially when you have tumors that are a bit radio-resistant, such as melanomas, sarcomas, this is basically one of the best methods that you can use in treating your spinal metastasis. Now, going to the complications, we've got a lot of complications that come with SRS. It is interesting, it is a great and beautiful, procedure to give to our patients. Very nice technique, but it has its own complications. You need to be very careful in the patients that you select. You need to be very careful in your plans and approval. And one of the complications that we have is radiation necrosis. We've got radiation pyelopathy, hypopituitarism, especially in patients with pituitary lesions. We've got vertebral compressions that can come up, and we have ways of how we can manage them. I wanted to choose one that's very, very common among the cases that we've gotten so far, and that is radiation necrosis. And this is so important also amongst our radiologists, because we really depend on them in identifying or ruling out radionecrosis with things like pseudoprogression or tumor progression. And one of the things that, of course, we look at is a MR spectroscopy to ensure that you're able to differentiate between the two. So if a patient is asymptomatic, doesn't have any symptoms, then you can just evaluate the patient and do MRs every 3 months and just ensure that you're able to check out for them. If the patient is symptomatic, then the ways of treatment, we normally give them steroids like dexamethasone, but sometimes they get refractory to steroids. And then this is a point where you can employ your bevacizumab, and they do pretty well with that. So based on that, I think you can be able to understand that stereotactic radiosurgery is a robust, is an immense, is a beautiful technique that we can use, but you have to be very careful on the patients that you actually choose and select for this kind of technique of treatment. So some of the take-home messages that I would want us to get, of course, is SRS extends ablative organ sparing in both benign and malignant tumors. In metastatic cases, what matters when you have multiple brain metastases is not the number of metastases, but basically the cumulative tumor volume of these metastases. And multidisciplinary case selection still remains essential to optimize local control while minimizing neurologic toxicity. So I wanted to bring out some of the data that we have. Whatever you see in a pie chart is basically one of the, basically an amalgamation of the tumors that we've treated so far since September 2023 to date. So as we can see, the highest number of cases that we have is metastasis, both to the brain and to the spine, but majority of them, of course, is to the brain. We've got meningiomas coming in second at 24%. We've got gloma jugulares and gliomas, and majority of the gliomas that we've gotten is not really low grade, but re-radiation in high grade gliomas like GBMs. And Next is basically you'll see one of the machines that we have for CyberKnife. You could go to the next one so that I can just show you our beautiful machine that we have. So you can tell a friend to tell a friend that they can refer their patients here. We have a very beautiful machine. You can see the drawings on the wall. It will make you comfortable. It will calm your nerves and relay your anxiety. So it's a beautiful technique for us to use. So you can refer your patients. Those are just our technicians there who are working on the machine. That's my references. Thank you.
Who rules the world? Who rules the world? Thank you so much. Tumeona leo all our speakers in the second session were all ladies. You guys, you are doing an amazing job. Makofi kwa kina mama. Makofi kwa kina dada. Makofi kwa bibi zetu. Makofi kwa dada zetu. You guys are doing an amazing job. Because of the interest of time, our cabinet secretary will be here at 3 p.m. I've been requested to close this session without any Q&A. Once we are going to resume here, I'm asking you if we can come back at around 2:30, maximum 2:40, so that we can resume and be seated before the cabinet secretary comes here. Once we come back, we take over, we proceed with the next presentation, Professor Njoroge and our sponsors, as we wait for the cabinet secretary to start the official opening ceremony. So lunch is going to be served at the public restaurant. You are going to be given your meal vouchers as you're stepping out. So please collect your meal voucher. Without your meal voucher and your registration card, you will not be allowed to have your meal. Please have them. Tuko na msosi tamu sana. Msikose chakula tafadhali. Enjoy your lunch.
Now, my presentation, you start with the MP4, the MP4. I'm the one coming next time. This one. Oh, yes. No. Yes, Professor George Njoroge. Yes, we have. But you start, there are two. You start with an MP4, which is a video. Oh, it was sent on the mail. Let me
Uko kuna table extra? Table. Jera, uko na meza extra? Uko kwako? Naweza leta hapa.
Ajabu.
Hapa. Haujaleta. Kuja. Nini hiyo? Toa hizi mawe hapa. Hizo maji, toa hizo maji. Signal ndo hizo. Iko sawa? Eh.
Ndio poa kwa hapo.
Iko hapo. Kwa nimekuja na iko mahali hapo.
Oh, ndio hii.
Nisikie kebo ya signal hapa chini. Ni ya signal hapa chini. Ni ya meza. Direct.
Muangalie na huko. Nikiweke kwa 1. Hii ya mwisho. unaweza nini kutoa hizo machaja.
easy. O God of all creation, blessed is another nation. Justice be assured our defender. May we dwell in unity, peace, and liberty, and to be found within our borders. Blessed is another nation. O God of all creation, blessed is another nation. Blessed is another nation. Justice be assured our defender. May we dwell in unity, peace, and liberty, and to be found within our borders. O God of all creation, blessed is another nation. O God of all creation, tupate na ustawi. Nimevipiga vita vilivyo vizuri. Nimevipiga vita.
The Lord's my rock, in him we hide. For speech of his, in him we hide. The Lord's thy rock, in him we hide. In the time of storm, my refuge, in him we always shelter in the time of storm. In a weary land, a weary land, a weary land. Oh, Jesus is a rock in a weary land, a shelter in the time of storm. Oh, Jesus is a rock, weary land, a weary land, a weary land. Oh, Jesus is a rock in a weary land, of storm. Shade by day, defense by night. The time of storm, no fears alarm, no fears of fright. Till in the time of storm, the Lord's my rock, in him we hide. In the time of storm, mighty rock in a weary land. In the time of no refuge in the time of storm. Be thou a helper ever near, shelter. Mighty rock in a weary land.
Hello. Good afternoon. Thank you. So today with me is Ann Kaunda, our language interpreter. Makofi kwa Ann Kaunda. So we'll be continuing with our afternoon session, which is a continuation of the morning sessions. We have some slight changes. We are going to bring earlier some of the speakers because of the program and they had to travel. So you'll allow me to kidogo call Dr. Mohammed Bilail. Dr. Mohammed Bilail. Oh, so okay. So Dr. Mohammed Bilail is my close colleague. We went to the same university back in Alexandria, Egypt. He's among the few breast specialists we are having. So yeye operation zote hajui, anajua only to operate breasts. So he's a specialist for that. He's among the few we have in Kenya. Makofi kwake. As you know that in KU Referral Hospital, we have a whole unit dedicated to breast care. It is called Breast Care Center. How many know our Breast Care Center? Amazing. So he's the one doing the amazing job. In a week, in a month, they are doing almost 30 cases, the highest in Kenya. 30 cases, 2 surgeons, the highest in Kenya. So that translates in a year almost 300 cases in a year. So that means a very high rate. Remember when we were given the numbers about cancers, which was the most common cancer? Breast. So he's the one taking care of them. So today he's going to tell us less is more. Because we all know that with breast cancer, a woman has to lose her breast. But that's not the truth. You can keep your breast and we do away with the breast cancer. Okay? So Dr. Bilail will take us through. Welcome, Dr.
Thank you. Good afternoon. Karibuni. I'm a boob doctor, kama mlivyoambiwa. So we'll start, we have a few minutes. So we're going to discuss and see how we handle the cases in KUTRH, especially when we're doing less surgery, which is called breast conserving surgery. So breast cancer, as we know, that is the most common cancer worldwide. It's the leading cancer also within our country here. And the incidence, they say that 1 out of 8 women is going to develop a breast tumor. So we should be aware that katika wanawake wanane, 1 of them is going to develop a breast tumor. That is a statistic. And then the incidence increases with age. But we differ. Here in our country, currently we see a lot of young breast cancer patients, which are the majority compared to the elderly. So there is a bit of changes. We are not like more off to the Western world. That is as per the Western world. But currently, Sub-Saharan Africa, even North Africa, we have tendency of having young women to be having high cases of breast cancer currently in our country. So surgical treatment. So there are different modalities which we do for surgery for a patient who are having a breast cancer. Long time ago, we used to be very aggressive, removing everything, the whole breast, together with the muscles surrounding the breast. So currently, there's some changes. So we'll see the history, how it was before, and how the things have changed currently. So initially, they used to say that breast is breast is a symbol of femininity. Every woman has the right to have a nice looking breast. So apart from doing taking care of the oncological aspect, we make sure also to have a good outcome, cosmetic aspect. The reason behind is if we can preserve the breast and the woman, some of them we remove the cancer and then we reconstruct the breast and look much more better than the way it was before. But the most important thing is we don't compromise the oncology aspect of the surgery. So a long time ago, we used not to be having any treatment. We used to say this is a systemic disease. So there was no surgery done, no anything. It said for a very long period of time, for over 500 years, there was like nothing will be done to a breast cancer patient. This is a systemic disease, so we just leave the patient to stay the way
there are. Just some other things were done, but there was nothing much on the surgical aspect. Later on, then later on, there was a physician by the name of Leonard's decided like, let burn. So imagine burning a woman is having a breast cancer, and then you burn that area. So it was very painful, and patient used to get a lot of infection. And then things changes. Later on, we had era whereby now surgeons were doing amputation of the breast, just removing the breast. So it changes from no treatment, and then later on burning the breast, and then later on amputating the breast. So there was some changes as years goes. So then there was that issue of Halstedian theory, said that the cancer spread anatomically through the lymphatic or direct invasion of the surrounding tissue. So with that, it led to the development of radical mastectomy. So this time, we used to remove the breast with the muscle surrounding around the breast, with everything, the pectoralis, latissimus dorsi, and everything. And it was, you see there, even you can see the ribs. Very bad cosmetic aspect. And then later on, now it started development of modified radical. Instead of removing the breast together with the muscles, now we just remove the breast and the axillary lymph nodes. So it was a bit safer for the patient. And then later on, apart from doing modified radical mastectomy, we developed technique of skin sparing, whereby we spare the skin, or nipple sparing mastectomy, and then skin reducing mastectomy. So the first two usually follow with immediate reconstruction. Or we can do delayed if there is a need of radiotherapy or other things, but we can do to either immediate reconstruction or delayed reconstruction. And the skin reducing mastectomy is more of like therapeutic reduction. Therapeutic reduction, therapeutic reduction. Is more of doing therapeutic reduction. So now the first two usually need reconstruction, either immediate or later on. But for the skin reducing is immediately. We just make it symmetrical on both breasts and everything becomes okay. So this is a skin sparing mastectomy case. You remove the whole breast tissue there, together with the nipple, skin sparing mastectomy, together with the nipple, and then later on we put an expander, or we put an implant immediately. Or sometimes you can do even tissue reconstruction with an LD flaps as such. So this is a case which I've done it here just recently. So imagine you see there initially the way it looked like, and then afterwards you see it's like nothing have been done to the patient. So we have removed the breast, and the same time cosmetically, and the patient, if you see her, if he's not going to tell you that I've been operated, you may say that there's nothing wrong with her breast. But this patient, we have removed the whole of her left breast. So we have retained the skin, we have retained the nipple, and now is okay. So we'll follow up with other treatment from the oncology aspect. So skin sparing mastectomy, I think we've discussed on that. Skin reducing mastectomy, so it's just more of reduction mammoplasty, or sometimes there's a new technique called Goldilocks mastectomy, which we are doing it at the moment here if the patient does not need an implant. So we do it also immediately. But with that type of surgery, we need to do symmetrization on the other breast. So this is skin reducing mastectomy. So how was the birth? The birth of the nipple sparing mastectomy? It was when realizing that the recurrence usually occur only at the area where they have removed the tumor. So they say that there is no need of removing the whole skin. Then we can spare the skin and the nipple, and that is when they develop the technique of nipple sparing mastectomy, in which we do it a lot here at the moment in our facility. So breast conserving surgery. So the good thing about breast conserving surgery, you just remove the part of the tumor with safe margin, and then you put clips, and there's no need of removing everything to the breast. It's just that is enough, and then the patient later on will go and receive radiotherapy, and the patient is going to be having her breast well preserved. So it was developed by Fisher, and they did a lot of studies, a lot of cases before it was acceptable, like comparing removing everything, mastectomy, plus preserving the breast, and to see how's the outcome in terms of recurrence and in terms of mortality. And we found out there is no difference in terms of recurrence and mortality. It was, everything is more of the same. So after that, then people started practicing. This is a study which it shows there's less difference. The margin is very, very small. So it is applicable if either you go for breast conserving or mastectomy. Although there are sometimes some patients, because they have very poor tumor biology, we might say that no, for mastectomy, for breast conserving, as per the experience, if we do that, we are going to get recurrence. So now we give them other ways of treating it, like nipple sparing with an implant or for immediate reconstruction as such. So these are criteria how we are going to choose for breast conserving. Not all patients we do a breast conserving surgery. So it depends when there's a very small tumor and maybe it's just located on one part of the breast, not like it having several lesions, several masses. So for such case, we avoid, or there is involvement of the skin, there is involvement of the muscle. So in such a scenario, we avoid doing breast conserving. So we go for mastectomy immediately. So some patient will come and say that, hey, Dr. Why didn't you do a breast conserving to me? You have done to my friend a breast conserving. No, it's not all patient fit for breast conserving. It depends. There's no skin involvement. There's no muscle involvement. There is not multifocal or multicentric. So with such cases, we do breast conserving when it is not having such contraindications. So also, if the patient fit for surgery, let's say patient cannot even stand for a long surgery, or maybe cannot stand for radiotherapy later on, and we know that if we do just mastectomy, this patient is going to be okay. Then we just follow with mastectomy for the patient. We avoid doing breast conserving, and then later on put the patient on radiotherapy. He's having some other issues of comorbidities, so we avoid doing breast conserving. That is one of contraindication. If patient is having comorbidities, heart issue and other things, we avoid doing breast conserving. We just do mastectomy to avoid getting radiotherapy. So it depends after multidisciplinary team. So contraindication, they say that pregnancy, not always. In late pregnancy, we can do breast conserving because after very few months, maybe it's going to deliver, then we can do radiotherapy for the patient. There's no worry on that. We call it a relative, not an absolute contraindication. So that is a multicentric tumor. If the tumor is you see it, and all the part of the breast there is masses. So that patient, even if come at an early stage and tell you that, Doctor, I need breast conserving. Oh, I'm sorry, I can't do breast conserving to you. What I'm going to do is mastectomy, or we can do skin sparing, nipple sparing, and I put an implant or expander to you. And that is applicable in our setup. And it has a very good outcome cosmetically. And also with oncological principle, is fine for the patient. So if it is a multicentric, I mean diffuse calcification, sometimes you find the patient is maybe 30-something, 35 or 30, is having a breast cancer, and the mass is only 2 centimeters. A surgeon say that I want to go and do breast conserving surgery. Without doing maybe a mammogram or MRI to confirm there is no diffuse microcalcification. So if you end up doing breast conserving surgery for such a patient, you have done, I'm sorry to say that, you have done a crime. Because at the end is contraindication. Not even relative, is an absolute contraindication for the patient. And if we have done surgery first and then you find this positive margin, and then you go for another surgery, you get a positive margin, we are really sorry. And if such a case happens, there is indication for mastectomy, either skin sparing or whatsoever, but we have to remove the whole breast. But not always, it happens very rarely. For us, it's less than 1% of the cases we get positive margin. So at least we have a good outcome on our side. Despite we don't do frozen sections, but we thank God we have good outcome on that. So traditionally, we used to make incision on top of the lesion. So cosmetically, it was not such good. Some women develop some, like, if the tumor is big, we say tumor to breast ratio is big, they develop like a dimpling, like Kashimo hivi. So if that happened, the woman said that, I know you have done breast conserving, but now you see there's chemo here. So cosmetically, it was not good initially. So the traditional breast conserving surgery, it was just on top of the lesion. You can see it. Just on top of the lesion, we just we make incision on top of the lesion. So cosmetically, sometimes it was not good. Not unless it's very small lesion, it's okay. For elderly, they'll say no worry for that scar. But for young women, especially, we get a lot of young patients say, hey, baba, hii sasa umeharibu mali. So currently, we use new techniques. The hidden scars, you guys just go around the areola or the inframammary. So those scars, it helps to, it become hard for the people observing, which is, is the husband, the boyfriend, or whatever. So it become like, it's hard to even can wear the stuff for beach, yeah, and enjoy your life. So you see, those are hidden scars. So this one is recommendable. But some scenario, even that cannot be applicable. So we go for other techniques. You see, like that. That is a breast conserving, yeah? On top. So most women, they say what? I don't like that. So now, because we are breast surgeon, the oncoplastic, we apply both the oncological aspect and the cosmetic aspect, the plastic aspect. So we have changed some things. They say that after traditional breast conserving, 20 to 30% of the patients were reported to have poor cosmetic outcome. So now what happened, we go for the oncoplastic. Still, we just make sure we preserve the breast. So this one, we apply the principle of the oncological principle plus the plastic principle to make sure that we get good outcome. So there are different techniques. I think that's not, so I can just go directly. So you see, this patient has undergone a breast reduction and was having breast cancer on one side. So we do it at the same time, we do reduction of the breast. So the patient is going to have, we say that a better breast than they were before in terms of cosmetic aspect. So the patient is getting treated for cancer and at the same time is getting reduction. So you see, sometimes some things come with some other things. So you see, like a scenario, this patient came, is one of the patients who operated, came with a cancer on this side. And said that, I don't want to lose my breast. So what we end up, we did something where we raised a flap there. It's called ICA flap. And then we remove that breast, that tissue there. And then we put that flap inside there and then we close. And then the final result was like this. You see now. So the patient would like not to get a mastectomy. So we can do even total reconstruction. So there are different techniques for oncoplastic. These are different techniques we apply in our setup here and other part of the world. So this is a butt swing technique. Also, we have we preserve. This is one of our patients. We have a Grisotti technique, whereby if it is involving behind the areola, so it used to be a contraindication for breast conserving, but currently we do it as an oncoplastic technique for the patient. See, this is one of our patients. So there's a round block technique which can be applied for both benign and malignant cases. You see, such a case is a round block technique. It's one of our patients. This after so this is one of our patient, not from this is a patient from Mombasa, has a very huge giant fibroadenoma, And he said that I don't want to lose my breast. Because even if you do the normal way, you'll put a very bad scar. So imagine the mass was bigger than the remaining breast tissue. So after doing that, you see now the outcome. Even you'll not know there is a scar there. So this is another one we did here. It was a breast conserving. You see there's no scar, and the patient has undergone a cancer surgery. This is another patient. These are just inflammation. Will come. It will fade away as time goes. This is not ours, but this is another technique. This is one of our patients here. So it depends on the site of the tumors. Not all technique you apply to all patients. Yeah. This is another patient here. You see this another case. This is not ours. Imagine, see this woman here. This woman was from another place, from Mpeketoni. And he said that hii tolewe kabisa hii imekuwa ndefu nenda kama magoti. So he said that it's okay. We remove that lesion. We did a biopsy, it turned out to be benign. So we did a reduction, mammoplasty, on the one breast. And this is the results after 1 month. You see, so you see, you even give hope for the woman. This is another woman, had a breast cancer on one side, this side. So this is what we did. It was here in KU. This is another woman. These are not reduction. These are patient with tumors. These are patient with tumors, with their cancers. This is another one. You see. And then this, the results. You see, this woman was like this, and now. So, okay. Cosmetic outcome was acceptable in more than 90% when you apply oncoplastic techniques, not just the traditional breast conserving surgery, okay? And the most important thing, round block is the best, okay, it's the most, I love that technique, the round block technique, but it differs surgeon to surgeon. So that is just for the sake of my fellow younger colleagues. Okay, now, okay, axillary lymph node dissection. This is a topic of Moki. So I was a colleague of mine to discuss on this topic. I'll just spend like 2 minutes. Usually we do management of the axilla. So it depends. We remove level 1 and level 2, but it depends on case to case. If sometime we do sentinel lymph node biopsy, we just remove 3 to 5 there, mostly 3, and we check if they're benign. For axillary lymph node dissection is when there is suspicious nodes or a confirmed axillary nodes with mets, then we always do level 1 and level 2 dissection. But when we do scanning and they shows there is nothing, then there is no need of doing axillary dissection to avoid lymphoedema. We end up doing sentinel lymph node biopsy. There are different techniques to do sentinel lymph node biopsy. There is by use of blue dye, there is by use of radioisotopes, and there is other gamma probe techniques currently we have. I think we are supposed to be having this thing here at integrated molecular imaging stuff. I hope so. We are going to be applying that in future. So currently, we practice sentinel lymph node biopsy when there is no suspicious nodes on the side of the cancerous part of the breast. Okay? We do axillary lymph node dissection when there is suspicious nodes. So not all women, we do axillary dissection. If you go to European countries like UK and you do axillary dissection for a woman who's deserving to get sentinel lymph node biopsy, you can be sued. So that one we practice it here at KUTRH. Not all women get axillary dissection at the moment. We try as much as possible to get less cases of lymphoedema. And there is new studies. I stand to be corrected by Dr. Abed and the other oncologists here. They say that currently we can avoid doing axillary lymph node dissection if we have good tumor biology and ERPR positive, HER2 negative, low Ki67, a tumor of less than 2 centimeter, and a woman who's more than 65 years of age or menopausal, so that one unaweza ukafunga macho ukasema sasa, and you're expecting a whole breast radiation maybe such, then unaweza kumwambia oncologist, now I will not do ocular dissection based on this study and based on this, but we don't practice mostly here in our setup, but it's currently practiced in other parts of the world. Thank you so much. I really appreciate it for the time you have given to me. Happy day.
There's something wrong. Mmepiga makofi bila kuambiwa. Dr. Bilal was advertising here. Naona makofi na wengi wamepiga ni wanawake. Makofi tena kwake. Naona mmefurahia, magoti yamepunguzwa yanaletwa kifuani. I think hiyo pia imefurahisha watu zaidi. So kwa wale ambao pia wanajiona hawako sawa, sijasema kitu. Nimesema kwa wale ambao wanajiona wako sawa, pia tunawafanyia matibabu. Bai hawako sawa, kuna watu mashallah wamebarikiwa na vifua. So ile pia ni ugonjwa. Sio ugonjwa, si kansa peke yake. Tumefahamiana? Kuna watu wamebarikiwa na vifua vikubwa. So what happens because of the big breast size, what we call gigantomastia, they experience a lot of pain on their chest and on their back. If you have seen anyone, just try to talk to them. It's not funny. You might be making fun of them. They're having big breasts and everything. So we are also doing what we call reduction mammoplasty to ensure like tunaziregesha wanasema saa 6 kamili. Then uko nje mambo inakuwa mazuri kabisa. Sawa sawa? Okay. I would like to change gears because I think Dr. Bilal, if I give you 1 hour, people will be happy. We'll now move to the next speaker who needs no introduction. Nani hajui Professor John Njoroge? Ambaye hajui anyoshe mkono. Ya kami? Nimesimamishwa. Nimeambiwa waziri anaingia. Endelee. No, I wanted to call the next speaker, so I should not. Should I call this next speaker? Ama we stop? Should I call the next speaker? Ama we stop? Huh? Okay, sasa naomba tusongee mbele kidogo. Tusongee mbele kidogo. Hii upande huu, tusongee mbele kidogo. Hii kuja katikati. Hii kuja katikati. Yeah.
Good afternoon, ladies and gentlemen. I would ask that we all be upstanding. I'm well informed that we had a very sumptuous, heavy lunch, and I would like us to just engage all our appendages to be in a movable state as we welcome the CS. So let's all be upstanding. DJ, I hope you're ready for me. Our last presenter who showed us very nice tea. I say the first T, you'd say the next T. You showed us very nice tea. Ah, wonderful. So I would like us to just remember, he said, depending on where you went to school, one of the presenters said, depending on the system that you went through. So we want to see, which system did you go through? Did you go through the CBE? Anyone here who has gone through the CBE? None. Aha. The 844. Do we have people who have gone through the 844? Show of hands. Ah. And the system before the 844. Let me call it that. Anyone who has gone through that? Ah, nice. Wonderful. So DJ, let me see what we have. So I hope you're ready. So let's do a small stretch as the DJ puts it on. Left hand up. Left hand up. Left. I can see some people with two left, or is it light? So check if your neighbor has a left hander. DJ, give me. Nipe sasa. So right hand up. Right hand up. So we do left, right, okay? So let's go. You can sing along. Let's see if you went to that school, Let's turn to the left. Turn to the left. Wonderful. Are you ready? So I don't know which school you went to. Check your neighbors to just judge your school, How many know this one, Let's go like this. Hapa tunakumbuka baba, Now let's go. Head, shoulder. Nishikie kidogo. Kwani kuna watu wako na ears huku? Hey, I'm seeing ears. Nirudishie hapo kidogo. So let's go. I hope you are ready, So tushike head, DJ akirudisha nyuma kidogo. Haya, twende. Head, twende. Head, shoulders, knees and toes, knees and toes, knees and toes. Head, shoulders, knees and toes. Ears, mouth and nose. Twende tena. Head, shoulders, knees and toes, knees and toes. Head, shoulders, knees and toes. Wonderful. Thank you. Thank you. Have your seats. So we welcome on stage the KUTRH choir. For those that are not aware, we have the staff choir. It has more membership than this, and I'm actually also a part of the choir, and we welcome you to join this choir. And today we'll have the next session. We'll have the choir giving us the national anthem, the East African anthem, and also a song that they have prepared for us. So let's all bear with the team as they arrive and as we start the next program. So ladies and gentlemen, remember we have breakout sessions for our conference. Make sure you look at your booklet, and we will give guidance on the breakout sessions depending on the time, so that some of the presentations that have not been given, we have a presentation by Professor F.G. Njoroge on esophageal cancer. Please stay put as we have that, and we believe you will have it in the right way. So choir, please, as I'm told those who did 844 felt left out. DJ nishikie kidogo. I'm told those who did 844 and a bit of the CBE felt left out because the last time they did the head shoulder was many years ago. So they asked for something more recent. So I'll ask that we all be upstanding. And let's exercise our bodies for the next afternoon session. Movement is key. Movement is health. So tell your neighbor, the more you move, the more you live. And the other neighbor, tell them, the more you live, the more you move. Okay, wonderful. So just find out where wanaishi wapi. So I'm told unaanzanga Githurai, kutoka Githurai unaelekea Roysambo. As you move on, unajipata uko at the river. The more you live, the more you move. Unaanzia Kenya, unajipata UK, then unajipata US. The more you live, the more you move. Okay, thank you. Nipatia DJ. So I want us to do a small match. We were doing this before in honor of Baba. How many remember Baba? Are you ready for Tuesday? Are you ready for the CS? Tunasema ni broad face. Kama na gani? Wonderful. Aha. So tunaenda mikono juu, tunaenda mikono chini, tunaenda mbele, tunarudi nyuma, tuna dance kidogo. DJ nirudishie mwanzo. I hope you are ready. Haya. Anaambiwa Iani, anaambiwa tunamjua, si ndio? Wangapi wanajua Iani? Wonderful. So let's go. Mikono juu. So we follow the instructions. Yekwe juu. Zungusha miguu. Twende mbele. Rudi nyuma. Haya, dance kidogo, zungusha kiuno. Check if your neighbor has a waist. Check whether they have a waist. Physically fit. Are they physically fit? Wonderful. I hope you are ready. Now I want us to do a special one. Unashika hivi ni kama umelipwa kama umelipwa mshahara leo. So let's go like this. Then una lean nyuma kidogo. Lean nyuma kidogo. Hiyo ni mtu amepata mshahara end month. Haya, kuja mbele kidogo. Enda sideways kidogo. Hiyo ndio position ya surgeons wakifanya surgery. Wonderful. Enda the other side. Enda the other side kabisa. Chini kidogo. Hiyo ni ya researchers. Wonderful. Have your seats. So again, ladies and gentlemen, welcome to our second annual scientific conference. This is the KUTRRH annual scientific conference. Again, I refer you to our booklets for our theme for this year's conference. What is the theme for this year's conference? Care without gaps. Check whether there is a gap between you and the person sitting next to you. Close that gap. Tukikaribia mbele. Yeah, audience also without gaps. So we want audience without gaps. So thank you again for coming. Please bear with us on the timings as we welcome the Cabinet Secretary for Health and all the protocols observed. DJ, just give me something as we await the arrival of the CS. Karibuni sana.
Kwa mziki ni mnoma ni fire, wasupa ni wengi wanadmire. Hii nyingine mwecheche na ni mbaya ni ya kipedeje. Weka dance twende, mikono juu, mikono juu, mikono juu, mikono juu. Sibaki hapo juu, one leg zungusha miguu. Alafu twende mbele.
As we await the arrival of the delegates, make sure you speak to the person next to you to know where they are from, their department or directorate, their specialty. And since June was Men's Mental Wellness Month, and then May was the Mental Health Wellness Month, ask them, how are you doing? Just ask your neighbor, how are you doing? And don't expect the normal fine. Don't give the normal fine. And once they answer, let them also ask you the same.
Nani mbaya ni ya kipedeje, weka dance twende. Kwa majina ni yani nakujua, we waka waka waka. Mikono juu, mikono juu, mikono juu, mikono juu. Sibaki hapo juu, one leg zungusha miguu. Alafu twende mbele, rudi nyuma, dance kidogo zungusha kiuno. Twende mbele, rudi nyuma, dance kidogo zungusha kiuno. Physically, physically fit. Madem wana wine wako physically fit. Physically fit. Ngoma zangu leo zote ziko on repeat. Have I ever seen you before? Are you here with somebody? Sexy girl, how you wine on the floor? You kill me with your body. Happy people, no depression. Wake a dance, punguza tension. Easy moves, so take the lesson. Kani noma kwa story mention. Hii nyingine mwecheche. Nani mbaya ni ya kipedeje. Weka dance twende. Mikono juu, mikono juu, mikono juu, mikono juu. Sibaki hapo juu, one leg zungusha miguu. Alafu twende mbele, rudi nyuma, dance kidogo zungusha kiuno. Twende mbele, rudi nyuma, dance kidogo zungusha kiuno. Ni mbaya masi mbaya, hii nyingine fire. Ni mbaya masi mbaya, wakitucheki wanagwaya. Wakiuliza eti mimi ndio nani, tunawajibu kwa majina ni yani. Wakiuliza eti mimi ndio nani, yule msanii ataleta Kenya Grammy. Washingo ni nyingi mawaya, na dopa ni genje ni mbaya. Kwa mziki ni mnoma ni fire, wasupa ni wengi wanadmire. Hii nyingine mwecheche, nani mbaya ni ya kipedeje. Weka dance twende. Mikono juu, mikono juu, mikono juu, mikono juu. Sibaki hapo juu, one leg zungusha miguu.
Remember again, ladies and gentlemen, we are live on YouTube. We are live on YouTube and all social media handles. Follow us at KUTRRH on all social media handles and at KU Referral on Instagram, at KUTRRH on at KU Referral on Facebook, at KU Referral on Instagram, and at KUTRRH on X. And on YouTube, the video is live. So keep smiling because you may never know, you might be in the view of the online video.
Shakira, we are ready.
We are ready.
We are ready.
We are ready.
We're ready.
We're ready.
We are ready.
We are ready.
We are ready.
We are ready.
We're ready.
We are ready.
We are ready too.
You knew from the day you were born that here in this place you belong. You've been this brave all along. What broke you once made you strong. Die, die, equal, darling, life, let's go. Die, die, equal, darling, life, let's go. Sweat and blood to write your story. That is how you pave the way. You're about to reach the glory. Only one step away.
All the highs and lows, all the tears and the pain.
You've been there through it all, been through it all. Just do it again. Now you get to believe, I believe. Cause you know what it takes to believe in my dream. At the top of your game. Feel it, got everything you need it. Now bring it like you mean it. Just like you mean it. Dale, olvídalo que vale. Juega como tú sabes, como tú sabes. And it's just contagious, you know.
And it never fades. No one's getting tired.
I know. You got that fire. Hey, yo, keep me a little higher. Let's go, let's go, let's go.
Shakira, we are ready.
We are ready.
We are ready.
We are ready.
We're ready.
So
We're ready.
I would
We're
like us
ready.
to be
We're
all
ready.
upstanding.
We are
Let's
ready.
all
We
be
are ready.
upstanding.
We are ready.
We are ready too.
Let's all be upstanding. DJ nianzishie kutoka mwanzo. Ask your neighbor, are you ready?
Shakira,
Ask
we
your
are
neighbor,
ready.
are you ready?
We are ready.
So we are doing
We're
this
ready.
the World
We're
Cup
ready.
way
We're
as we
ready.
welcome the
We are ready.
CS.
We are ready.
Okay?
We're ready.
We
So I
are
want
ready.
us to hold the ball in front of us. I don't know how many of you know the pepeta dance. Okay, are you ready? So take your ball, everyone, take your ball.
Ready.
We are ready.
I
We are
take my
ready.
ball.
We are ready.
We're ready.
I
We're ready.
put
We
it
are ready.
here.
We are ready.
We are ready.
I
We are
pepeta.
ready.
I
We're ready.
pepeta.
We are ready.
I pepeta. Are you ready?
Ready too.
So you go as per the beat, eh? So take your ball. Put it there as you pepeta. Are you ready? To the beat. We pepeta to the beat. Wonderful.
Here in this place you belong.
The right foot, eh? Just check if your neighbor is on the right foot.
What broke you
Now let's go to the left foot.
made you strong.
Twende. Left foot. Pepeta. 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 Are you ready to score? Are you ready to score? Aya. Anakwenda na mpira na score. Ba. Care without gaps, eh?
Your desire, when there's a will, there's a way. You're the owner of that fire. No one can take it away.
Wonderful. So, ladies and gentlemen, we'll start with our prayers. We'll have the national anthem and we'll have the East African anthem. Kindly have your seats as we await the arrival of the CS.
You've been there through it all, been through it all. Just do it again. Now you got to believe, I believe. Cause you know what it takes to believe in my dream. At the top of your game.
Ladies and gentlemen, I would request that we all be upstanding. Let us all be upstanding. I want to teach you something small as we continue with our program. Let's all be upstanding as we continue with our program. Now, I want us to do is it a round of applause or is it a loud of applause? Round or loud? Is the applause loud enough or is it round enough? Wonderful. So I want us to clap. Let's clap. Let's give a round of applause. Let's give our claps as we are upstanding. Wonderful. I want us to clap the sign language way. Do you know how to do it the sign language way? Like this, eh? Wonderful. Let's all be upstanding. I would ask that we all be upstanding. Wonderful. How do you say thank you in sign language? So you start at your chin. So I want us to start at our chin. Then you have the other hand placed down so that you take that hand to the other hand. Just like our choir. Let's follow our choir. Thank you. And how do you say welcome? So we say welcome. Wonderful. So we'll have the CS joining us. And we have his team with us. And we'll tell him welcome. Then we'll give him a round of applause. And then we do the normal clap. Are you ready? So let's do the first trial. So we do welcome. Then round of applause. Then the normal clap. Wonderful. Many claps, eh? Ile makofi ya mvua. Tufanye makofi ya mvua kidogo. Let's do a trizex. Inaongezeka. Inaongezeka. Mvua inaongezeka. Inaongezeka. Radi. 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 Wonderful. I can see you're a great team. Let's remain standing as we welcome our chief guest. I'd like to give the apology on behalf of the programmer as we do our welcome remarks. Tell your neighbor all protocols observed. Ask him, what is your protocol? Do people stand when you enter? I'm given the story of a man known as Jeff Koinange. And I'm well informed, akiitisha bibi yake chai anamwambia, mama watoto, leta chai. Today I'm here on JKL Live, hapa nyumbani kwetu. So we all have our small palaces. Ask him, where is your small palace? Yeah, so we thank you for bearing with us, even as we welcome our chief guest. Today we've done enough exercises. I do ask that you take your seats. I promise that is the last time. The last time. Yeah. And I normally keep my promises. As promised for one last time, please stand. So, ladies and gentlemen, let us all welcome the Cabinet Secretary of Health, Honorable Aidan Duale. As we said, we say welcome. And then we do the applause. And then makofi ya mvua. Welcome the chief guest and all protocols observed. The national anthem by the Kutrrh choir.
Justice be our shield and defender. May we dwell in unity, peace and liberty. Plenty be found within our borders.
Ask that we remain standing for the next session of prayer as I welcome Dr. Caroline Ngugi for the next session. Dr. Abeid and our chaplain, karibuni sana for the opening prayer. Dr. Abeid, please.
Shukran. Naweza kunita Sheikh Abeid pia, sio Dr. Abeid peke yake. Thank you so much, Shem. I'm glad here to have all of you here. We are going to pray in Arabic, that is traditionally in Islam. So we'll start with Surah Al-Fatiha. Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alameen. Ar-Rahmanirrahim. Maliki Yawmiddin. Iyyaka na'budu wa iyyaka nasta'in. Ihdina as-siratal mustaqim. Siratal ladzina an'amta 'alayhim ghayril maghdubi 'alayhim waladdallin. Amin. ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار اللهم سهل لنا ما نريد ونجنا ما نخاف يا لطيف الطفنا يا لطيف يا لطيف اللهم سهل لنا ما نريد ونجنا ما نخاف فلسبحان ربك رب العزة عما يصفون والسلام على المرسلين الحمد لله رب العالمين.
We continue in prayer. O God of all creation, we've gathered here and we want to acknowledge that you are the source of all wisdom. You are the source of health. And Lord God, as we gather here, want to pray for the minds, oh God, that are a source of hope, are a source of help and health for many people. Lord God, we thank you for Kutrrh that has been a beacon of pillar and hope for many lives. As, Lord God, the second annual conference commences and progresses, we want to invite your holy presence, believing that, Lord God, you are the source of health, and we want to pray that let your light shine, that light that cannot be overcome by darkness. As this meeting commences, Lord, we pray for new and unique ideas that will restore health and hope again over the lives of the people. For everybody involved, the leading scientists, doctors, as well as the multidisciplinary teams, want to pray, Lord God, that you guide and direct over the government officials, the leadership of this institution, Lord God. Let your power overwhelm us. And we want to pray that to the success of this meeting, the glory and honor of your name. And this we pray in Jesus' mighty name. Amen.
Good afternoon. I would like to request our partners who are with us, your seats are here. Dr. Moko, if you have any partners outside, please request to come and sit. Taki and the team. So, the Cabinet Secretary, Ministry of Health, Honorable Aden Duale, the Principal Secretary, State Department of Science, Research and Innovation, represented here by Dr. Rosalie Owor, the Director General Health, Dr. Patrick Amoth, the Director General Ministry of Education, Dr. Elias, our Chairperson of the Board, Mr. James Kibugu Wambu, KUTRH, board members present, represented here by Honorable Leonard Sang, our Chief Executive Officer, Dr. Zainab Gura, the Director Special Needs of Education, Mr. Frederick Hager, the Director Ministry of Health, Dr. Andrew Toro, all KTRH management present here, our directors present, and all our partners. Allow me to recognize CHAI, who are represented here by Deputy Country Director Rosemary Kehoto, KISE, represented by Director Norman Kiogora, Staki Technologies, who are represented here by the Managing Director Nitin Gupta, and the Sales Manager Roslyn Degwa, Kenya Society of the Deaf Children, represented by the CEO Madam Rhoda Kabiti, and all our partners who I may have missed out. Ladies and gentlemen, good afternoon. Good afternoon. I think the knowledge has been too much, but I am happy that we are filled in a room, and we have walked into this room, a room filled with energy, a room filled with passion and expertise. When I look around, I'm seeing our experts. And I'm happy to know that even tomorrow, and by the end of tomorrow, we'll have born new ideas, we'll have born new partnerships, and we'll have new solutions which will help us serve the people we love and the people we are here for the most, who are our patients and Kenyans. So it is with great pleasure, as the Director, Training, Research and Partnership, and the Chairman of the Organizing Committee for the second KUTRH Annual Scientific Conference, to welcome you all to this opening ceremony. Our guest and our chief guest, we must say, as we mentioned earlier, the program started in the morning, but we deliberately reserved this special ceremony so that we can have an official launch or opening ceremony, and of course, graced by our chief guest, who's our Cabinet Secretary for Health, and all our distinguished guests. So we are truly honored to have you here. I will say, ladies and gentlemen, that our theme this year is Care Without Gaps, discussing on holistic pathways to universal health care. And I will say that there could hardly be a better fitting demonstration of this theme than what we have experienced this afternoon. Before the Cabinet Secretary joined us, I know we were all waiting for him. He visited the hospital to officially launch the Ear Clinic and Hearing Aid Fitting Center, which is a significant milestone for KUTRH. So that's why we've taken a bit longer. And indeed, it's not just a milestone for KUTRH, but it is a big milestone for those of us who work at KUTRH and our families and partners. My community, I call them, those with magic hearing heroes. I actually call them my tribe, but I don't want to be tribal. So they are the people who live with magic ears. Some of us are blessed to have 4 ears or 3 ears. I know most of you have 2, but some of us are truly blessed to have 4. And I must say it works better than those of you with 2. So it is a milestone for us, and we are really happy. So I was saying today, I came earlier, if you allow me, Chief Guest, I forgot my hearing aids at home. So when I walked in, I came to this side, there was so much activity, everybody was talking and I was lost. So I told my people here, and I went and sat in my office until they were delivered. So indeed, hearing is not just a sound, but it is a connection to your family, a connection to everybody. Imagine sitting here and you can't hear what we are saying. So it is a connection to life itself. That's how I consider it. So it is a great milestone for us. So this conference is an opportunity to discover and discuss how remarkable technology has become. When I talk about technology, we had Starkey people here, and they have the new hearing aids, and I was amongst the first beneficiary. And I said they work like magic, because when I walk here, when there is too much noise, it reduces for me the noise. When I can't hear you, it increases for me the noise. So my ears work, our ears, my community, magic ear people, our ears work better than everybody else's, isn't it? Yes. So all I can say is that as much as they are magic ears, they leave a deep debt in the pocket. So the wallet is not happy. But seeing this engagement here today, we've had very good discussions and bringing in everybody. We have the technology people Starkey with us. We have the policymakers. We have the doctors. And of course, we have our big boss, the CS Cabinet of Health. And we've had good discussions on how to support those of us with magic ears, to ensure that they are easily accessible and affordable. Because that debt in the wallet, I must say, for the years I have worn them, it has been huge. But we are happy that this conversation has started. So having said that, this is exactly what this conference is all about. So over the next 2 days, Honorable CS, we shall share research, innovation, and experiences. And all of this is for one goal, which is to strengthen health systems and improve patient outcome. So it is our hope as the organizing committee, the steering committee, and as the KUTRH management, that we will spend these 2 days discussing, and we will have better conversations by the end of 2 days and better solutions for the things that we are seeing in our health systems. So with that, welcome once again to our second KUTRH Annual Scientific Conference. And I would now like to welcome our CEO, Dr. Zainab Gura, to give her remarks and take us through the next steps. Karibu, CEO.
Thank you. Our Cabinet Secretary for Health, Honorable Aden Duale, the representative of the PS State Department for Science, Research and Innovation, Professor Shaukat, our Director General for Health, Dr. Patrick Amoth, our Chairperson for the Board of Directors of KUTRH, Mr. James Wambo, all the members of the board present, researchers, healthcare professionals, development partners, distinguished guests, ladies and gentlemen. Good afternoon. It's our great honor to welcome you all to Kenyatta University Teaching, Referral and Research Hospital. Today marks a dual milestone for our institution as we launch the second annual scientific conference and also witness a transformative milestone in our ear and hearing care initiative. I want to extend a warm welcome to our chief guest, our Cabinet Secretary, and thank you, sir, for accepting to grace this occasion and for your unwavering commitment to Kenya's healthcare agenda and for taking time to join us this afternoon. Already this afternoon had been very impactful as put forth by my colleague, our Director, Research and Partnerships. Indeed, we are committed. We are committed in terms to make sure that we achieve universal health coverage. And what we've witnessed this afternoon is in the true spirit of leaving no one behind. KUTRH is on the pathway of making sure that we have comprehensive hearing rehabilitation center that emphasize on pediatrics care. We have participated in various school screening programs, and as highlighted, we've been able to reach over 9,000 children. We are able to fit 109 hearing aids, and we will walk this journey together with our leadership in the ministry and our partners as we've done. These partnerships, this achievement in ENT is part of the larger ecosystem, our CS. It is part of our data-driven, cutting-edge care that we provide in this facility. And we'll strive to make sure that we provide the healthcare that is needed in Kenya as per our agenda, the ministry. To put our growth into perspective, over the last year alone, we have achieved various medical milestones. In ENT services only, we've served over 2,500 specialized ENT cases and procedures and 450 highly specialized surgeries. In cardiovascular, our CS, we are conducting open heart surgeries, and we've done 29 so far, and these are surgeries that where you do one in a day. We have had extensive diagnostics. We have cutting-edge imaging and diagnostic center, both the lab that is ISO certified. We conduct over 350,000 diagnostic procedures annually and over 50,000 radiology requests. In our molecular imaging, we have done so far 5,600 PET scan procedures. And indeed, these are procedures that are fully covered by SHA. We strive to continue having oncology excellence. We've conducted over 18,000 radiotherapy sessions, 17,000 chemotherapy sessions, again covered by SHA. So we have CyberKnife, which is a precision treatment for cancer, which is the only one in sub-Saharan Africa. So far, we've done over 250 CyberKnife procedures. Indeed, this cannot be done seamlessly without the financial support and access that is provided through the Social Health Authority. This data brings us seamlessly to the second agenda for the day, which is why we are here now, the launch of our second annual scientific conference, which will run today and tomorrow. And this conference is much more than an academic gathering. It is a vital convergence of knowledge, experience, and innovation. Indeed, we are living to make sure that we provide our triple mandate of providing clinical service, training and teaching, and research. And you cannot do research because at the end of it all, why do research if you can't disseminate? Why do research if you cannot engage? Why do research if you cannot share so that it is utilized both for decision making at clinical level, but most importantly, for decision making at policy level? Every medical breakthrough, every policy shift, every clinical advances, therefore begins with curiosity, evidence, and collaboration. Therefore, platforms such as this one today provides research and moves it into practice, innovation into impact, ideas into improved health outcomes for our people. Healthcare landscape therefore continues to evolve rapidly. Advancement in technology, emerging health threats, rising disease burdens, and changing patient expectations demand that we adapt, that we innovate, and we respond with agility. We have to research, we have to be curious, and we have to find out what is the next best intervention so that we can provide the best outcome to Kenyans as they seek healthcare. It is not only for clinical treatment, sir, it is also for prevention. We need to research for prevention so that we can close the tap upstream. At KTRH, we recognize that innovation is no longer optional, it is therefore essential. Under this year's theme, Care Without Gaps, Holistic Pathways to Universal Healthcare, we challenge ourselves to rethink healthcare delivery by embracing integrated, inclusive, and patient-centered approaches. Universal health coverage can only be achieved when prevention, diagnosis, treatment, rehabilitation, research, technology, and compassion are seamlessly connected. We have 6 themes for today's and tomorrow's conference. We have the first one is integrated critical care, and this emphasizes the multidisciplinary collaboration in emergency and intensive care. As a specialized facility, this is one of the services we provide exclusively. In oncology and non-communicable diseases, the second theme, indeed, it is one of the rising burden in our country, and therefore we have to talk, we have to research, and we have to discuss. Mental health and well-being is increasingly becoming a challenge that we have to discuss how it becomes accessible, how it should be stigma-free, how to recognize innovations that will make service seamless. Infectious disease and community health is the fourth theme. Infectious disease, even as we have rising burden of non-communicable diseases, remains our problem that we have to reinforce surveillance, that we have to build resilient public health systems and treatments that provide curation. The fifth is maternal and child health care. Ensuring safe motherhood and healthy childhood is fundamental to our healthcare. The sixth, our chief guest, we want to discuss artificial intelligence. We want to discuss digital health systems. We want to connect it with innovation. So our sixth theme is artificial intelligence, digital health, and innovation, to make sure that we harness it to improve efficiency, to make sure that we leverage on technology as we provide the clinical decision making to our health workers and policy decision making to our policy makers. We therefore don't believe in scientific discoveries should be confined to publications. We believe that it should be shared and discussed. It should inform decision making. To support this, we have deliberately implemented a functional research partnerships and collaboration framework, and I'm proud to share that in a short period of 1.5 years, we have 7 ongoing research collaborations with 12 approved projects actively in progress at the hospital level. We have also put in place research infrastructure recognized by NACOSTI, so that we can now increase our collaborative research and partnership with all major players in this field. As we commence this conference, I encourage every researcher, every clinician, every policy expert here to engage actively and share insights openly. I will now invite our next speakers, and it is my singular honor and privilege to invite our board of directors, the chairperson of our board of directors, to make his remarks, and welcome our other guests. Welcome our chair of the board of directors, Mr. James Wambo.
The Cabinet Secretary for Health, Honade Ndore, our Director General for Health, Dr. Patrick Kamoth, our Director General for Special Education, Fred Hunger, Chief Executive Officer for Kutrrh, members of the Board of Directors present, research scientists and healthcare professionals, development partners, distinguished guests, ladies and gentlemen, good afternoon. It gives me great pleasure and a profound sense of honor to stand before you today as the chairperson of the Board of Directors of Kenyatta University Teaching, Referral and Research Hospital to officially welcome you to the second annual Scientific Conference 2026. I wish to begin by expressing my sincere appreciation to our chief guest, the Honorable Cabinet Secretary for Health, for gracing the occasion, and the government's continued commitment to strengthening healthcare system and advancing universal health coverage in Kenya. I also extend a warm welcome to our distinguished guests, delegates, researchers, clinicians, academicians, and partners who have joined us for from across the country and beyond, demonstrating a shared belief and knowledge that knowledge, innovation, research, and collaboration are fundamental to transforming healthcare. Our guest, this year's conference themed Care Without Gaps, Holistic Pathway to Universal Healthcare, is both timeless and very formative. It challenges us to move beyond fragmented models of care and embrace integrated, patient-centered systems that ensure continuity across the entire health journey, from prevention and early detection to diagnosis, treatment, rehabilitation, and following up to care, so that no patient is left behind in accessing quality health care. Since establishment of our institution has remained guided by clear and compelling vision for to be the world-class teaching, referral, research hospital that delivers exceptional patient care, address medical science, and contributes meaningful to the national development. The vision continues to guide every strategic decision we make as a board, from investment to infrastructure, cutting-edge technology, to strengthening governance system and developing human capital. In line with this vision, we're in the final stages of launching the amenity wing, a modern private wing that will significantly enhance our capacity to deliver differentiated high-quality care. This facility will go a long way in ensuring that we cater to patients across all segments of the society, including those within the corporate sector and individuals seeking premium personalized services, with upholding the highest standard of comfort, privacy, excellence, and excellence. It reflects our unwavering commitment to inclusive responsiveness and sustainable health delivery. Ladies and gentlemen, as a level 6 national referral hospital, Kenyatta University Teaching Referral and Research Hospital occupies a unique and critical position within Kenya healthcare ecosystem. We're in the center of hope for patients and with complex and specialized conditions, a training ground for the next generation of healthcare professionals, and a hub for research, innovation that is shaping the future of health, not only in Kenya, but across the region. Over the years, we have made deliberate and strategic investment aimed at transforming healthcare delivery, including advanced technologies such as integrated molecule center, the CyberKnife, the 3.0 Tesla MRI, and a robust hospital management information system. These investments have significantly enhanced our capacity to provide specialized care, reduce need for overseas referrals, and position Kenya as a forefront of medical innovation. At the same time, we continue to invest in our human resource to ensure that our technology is matched by the expertise required to deliver quality outcome. To our guests, at least at the heart of our work lies the aspiration for universal health coverage. The promise that every Kenyan should have access to quality health services without facing financial hardship. Our institution continues to play a central role in the realization of this goal by expanding access specialized services, improving efficiency in service delivery, and strengthening institutional capacity to meet the diverse healthcare needs of the population. However, we fully recognize that universal health coverage cannot be delivered by a single institution alone. It requires collaboration and among government, healthcare providers, academia, research institutions, and development partners. And this conference serves as a powerful demonstration of that shared commitment. We continue scaling up our care capacity to meet growing needs for specialized care. I'm glad to note that the government has committed to providing financial support towards completion and expansion of our cancer center this financial year. This is a welcome relief as we look forward to expanding our specialized care. For sure, we're going to open the cancer center care. Ladies and gentlemen, this annual scientific conference reflects our commitment, dedication to the third pillar of our mandate, which is research. Well, our institution is widely recognized for excellency, healthcare delivery and training. We are equally committed to strengthening our role as a premium research institution. The rapidly evolving healthcare landscape, characterized by emerging health challenges, advancing technologies, and changing challenging patients' expectations, demand continuous investment in research, innovation, and evidence-based practice. This conference provides a vital platform for sharing knowledge, presenting scientific work, challenging existing approaches, generating practical solutions that will shape the future of healthcare. I commend all researchers and clinicians participating in this conference for their dedication and contribution to advancing knowledge and improving patient care. To our partners and stakeholders, the success and the progress we celebrate today have been made possible through strong partnership. We extend to our sincere gratitude to the Government of Kenya, the Ministry of Health and Development and funding partners, academic research institutions, and all stakeholders who continue to support our mission. Above all, the dedication of the institution staff, whose professionalism, compassion, and commitment remain the cornerstone of our achievement and driving force behind care we provide every day. As I conclude, allow me to reaffirm that Kenyatta University Teaching, Referral and Research Hospital board unwavering commitment to excellent inpatient care, innovation, research, equitable access to health services for all Kenyans. I encourage all the participants to engage actively, collaborate meaningfully, and translate the knowledge and insight gained from this conference into practical solutions that will strengthen health delivery and bring us closer to the realization of our universal health coverage. Thank you, and God bless you. Back to you.
Thank you. Thank you, our chair. I would like to highlight that as an institution that is mandated with research, we work very closely with the State Department of Science, Research and Innovation. In Waziri, we've worked with NACOSTI to actually accredit us as a research institution officially, but we've also working with the National Research Fund and also with the Kenya Innovation Agency, Kenya, so that we are able to tap into the knowledge, but most importantly, work with us to strengthen research in this institution. I would like to invite Dr. Rosalind Owor, a representative from the State Department of Science, Research and Innovation, to provide her remarks. Karibu.
Thank you, CEO. They normally say that politicians, when they get an opportunity, they normally say something that is not even within the function that is there. Let me take this opportunity to inform us that the State Department for Science, Research and Innovation is based at the Office of the Prime Cabinet Secretary, having been established by Executive Order number 1 of 2025, and having been given the mandate to coordinate research in the country at all MDAs, that is at national and also county government. As I stand here, my name has been said. I'm the Director of Research in the State Department. Today I'm representing my Principal Secretary, Professor Shaukat Abdul Razak, EBS, and I'm here to give his speech. Honorable Aden Dwale, CS, Ministry of Health, Director General Dr. Patrick Amoth, Mr. James Kibogo Wamboy, Board Chairman KUTRRH, Dr. Board Members, Dr. Zainab Gura, CEO, KUTRRH, Dr. Elias Meli, CEO, NCIH. Distinguished researchers, scientists, and health care professionals, development partners, ladies and gentlemen, good evening. It is a great pleasure to join you today at this important scientific conference under the timely theme, Care Without Gaps, Holistic Pathways to Universal Health Care. I congratulate Kenyatta University Teaching, Referral and Research Hospital for providing a platform where science, clinical practice, innovation and policy converge to improve the health and well-being of our people. Ladies and gentlemen, no country has achieved universal health coverage without investing in science, research, and innovation. Every major breakthrough in medicine, from vaccine and diagnostics breakthrough in medicine, from vaccine and diagnostic to precision medicine, artificial intelligence, genomics, and advanced medical devices has been driven by research. Scientific evidence enables government to make better decisions, innovations, improve the quality and accessibility of care, while research ensures that solutions are relevant to our local health challenges. As a country, Kenya recognizes that health is not only a social service, but also an important driver of economic growth, productivity, and national competitiveness. A healthy population is the foundation of a prosperous nation. The government, through the State Department for Science, Research and Innovation, is implementing a number of policy reforms to strengthen Kenya's national innovation ecosystem. Among these is the Science, Research and Innovation Synergy Framework, which brings together government, universities, research institutions, industry, development partners, and county governments to work collaboratively rather than in silos. By aligning our efforts, we accelerate knowledge generation, technology development, and the translation of research into real societal impact. In addition, we have developed the National Research Financing and Capacity Strengthening Master Plan, which provides a strategic roadmap for sustainable financing of research, development of world-class research infrastructure, strengthening human capacity, promoting multidisciplinary research clusters, supporting research chairs, enhancing international collaborations, and increasing the commercialization of research outputs. The master plan recognizes that predictable investment in research is not an expense. It is a long-term investment in national development and resilience. Ladies and gentlemen, health innovation presents one of Kenya's greatest economic opportunities. Our universities, hospitals, and research institutions continue to produce valuable discoveries. However, our greatest challenge is moving innovations from the laboratory to the marketplace and ultimately to the patients. We must strengthen innovation ecosystems by expanding incubators and technology transfer offices, protecting intellectual property, supporting clinical validation, attracting venture capital, and creating stronger partnerships between researchers, clinicians, and industry. Through effective commercialization, locally developed diagnostics, digital health solutions, pharmaceuticals, medical services, and biotechnology products can reduce import dependence, create quality jobs, stimulate local manufacturing, and improve healthcare delivery. Emerging technologies including artificial intelligence, genomics, digital health platforms, robotics, biosensors, and precision medicine are rapidly transforming healthcare globally. Kenya has an opportunity not only to adopt these technologies, but also to become a regional hub for developing and exporting health innovations across Africa. The success of these efforts will depend on strong collaboration through the triple helix model of government, academia, and industry, working closely with healthcare providers and development partners to ensure that research responds to real societal needs. Ladies and gentlemen, the conference theme reminds us that care without gaps requires innovation without boundaries. Every researcher, clinician, policymaker, and entrepreneur gathered here has a role in building a healthcare system that is accessible, affordable, equitable, and driven by evidence. Let us therefore strengthen partnership, invest in research, support innovation, and accelerate the commercialization of health technologies that improve lives. As Nelson Mandela once observed, education is the most powerful weapon which you can use to change the world. Today, we can confidently add that science, research, and innovation are among the most powerful instruments for transforming healthcare and securing our nation's future. I commend Kutrrh for its leadership in advancing research, specialized healthcare, and innovation, including initiatives such as the Universal Newborn Hearing Screening Program, which demonstrates how partnerships can improve equitable access to quality healthcare. I wish you fruitful deliberations and every success in this conference. Thank you, and God bless you.
Thank you, Dr. Rosalind. It's now my honor and pleasure to invite our Director General for Health to provide his remarks and also invite our CLs to open for us this session.
Thank you, CEO. Our chief guest, the CS for Health, Honorable Adam Dwale, allow me to ride on earlier established protocols because of exigencies of time. The theme of the second KUTRH annual scientific conference is very succinct, and it talks about care without gaps. And the gaps in modern healthcare is not just about lack of health facilities or lack of health workforce. It is more of how we coordinate. It is more about equity. It is more about continuity of care amongst other things. So this theme reflects very well with the journey that we are undertaking towards universal health coverage. Researchers are supposed to be able to generate solutions to our problems. Unfortunately now, generating information is not a problem. Translating that information into patient care is the biggest problem. So I want to challenge the researchers who are here to ensure that we can be able to generate local solutions for our own local problems. This is more important now than ever before because of the dwindling of overseas development assistance. It means, therefore, that the interventions that we are going to be able to implement to improve healthcare services for our people must be cost-effective and informed by clear data that shows impact. I want to congratulate Kenyatta University Teaching Research Hospital for convening this second annual scientific conference, because without us sitting together to be able to demonstrate what we can be able to do as African people, then we'll not be able to move away from the bondage and slavery of dependence on solutions coming from without Africa. Therefore, going forward, we want to challenge the researchers to be able to ensure that as policymakers, you dissect whatever problem that you are dealing with into a palatable formulation that I can be able to understand, so that when I develop the new guidelines for hearing aids or hearing disability, then it becomes very easy for us to implement. As healthcare is a very dynamic subject, and every day new things emerge, and therefore research is part of continuous learning. Waziri, we want to thank UTRH for this conference and for all the innovations. In fact, this is a model level 6 hospital. Based on what we have just seen regarding learning disability, this will be a center of excellence for learning disability and hearing loss, not only for this country, but for the entire region. At this juncture, I want all of us to be upstanding as we welcome our chief guest to be able to give us his keynote address. Welcome, Honorable Cabinet Secretary.
The Director General of Health, Dr. Patrick Amoth, the Chairperson of the Board of KUTRH, Mr. James Kibuga, the Chief Executive Officer, Dr. Zainab Gura, other board members, colleagues from the Ministry of Education, State Department for Research, researchers, health professionals and partners, distinguished guests, ladies and gentlemen, good evening. It is an honor for me to join you today at the second annual scientific conference of Kenyatta University Teaching Referral and Research Hospital with the theme Care Without Gaps, Holistic Pathways to Universal Health Care. And I want on the onset to thank the board, the management, and the staff of this hospital for organizing this very important scientific forum, because such forums, they provide very invaluable platform for advancing research and forging collaborations and generating evidence that ultimately translates into better policies, better clinical practice, and better health outcomes, not for our country alone, but for our citizens. This teaching, referral, and research hospital has evolved into one of Kenya's most centers of clinical excellence. It has evolved as one of the most famous centers of research, innovation, and specialized training. And beyond delivering highly specialized healthcare, as the CEO and the chairman have said, this hospital has also become a very strategic national platform that will help us generate evidence, a place to pilot innovations, and a place where government health reform agenda can be done. So as we accelerate the implementation of Taifa Care as a country, and we strengthen our referral systems, this hospital, which is the teaching and referral and research hospital, will remain central in ensuring that science informs policy and innovation improves our patients' outcome. The government remains committed to achieving universal health coverage through Taifa Care. And the Social Health Authority, the digital health transformation, the investment we are making in infrastructure, the strengthening of our healthcare workforce. We have just flagged off over 6,000 interns, doctors, nurses, clinicians, pharmacists, dentists yesterday to all our 47 and referral hospital, 47 county hospitals and referral hospitals. And we are doing all this because UHC is not simply about expanding access, but it is about ensuring that every Kenyan receives quality care without, number one, interruption, number two, without fragmentation, and number three, without inequity. And this is the true meaning of this conference theme, that it should continue guiding how we design and how we deliver healthcare services in our country. This vision is also aligns closely with our current priority at the Ministry of Health, particularly the Every Woman, Every Newborn, Everywhere initiative and the ongoing Rapid Result Initiative on maternal and newborn health led by the Director General. And what do you want to gain? What is our achievement? What is the objective of this Every Woman, Every Newborn, Everywhere? And the Rapid Result Initiatives on maternal and newborn. Our aim is to eliminate preventable maternal and newborn deaths through a very integrated, evidence-based, and people-centered care. Their emphasis are on continuity of care, early diagnosis, how do we do our timely referrals as a country, how do we do multidisciplinary collaborations and quality improvements? And all this, reflects precisely what we mean by care without gaps. I therefore hope that the scientific deliberations over the next 2 days will help us and will generate practical solutions that will strengthen our national priorities as a country. But ladies and gentlemen, the future of healthcare will be decided not only by the facilities that we build or the medicine that we prescribe, but by the knowledge we generate and how effectively we apply that knowledge. So research is the bridge between today's challenges and tomorrow's solution. As we embrace digital transformation, as we embrace artificial intelligence, as we embrace precision medicine and data-driven healthcare, we must also ensure that innovation remains evidence-based, ethically grounded, and firmly focused on improving the outcome of our patients. So technology should enhance, but should not replace compassionate, patient-centered care. Earlier today, before I came to this conference, I had the privilege of launching a very important exercise. Important to a section of our society. The ear and the hearing initiatives here at Kutrrh. And it demonstrates how research, innovation, and strategic partnership, when they come together, they close the long-standing gaps in healthcare delivery. Hearing loss affects more than 1 million Kenyans. And if left undetected, it can have a very lifelong consequences for communication, for education, and for social inclusion. And I'm encouraged that the school and the community screening program have already identified more than 900 children with hearing needs. Over 100 children have received hearing aids at Kutrrh, while about 80 high-risk newborns have undergone hearing screening. And this demonstrates the feasibility of integrating hearing screening into our routine newborn care. So on the onset, I want to thank the management, the board, our partners, Chai and all the rest who are sitting here for that initiative. And we have taken a greater step towards, creating a generous support for the Hear the World Foundation. Kutrrh will establish the first of its kind in our country, structured universal newborn hearing screening service within the public health system. That our newborns in the first month, the third month, and by the 6th month of that newborn, early detection, early screening has been done. And more so, those who are born with some complications. So Kenyatta University will join and will be the first one to have that structured universal newborn hearing screening service among all our public health system. For us as a country, this is a landmark initiative. It will strengthen early diagnosis and it will help us to do very timely intervention for infants with hearing loss, ensuring that children receive care they need during the most critical years of development. So it will also complement our broader objective of awareness, the every woman, every newborn agenda, which we want to seek in order to improve both newborn survival and lifelong development outcomes. This investment is important, and I want to commend the Hear the World Foundation, the Clinton Health Access Initiative, CHAI, the Global OHNS Initiative, and the Ministry of Education and all other partners whose collaborations has demonstrated how strategic partnership accelerate innovation and strengthen our healthcare system. Ladies and gentlemen, behind every research finding is a patient. And behind every innovation is a family. And behind every partnership is an opportunity to improve lives. As you deliberate over the next 2 days, I encourage you to think boldly, collaborate openly, and generate practical solutions that strengthen Taifa care, universal health coverage, awareness, the improvement, the quality improvement, patient safety, digital health transformation, and the implementation of science. Let this conference become a catalyst for translating scientific evidence into measurable improvements in the lives of Kenyans. The Ministry of Health remains committed to creating an enabling environment for research, innovations, and collaborations. We will continue working with our teaching and referral hospitals, with the universities, with the research institutions, with the county government and development partners to ensure that Kenya remains a leader in scientific excellence, in health innovation and evidence. And this will help us make a very informed policy while positioning our country as a regional hub for health research and innovation. As I conclude, let me commend the board, management, researchers, clinicians, healthcare workers, and partners of Kutrrh for your dedication in advancing Kenya healthcare sector. Together, let's continue building a healthcare system where innovation serves humanity, research informs policy, partnership accelerates progress, and every Kenyan can access quality healthcare without any barrier. And now is my singular honor and privilege to officially declare the second annual scientific conference of Kenyatta University Teaching and Referral Hospital officially open. Just to my sister, the director of research, when the president created the State Department, he had a good reason why he created it. And next time, because this is a research conference, tell your peers to be here. He's lucky he's not in MOH. Yeah. You know, serious business must take and must be led by serious people who take leadership, who sit in the cabinet, or who are accounting officers. The problem we have in our country is that I am not a medical doctor, and I will not be a medical doctor because I have passed that age now. By the time I go do another 6 years and specialization, that will allow you to calculate my age. But I work with technical and very professional team at MOH and all our referral hospital. And all that they require from me is leadership. So if the leadership is not there, then the technical and the experts will only do what they are supposed to do. And I'm sure if you look at the cabinet dispatch yesterday, I had 3 papers. And when I was discussing the 3 papers, 3 different papers which were passed, I spent less than 15 minutes. Because I had to go and read the whole night. Because I don't want the chairman of the cabinet, who is the president, to tell me, Minister, stop reading. Tell us what is your objective. You know, the moment somebody tells you, don't read, tell us what do you want us to approve for you. You know, I went to a meeting one day, you people, and it's good because I have been around. I like modeling indigenous. I like modeling good people. The moment you go to a meeting and you make a suggestion and you do maybe you present a research paper And one of among the people sitting, one of them who you see as a very serious person tells you, Mr. X, are you sure what you're talking about? That's a very bad indictment. That you're not even confusing people. Are you sure? Are you sure what you are telling us? And you know, one time it happened. So when we finished the meeting, I just called aside that person. I told him, no, you did not prepare yourself. Why am I saying this? The doctors, Zainab, your doctors, Dr. Masharia, and where is the lady? Dr. Mwoko, and their staff, they are very brilliant people. Can we clap for them? They know their stuff. I like associating myself with intelligent people. May I look at you like this? You know, today, my doctor for ENT is a very brilliant man called Professor Macharia. I'm sure those of you who are in the medical field, you know him. And not this Professor Macharia. Oh, his son. I was about to ask him. He's one of the most brilliant ENT. And I'm very happy. In fact, I'll text him. I say, you have a brilliant son. You know, I do know that many things I do know before when I was entering this compound. But unfortunately, I never took notes. So I'll try to, first thing I do when I go home, I'll take a paper and a pen and try to remember the good thing you're saying. So the initiative that you've started, thank you, Chai, thank you, everybody here. No child, all of us here are parents, good people. And you can imagine what our sister was saying. And we will put, now we are paying 800,000 for the benefits of SHA. But I can assure you, the remaining bit, we will talk to the benefits and advisory and panel tariff led by Professor Joko to make sure they add it. Because those families are very special families. We want everybody in our country to be equal when it comes to healthcare. You know, I was talking to their parents. Those of us who are with me. Just put yourself like those parents. They are our people. So our doctors, I am so proud of you. The hospital, please continue. Let this hospital, you know, there's no difference between this hospital and Aga Khan or Nairobi hospital. So I was telling Zainab, you must put foot on your marketing team. They must sell this facility. And we have a health summit at the end of this month. Today is 1st or 30th. Yeah, at the end of this month, we're going to showcase the power of health as a country, the achievement that we have made as a country. Because Kenya is top in the region, in Africa, in healthcare. Thank you very much, and God bless you.
CS, we will request that you remain. We know you're pressed for time, so thank you very much. I request our CEO and our chair of the board and Honorable Bosang to come. We have a few gifts of appreciation that we will request that you give to our partners and our team. Sorry. So I will invite Chai representative. Then we'll have the Director, Special Needs Education, Fred Hager. So these are just little tokens of appreciation from Kutrrh. Thank you, thank you. Then we'll have the representative, Dr. Awar from PSSTI. Dr. Toro to receive a gift of appreciation. We still remember you as the CEO. He was our first CEO. Yes. I'll invite our DG, Dr. Moth. And now I will request our chair to present this to our CS. Thank you. All right, so thank you very much. We'll go now to a quick photo session over here. Shem, please arrange us. We'll have a quick photo session, followed by a quick vote of thanks. We sing the national anthem, and we're done. Sorry?
So you start with
I'll
the
ask
first
the
photo.
DG.
The DG, please join that photo.
Fred?
Fred, please join that first photo. The organizing committee, please be on standby. All directors, management, and the organizing committee, please take to the podium. The organizing committee, please join into that photo. Organizing committee, please join into that photo. Thank you. Okay. Let's all come. Our chief guest will take the first line. Our photographers, please take your position. If they take the first line. So let's all line up. Please squeeze. We said care without gaps. Care without gaps. Please make sure you're in the photo. So group photo. No gaps at the back. Please come forward. No gaps at the back. Thank you. We'll now have the Kutrrh choir come in as we have the vote of thanks. We'd like to So ladies and gentlemen, have your seats as we have the Kutrrh choir. So we have the vote of thanks. And first and foremost, we'd like to thank each one of you for gracing this occasion. So I'd like to thank each one of you for gracing this occasion. And I would like us to do a special clap for each one of us for being here. So one clap. Wonderful. And next, I would like to appreciate the organizing committee that were able to make this possible. To our sponsors, our partners, for believing in this conference. Another clap for them. Our protocol officers, the media crew, the volunteers, and everyone making this possible. Another clap for them. Wonderful. And lastly, for all our guests, including our chief guest, I would like us to be all upstanding for a standing ovation. And we give them the famous rain clap. So we start with Rasha Rasha. Rasha Rasha, this is the small rain, ladies and gentlemen. The small rain. I remember while you were away, Cabinet Secretary, we taught them about using the sign language to clap. So this is the sign language way of appreciation. And then we move to the normal clap that you're used to. So we start small, we go increasing. Thank you, our chief guest. Radi. Wonderful. Ladies and gentlemen, we'll have the national anthem to close. Please remain upstanding. National anthem, please.
Justice be our shield and defender. May we dwell in unity, peace and liberty. Plenty be found within our borders.
Thank you. You may take your seats. Our chief guest, you're free to leave. We will continue to the next session for our scientists and everyone attending the conference. Please do not exit. And we'll have the first presentation on care without gaps by Professor F.G. Njoroge. So welcome, Prof, for the next session. And then we'll have the presentations by F&S Scientific, and we'll have the presentation by our other sponsor, Roche. So stay put as we have the presentation by Professor F.G. Njoroge. Our IT team, please be ready for our presentation as we welcome our professor. Again, ladies and gentlemen, remember this is in line with our theme for the conference, Care Without Gaps. And the first gap that this presentation is addressing is the gap of us working with the counties. Are we working alone or are we working with others and working with several partners? So IT team, we are ready for you whenever you are. And then, ladies and gentlemen, after this session, we'll have a very nice warm cup of tea and sweet snacks, healthy snacks awaiting you as we end our day one of our second annual scientific conference.
In Kenya, Dr. Njoroge was first introduced to the
So I draw your attention to the screens, media team. You can start from the beginning.
Born and raised in Kenya, Dr. Njoroge was first introduced to the intriguing world of medicine by his grandmother, who was an herbal medicinal doctor. He went on to the University of Nairobi, where he graduated with first-class honors and a degree in chemistry. He proceeded to obtain master's and doctorate degrees in organic chemistry from Case Western University in the U.S. in 1985. Since then, Dr. Njoroge has made a career as one of the scientific world's leading researchers and pioneers, particularly in the fields of infectious diseases and oncology. He has published over 120 research papers and has been awarded over 100 patents, the first African researcher to do so. He has held various leadership positions at America's leading pharmaceutical companies, from Schering-Plough to Merck to Lilly. It was while serving as director in the Department of Medicinal Chemistry at Merck Research that Dr. Njoroge made his most far-reaching research breakthrough, leading a team that discovered and brought to market a radical new medication for treating hepatitis C, a disease that infects over 3 million people in the U.S. and between 130 to 170 million people worldwide. It was for this and his other contributions to our understanding of the chemical world that Dr. Njoroge was inducted into the Scientific Hall of Fame by the American Chemical Society, the world's largest scientific society. Dr. Njoroge is a living demonstration of the reality that Africa possesses the raw intellectual material to, if properly harnessed, compete in the fields of scientific achievement. As a pioneer, he has stamped his name in history books and has blazed a path that will only lead to more groundbreaking discoveries in future generations.
Ladies and gentlemen, a standing ovation as we welcome Professor Njoroge to the stand. Wonderful. Have your seats.
Thank you, MC. And thank you, all of you, for staying back at that event that we just had. I really appreciate you being present here. And this video, I just put it together. It was put together for me, but it's very, very pertinent to us here in Kenya. And when we are thinking about research and innovation. And it's very, as you heard, we are moving to an area in our country where we are thinking of creating new medicines. And that's what I did in America for the last 40 years. And the drug that you heard about that we created back in 2011, went to the market and sold about 50 billion Kenyan shillings in the year 2012. So for the younger ones, I would say I put that video so that you can see that we can all achieve. All we need is to put our minds together and look for issues, and we are talented and we can make great things. That was one of the drugs. There were two other drugs that came from those discoveries. The honest thing I would say, when that drug went to the market, I got many calls from Kenya to send some money. Unfortunately, it was not my drug. It belonged to those companies that I was working for. So with that, I will come. That is not what I was going to discuss today. I'm going to discuss about some research. I retired from US back in 2019. And when I came back here, I was invited by KU Referral, or Teaching and Referral Hospital, to initiate research and give back to my country. And my first project, as you can see from there, and I'm setting a scene for early detection of and improved survival for esophageal cancer. This was an interest. It's a collaborative effort, and as you can see, could I have the? Oh yes, here. This was a collaborative effort between us and University of Manchester. And it's something we started back in 2021. And I would like to say when we started in 2021, we wrote a proposal that unfortunately, because of some technical hiccup, we were time barred. We were late in submission by 5 minutes. And they said they cannot approve our application. So we went back, refined it, and even got a better standing on it. And on 2022, we wrote another application, and that was the one that was funded. And I'm going to give you reasons why this particular project was awarded. We looked around in the cancer area, and as you heard this morning, the most difficult cancers are breast cancer, colon cancer, prostate cancer. But there was one very key information that we found. And if you look at this diagram here, it is showing you the incidences and mortality at looking at various cancers. Great advances have been made in things like breast cancer, colon cancer. But if you look at the number 3, which is esophageal cancer, the incidence and mortality are nearly equal. What that means, if you are diagnosed with esophageal cancer, chances of succumbing to that disease is greater than 99%. It's like a death sentence. So when we wrote this application, we wrote it to NIH of UK, and it was competing with numerous other applications from all over the world. And it was nominated and given the first position of the award. So that was very, very important, and to many researchers, you should not give up, especially if you find an important problem to solve, because this was very, very compelling, and that's why it was given that position. Now, if you look at the various cancers that are there in our country, esophageal cancer, as I showed there before, it's the third most common, but with the highest mortality. Now, there are about 4,400 cases per year. And as I said, the fatality rate is about 99.3%. Why is this happening? Of course, there are various things that people have talked about. But we all know it's late presentation. When patients see their primary doctor, they are either having a heartburn, they might be vomiting, or they have had a hiccup, and they're given either cough suppressant or something to relieve the pain. But when they come back because they cannot swallow food. And at that point, the cancer has gone to has metastasized. It has spread to other parts of the body. That's one of the reasons. And so there is delay in the diagnosis. What we also observed in various parts of our country, there is no uniformity. We saw places like Meru, the cases were much higher than in Nakuru. And if you went to places like Bomet, the cases were even very high. And the question was, what were the risk factors? The problem with that is whenever you went, that community has an answer. If you go to Meru, where our MC comes from, they were telling us it's because they chew milah. If you go to Bomet, it's because they are drinking musik. If you go to Kiambu or Nyeri, it's because they say it's because they are drinking hot tea. The question was, what are the risk factors? So we had to think about that. We also considered now approaching this problem. How do we approach it? One issue we have in Kenya as we talk is access to health care. We know 75% of our people live in rural areas. But medical facilities, most of the medical facilities, 80% of cancer centers are in Nairobi and metropolitan areas. So you can hear a disconnect there. So we had also to think about that. The other thing is there was now a need to find a good partner. And that's how we got a partnership with the University of Manchester. And we decided to adopt something we call a hub and spoke model. A hub whereby Kutrrh is the hub where we initiate the kind of things we want to do and have various counties. And we decided to start with 5 counties. And you can see them there. They are Kisii, Nyeri, Meru, Nakuru, and Kiambu. We decided let's start with 5 counties. And now decide what we're going to be looking for. Since we are collaborating with the University of Manchester, we realized that in Manchester they have a population from black ethnicity in the greater Manchester. So they were very happy to work with us because any results that we would get would also be beneficial to their people in the greater Manchester. And that's why they were also very, very excited. Any outcome would be very important to them as well. So we wrote this grant, and then as I said, the grant was very well received. And we wrote it and submitted it to NIHR, that is the awarding institution in UK. And in 2022, we were given a 3-year grant, which would run up to August 2025 of 2.7 million pounds, which was about a little bit more than 400 million Kenyan shillings. And those of you who have been who have been listening to the newspaper, I think when they saw this information, it went viral that Njoroge has been awarded 440 million Kenyan shillings for his research. They missed, and I will tell you what happened because it was given another award in UK. They missed that part. And this gave me a lot of problems, by the way. All my relatives were calling. All my friends were calling. Where is my cat? What am I getting? That was a big, even people from Kutrrh were also calling me. And some of them, they are the ones who used all this money. They had to go to do research. And the outcome was what actually made the group there give us the second award that I would be talking about. So we've been talking today about collaborations, and this is a group that we set up, a mix of people from Kenya and a group from UK. I know you cannot read, but you can see at least some faces. And this group was working together in what we call co-creation. We work together hand in hand. This project or this proposal, it was initiated here in Kenya. And like many of the other donor projects, as you see, they come from outside and they are brought to us. This was initiated not only in Kenya, but here at Kutrrh. So we are very, very excited that this thing happened and took place in this institution. You can see this is one of the pictures showing our hubs, which I've just talked about. We looked at the populations. As I said, there is Nyeri, Meru, Nakuru, Kisii, Kiambu, and there is some demographics that you can see here. We choose those locations for particular reasons. Some of them because we wanted some diversity. Places like Nakuru, there is a lot of diversity. And places like Kisii, there is less diversity. So there are reasons why we chose those. But we also need to go, we will, and you see towards the end, this was just the beginning. Also, we included other institutions who we call the stakeholders. We had KEMRE for Seru and other approvals. We had Jomo Kenyatta JKUAT, where you hear they were doing a lot of DNA work. And you see why we needed JKUAT to come and do DNA work for us, extraction of DNA. We also had Mount Kenya to do some genomics work, and also National Cancer Institute, because they are the ones, they are custodians of the cancer data. So we had those in our discussions and in our group. Now, this is very important. This is the research question. How can we tilt the balance? Because the major issue, as I said, with esophageal cancer, is that we get very late diagnosis. And late diagnosis, it means most of those patients are already at stage 3 and stage 4. So our question was, how can we tilt the balance whereby we have more of the patients diagnosed at stage 1 and 2? So we put, one of the things, we put 3 questions, 3 aims. One of them was awareness. Aim 1 was what we call awareness and community engagement. And we wanted participation from the communities. A lot of research here, sometimes we don't engage our communities properly by going to them and also giving them feedback. So that was one of the questions that can we learn the early signs and symptoms of esophageal cancer in Kenya? And I will show you how we decided between us in a co-creation manner. How did we go about that? Learning about the early diagnosis of esophageal cancer. So also we wanted, can we understand the availability and accessibility of cancer services? You know, a lot of our people, as I said, in Mashinani, they have very low access to healthcare. So we decided we are not going to tell them to be coming to, let's say, Kutrrh or other major hospitals. We now created a system which I will tell you about, how they can access. They didn't have to come. We had to go to them so that we can give them the services or to try to do the screening on from them. And the third one, for the aim one, can we build an effective awareness, and that I've talked about, and recruit screening? That was M1. So M1 was community engagement and awareness. M2, because what we realize here now is we had to find a way of finding whether they have they have any incoming esophageal cancer. And you're going to see we did some endoscopy work, which I'm going to talk about in a few minutes. Now, M2 was mostly clinical work. How do we identify whether they have esophageal cancer at an early stage? So that was M2. And this is where we actually invoked using endoscopy, but minimally invasive, where we had an endoscope putting in the esophagus, in the throat, minimally invasive, and see whether there are any regions. And if there were regions, then we would take them to the pathologist. And that would bring us to M3, where we would have a pathologist. And the interesting thing, if the pathologist found that the lesions or the biopsies that were taken during M2 were cancerous, then we would send them to JQuat, where they would extract the DNA, and we collaborated with the University of Manchester, where they would do a whole genome sequencing from the samples that we found were cancerous. It was very, very important. The important thing about this, all the risk factors I talked about, if we don't know, it might be the DNA of people in Meru might be different from one in Kisii or Nakuru. But who knows, they also might be the same. There must be the same modification of the DNA. So we are waiting for that result. But they are doing the whole genome sequencing to tell us how different or similar are those DNA. And this is work that is being done in M3. So what we had to do in M2, whereby you use the pathologist, we had to have the capacity, as well as capacity to train our healthcare workers or our clinicians how to do the endoscopy. And I'm gonna show you some of the pictures how we did that with them. And then as we did that, we also had to build the capacity for our pathologists. You know, in Kenya, pathologists have very, very few. So we had to train some people to help with the pathology work and also get them better equipment to be able to do the work in a faster way. What we are hoping in M3 is that we might find a modification in the DNA which would become a signature. And that will be a breakthrough if we could find a signature for esophageal cancer. Because that would mean that would be an important biomarker. It would be like what you do when people with diabetes, when they do hemoglobin A1C, or it would be like what they are doing now. You've heard of the way now cancer is treated, targeted therapy, whereby they are looking for a particular mutation. For example, in Western world now, They cannot treat you of cancer until they look for the biomarkers. For example, last G12C, Aga Khan is doing a lot of work on that. If you have that mutation, they can now treat you better and with less side effects. So we are hoping we might find a biomarker in M3 after we do the whole genome sequencing. So then, as I said, we had to train our clinicians. And in the beginning, of course, we didn't want to train them with people that would take a long time. A model that was working is with a pig model. You know, pigs are very good models to what happens in humans. So you can see that there is a model they are using the pig so that they can learn how to do endoscopy on a pig. So what did we do? We retrofitted. We bought a truck and retrofitted it with endoscope towers. The endoscope towers are in the truck, and this is the one that we use to dock in various sections of the country, of the counties. And we had clinicians there who would do the biopsy, or if they would take biopsies that would go to the pathologist. This is the inside of the truck. As you can see, it's very well equipped. It's a mobile clinic with all fabricated with all the necessary items that we needed to do the evaluations. Now we had to do a lot of things in the awareness. We started by what we would call inception. We would go to various community, invite the CHAs, CHPs, and they also would bring in the partners, and we would have a meeting with them to tell them why we are there for. For our awareness, we used all the media that we could get. We did use radio, we did use TV, and even churches. So we got all these people and we disseminated this information to them and attracted them to come to our things. The first area of the first information we really wanted is to have a baseline, to get an understanding of what people think. This is what we call the baseline information, or CAP, which we are looking for knowledge and attitudes and also the practices of the people. We wanted to understand what do people think about cancer, especially esophageal cancer. So that we call it CAP. That was the first part we did when we went to communities. And you can see an individual there trying to take the CAP. Then, as you can see now, we had to dock the truck in different areas. You can see that one was in Meru, and from Meru we went to Nyeri, Kisii, and Nakuru, and also Kiambu. So we went to all those different places to do that. To evaluate that data, I said we needed to do genetic work. We need high computing, high performance computer, and we got this from the grant. So we bought very high performance computer so that they can, because the data you generate from DNA work is a lot of information which you have now to sit down and try to evaluate. How we did the awareness, we did geospatial using GPS. We randomly chose through GPS various locations. As you can see, this is a community engagement. Where did we go? Where do we go in Meru? Where do we go in Nakuru? Because we don't have to. We didn't have to go to every area of that institution. We did what we call sampling, and that's what you see from M1. Now we did from the endoscopy work. You can see the numbers that we got from different locations. And if I go a little bit back, we had an idea of how many we wanted. We wanted to do from the community, first of all, inviting people to come to be screened. They would answer a questionnaire. We wanted to do genomics, whole genomic work. We needed about 100 samples so that we can power our study. So we did 2,500 we looked at 2,500 people, and from those, we were able to get to do 1,000 endoscopies from the ones that were evaluated. And out of those, we got about 86 people who had the cancer. So that was a very important. We had to move. M1 gave us the number of people that we had to look for. They went for M2, where they did endoscopy by the clinical, and the 100 samples we got are the ones we sent to JQuat for further evaluation, extraction of DNA, and sending it to Manchester. So here you can see the numbers. I don't need to go through the numbers, but these are the numbers from different counties. And one important thing we found, especially places like Nyeri, we were unexpectedly overwhelmed when we realized the doctors there. They told us from the information we are getting through this, they were overwhelmed by the number of patients that were coming back because they've been identified to have esophageal cancer. Now, from the information we have here, from the information that we got here, we had to look at this information, this data, and look at it very, very carefully. We had external advisory board, and you can see this as a group of members of external advisory board that are with us. And I am not going to give you the data because we are writing about 12 publications in peer-reviewed journals. Very interesting information. One of the things, some of the accomplishments are that in M1, we had very good community engagement and involvement. If you do good communication awareness, you will get very good engagement. We also get good clinical work because we had trained our clinicians, and also the pathology work went very, very well, so that we got close to the samples that we needed. Having the track, being able to be docked where it was needed was very, very important. Also, as you saw from the track, the emblem on the track, it was an advertising feature by itself. So people, when they saw that track, they came to us. Preliminary data, which I'm not going to show you the data itself. All I can tell you, we were able to get people who are in a number of people in stage 1 and 2. Of course, there are some with stage 3 and 4, but now we were able to see people who could not have been seen before, who are now in stage 1 and 2. But the most interesting finding was that we were able also to establish or to find people who are precancerous, dysphagia, people who have not developed into cancer, but they are just, the cells have already started differentiating, and eventually they might become cancerous. That's what you clinicians here call precancerous. And that's very important information because those would be very easy to treat. And not only that, now in combination with having established that we can get early detection of people in stage 1 and 2, that means a lot to the country. Because economically, it would mean it would be easier to treat those people rather than treating them as stage 3 and 4. And in terms of health economics, we would be saving a lot of money, and also for the families, a lot of agony, and also for the individuals themselves, less death from this disease that carries 99% in terms of mortality. So that was very, very important, and that's why I'm saying we are putting that data, and that is the data. When they saw in University of Manchester, that's the one where they give the other award for the outcome of this study. And the other thing, as I said, with numerous healthcare workers and medics who are trained in terms of capacity building. And now, more importantly, this information is not only used here in Kenya, they are using it also in Manchester because, as I said before, there is a community there that is very similar to our community here with black ethnicity. So, because of time, I won't give any more information, but the future, this is where the future is. We know it can be done. We have the truck, which some of you, when you go outside, the truck is sitting over there in the parking lot. You can see how it looks like. We think the future is now. What happened? The future is now taking this truck. Can you get back what happened there? I want to see the slide, yes. It's taking it now all over the country. We can go to Garissa, we can go to Kisumu, and people don't have to come. We can now take the truck. It has an endoscopy tower, and all you need is trained clinicians to go there and trained pathologists to do the work. So you can see this is the future whereby people will be accessing this healthcare or this diagnostics from people going to where they are. So this is where we are now. And as I said, this is about 2 months ago. They were celebrating in UK about this project. This is the information whereby they are saying how many clinicians were trained, how many samples, how many people we found to be stage 1 and 2. They were very, very happy to see that information. And for that matter, they actually they were given an award, a second award. This is not a money award. This is a recognition award. And this is what the newspapers had. But they connected this with the money. I asked them, why did you, the voice is not there. I asked them, esophageal cancer at early stage, using diagnostic work by a truck. And very interesting in interaction, partnership between University of Manchester and KU Referral Hospital, whereby we are trying to diagnose esophageal cancer at early stage using diagnostic work by a truck, using our clinicians and pathologists and community people to do all this. We've been able to diagnose esophageal cancer at an early stage.
Yeah, and these early detection mobile units were kind of very similar to the ones we're using for lung cancer in Manchester, but when placed actually in Kenya, we were able to increase screening access, detect cancers earlier, and really develop a community trust with our patients. Anything about the future, George?
Yes, we think the findings that we've gotten will be very useful for scaling up this detection of diagnosis of esophageal cancer. And we're gonna, through Ministry of Health in Kenya, as well as National Cancer Institute, we're gonna scale it up and look even other types of cancer like the colorectal cancer. That is by PI, Rob Bristol, and you can see they are very, very excited here. I can just put a disclaimer. They called me from my farm, and I was very tired, so it was not as clear as they were, and they were using the Zoom. But in any case, it was a good interaction with the University of Manchester. Now, just to acknowledge my group, it's a huge group. You can see these are the colleagues we worked with here at Kutrrh. You can see the number of people that were working in this project were enormous. And also now, I didn't put the names here, we had all the colleagues from the various counties, what we call the spokes, and also the people from Manchester. All these people were involved in this project. So, all I could say, this is a journey that we traveled. It started slow, but the outcome is very, very useful. We are now taking this information to Ministry of Health as well as to NCI to inform policy on the management of esophageal cancer. Thank you very much for your listening.
Wonderful. Thank you, Prof. As Prof takes his seat, we have one comment there, and I'd like us to appreciate him the parliamentary way. Let's appreciate him the parliamentary way. So F&S Scientific, please to the podium as we have this comment for you, Prof. Or is it a question? Just pass the mic. F&S Scientific, please get ready.
Thank you so much. My name is Victor Misuo. I'm a scientist. Prof, it's good that today I'm here and you delivered a powerful speech. I come from Tana River County. There's a village in Hola where sometimes in December last year, we've had around 15 elderly men who died. And the cause of death is suddenly they cannot eat. So we were suspecting that it's cancer, but no research has been done in that area. And they all die in that mysterious way. So back home, they believe it's voodoo. But as a scientist, I know it has something to do with cancer or the oral system. So as you answer that, my question is, the truck that is here, what does it take for you or for your team to take that truck to Tana River? What will it be required? Because I think the cases there are becoming more and more alarming every day. Thank you.
Should I wait or should I answer that question first? Okay. That's a very good question. And this NIH, the donors, that's also the question they asked us. What do you do with this truck now that the research, the project is over? And the answer we told them, we're going to go to other places that we were not able to go during the first time. And a good place to go maybe is Tana River. Come there and see what's going on there. If you can invite us there, we can arrange with your medical practitioners there. And we would like people to utilize this truck in different counties, because we have the towers. We have two endoscopy towers. And these are for us now. They are not going to go back to UK. We can use them in our country. But as I said, we are waiting for the final result if we can find a biomarker so that we can look for any marker in the blood. And that we can do even a more elaborate work in figuring that, just like as I said, when you go with diabetes, you get HbA1c. We are hoping we can get to that point. But that's a research part of M3.
Hello, just one more question. My name is Vivian Mogeni from the surgical department, and I wanted to say thank you so much for your presentation. Your body of work is amazing, and I think in the research world you've become a celebrity for what you have done so far. So my first question maybe a bit obvious, but I wanted to ask, because esophageal cancer, one of the screening modalities like you are using in the study, being endoscopy, is a bit invasive, and I think you've already mentioned about the biomarkers. So I wanted to ask, will your study, as you're looking into the different aspects, will it inform on maybe population level screening when it should start, so that or are we only focused on the cancer survival, or it can also help in the, I would say, screening to diagnosis? Maybe that's a bit vague, but you can touch on it.
I think one of the other questions that our reviewers want, especially the external advisory board, is the patient journey. And we are working on that, and we know, first of all, is from the questionnaire, we have refined our questionnaire to be able, because you cannot screen the whole population, but from the questionnaire you can get to understand who might be having that issue. And with that, but once you get it, in America they say, don't find it if you cannot fix it. So we need to know how they can be treated. First of all, like now, I was talking to the oncologists here, and they were telling me we need to find a way the best way to treat the precancer dysplasia. How do we treat that? And also even stage 1 and stage 2. We need to understand how to treat that. And that's a very good question, and I think they already have a good understanding how we can go about that, as opposed to most of the cases they've been seeing before is stage 3 and stage 4. So they have a better problem to solve right now. But I think we are getting there. And this is how research goes. You unravel one issue, you now get another one that you need to solve. But this is the way research goes. And I think your question makes a lot of sense.
No worries. And just finally, from your experience leading this program, what distinguishes research proposals that are internationally competitive from those that are scientifically sound but fail to secure funding? In particular, what should emerging researchers and institutions like ourselves in Kenya prioritize when developing proposals for global collaborations? Because you are able to secure such a huge funding in such a huge research that has benefited so many people. So going forward, what can we learn from your experience in preparing future researches and such collaborations? Takeaways that we can go with.
Good question. 2 things you can do. One, the first one, look for a very compelling case. This case was very, very compelling, saying that nearly 100% people, if they get esophageal cancer, they would die. Everybody said, well, I won't find a solution for this. When we came with the endoscopy, by the way, the endoscopy and Shem and others have been out there going to where the peoples are. It was very minimal invasive. So that is one way. But as I said, we need even a better way than that. The second one is look also for a problem that is here and also in their country. Everybody wants to have a piece of cake. If they hear, the Manchester people, because they had a similar problem in Greater Manchester, they felt this is a very good project because the outcome we get here also will help them. And the third one, which I would say, is that they are very, very interested. I worked in drug discovery. I'm a drug hunter. I worked in drug discovery for many years. We, the black community, people of black origin, we are poorly represented in TCGA. That is the atlas of genomics, because we never have any information there. And when they develop new drug, they don't know. The drug that was approved by FDA from my work in US for hepatitis C, the performance in the black community was very, very poor. And that's one of the issues we have in this country. We are using drugs that the clinical trials were done in another place, in the Caucasian population. But we never know whether they work in a similar way with our population here. And you saw, I was a board director, my friend there, I was who gave good Evans. I was a board director at Kutrrh. And I would tell them, the donors, sometimes they only want to do a project that they are interested in. So we also need to start thinking about that. They did a good study at Kutrrh on Gardasil, this HPV vaccine. And unfortunately, it was from my previous employer, Mark Sharp and Dome. They were saying you need to give 3 doses. I think they found you need only to give 1 dose. So you can see we've been giving 3 doses, but in Africa we need to give only 1 dose. So there are many things. There's a lot of questions. Some they will not support. If you take that problem to US, they will not give you the money. If you tell them that you want to reduce a dose, their market will go down. So we have to think of about a lot of things. Okay, Evans?
In the interest of time, one last comment.
Yeah, Prof, I'm grateful for that work, and I'm just imagining that when you find the signature for this type of cancer, which is deadly, of course some of us are affected, directly or indirectly of the same. I wanted to establish the mechanism to which you will, of course, expose all Kenyans to find it early, because still the scenario may remain that the patients will walk to the hospital at the late stages again. We have the signature, yes, but the approach to which you will use to have every Kenyan screened for this, or what will be suggestive signs, maybe from 86 you found, what were the common lifestyles or something that will predispose to this, that you can easily share for our benefit in this audience. Thank you.
Okay, again, that's a very interesting question. Where do we go if we find this signature? Of course, first of all, you have to patent that signature because it will be a remarkable work. It will be a breakthrough, not only for Kenya, but for the whole region and even for the whole world, if we can find that signature. Now, depending on how easy it is, because if it is just a mutation, a modification on DNA, and it can be done just like we do in other areas, like in, as I said, in diabetes, then that could be, we could inform in having NCI have it as an information of policy. So I think that is a question we would decide. First of all, it will depend. You've heard today why we are not getting to targeted therapy is because of the expense, how expensive it is doing genomic work. So we are hoping if this would be a blood marker, that can be, we could request, because we are not in the policymaker, we are not the policymaker. We work with the policymakers so that it's instituted, and we have a clear, we already have from the research I was working with, we had a clear paradigm. How do we really trace the people who might have esophageal cancer? We'll enhance that and make sure that there is a policy as to how, when people go with heartburn, they also may be told to use that signature.
Thank you. Let's appreciate Prof with one big clap. One. Thank you, Prof. F&S Scientific and Roche. Please be on standby as we conclude.
Hi, everybody. My name is Elvin Sager. I am from F&S Scientific. We are a biotech supplies company, and we also consult in terms of offering capacity building within the field of genomics. And I'm very, very happy that today, as we were having the conversations of the day, I had at least 3 researchers speak directly about what we as a company do and where we see our country and our products take our country forward to. For example, Professor Njoroge, you stated, for example, that you took the samples to Manchester for sequencing. I am very happy to inform you and everybody in the podium, in the room, that we have at least 30 next generation sequencing machines from Illumina within the country. And in fact, we are the first country within sub-Saharan Africa to have the Novasec X, which can sequence the human genome in 48 hours, a maximum of 128 samples in 48 hours. So in case you want to expand on the research you are doing, Illumina can be able to offer assistance and help within that direction. We have connections with the clients we have. For example, we worked very hard and very strongly with Dr. Alan at Aga Khan, as you mentioned. So within his field of research in cancer, we are the people that he chose to assist him in his research. And I'm very, very happy that currently we are offering solutions that are actually impacting the lives of the patients, offering solutions to their diseases and the same. Secondly, Dr. Mwanza also said that NGS is the future, and that is the truth. NGS is the future of medicine, and that's where we all should be thinking about. Now, sorry about that. Oh, thank you very much. So I'm going to just be rushing through this because most of the things I have to say were already stated by the people that are on the podium. Now, this is the current landscape of of cancer diagnosis in the country. A patient comes in, for instance, that wants to have diagnosis of colorectal cancer, and then the patient goes into the hospital, and then they do a colonoscopy. While they do the colonoscopy to the patient, they realize, for instance, that there's a growth within the colon. Then the clinician will recommend a histology, and then they do a biopsy. Sorry, I am a stammerer. A biopsy. And then once that is done, there are several levels that go through before the patient gets his results. Now, what we need to think about as researchers, as a country, is how we can be able to change this and make it much, much faster so that our patients can be able to get quality care. And with this, we are seeing a new path whereby we no longer have to go through the direction of intrusive analysis of the patient. We can only take the blood, for example, and then we can do something like circulating tumor DNA, because we understand that when somebody has cancer, the cancer releases small fragments of DNA in the blood that are very specific to different types of cancers. So if you can be able to target that within the blood, then you are able to detect the presence of cancer before the patient even shows symptoms. Now, if this can be adopted, most patients can be diagnosed when they are either at stage 1 or stage 2 cancer, which increases the survival rate by up to 95%, which I believe is something very, very interesting. Now, how does this help us to do our work as researchers, as doctors? It gives us the capacity to offer early detection, as I've said, and this one will give a very high survival rate and very low mortality rates. Secondly, there's going to give us the chance to offer comprehensive assessments. What we mean by this is that every single cancer can show the same phenotypic characteristics, but very different genetic characteristics. Therefore, by understanding the tumor biology based only on genetics, we can be able to offer a comprehensive assessment of that patient's specific type of cancer. Secondly, we can then offer specific monitoring of the patient. For instance, the patient has been treated for the cancer, and now the question comes in, how do we then check whether the cancer has come back? We don't need to take the person for a CT scan. We don't need to do another biopsy to the patient. What we can do to the patient is simply, as I said, look for the ctDNA in the blood, and that can be enough. Okay? As I said, so every cancer is very different in terms of their genetics. For instance, when you have different types of mutations, as Prof has said, you can either have a gain of function in cancer, whereby a gene is activated that was not activated before, and this can give things like for instance, the EGFR gene is a very important gene in oncogenesis. Once it is activated, the patient is more likely or not than not to get cancer. Secondly, you can have genes that are turned off. For instance, the P53 gene, when it is turned off, it predisposes the patient to cancer. Now, these different types of cancers are presenting the same phenotypic characteristics, yet they are defined very differently within their genetics. So, what we have come up with as Illumina and as F&S Scientific is an understanding of how we can be able to help the researchers to achieve what they want. I understand that we are in the business of making business as a company, but at the heart of it all, while we try to make business as a company, we also want to assist our researchers to make better decisions, to have better outcomes for their patients. Now, with that in mind, we as a company have this plan that we are instituting in different institutions, whereby if you have a grant, for instance, that may require you to get some high-level, some expensive equipment, there are some that we have. For instance, some of the sequencers that we spoke about, we have them within us. So what we do is we ask you, Daktari, Prof, you can write your grant and tell the grant provider that you already have a sequencer, and F&S will step in and offer the sequencer for you during the duration of your study. Again, in case you want a sequencer that we don't have within our midst, I've told you we have got about 30 of them in the country. We know somebody who will have a sequencer that can be able to assist you in what you do, okay? And that is very, very important to bring us together as scientists and to bring us together as a country so that we can push the healthcare of our country forward. Thank you very much.
Wonderful. Let's appreciate F&S Scientific in a better way. Let's give them the parliamentary appreciation, followed by a big one clap. Thank you. And you are available?
Sorry about that. Yes, we are available. We have a booth outside there where you can come and look at what we offer, and we can have a more detailed and deeper conversations. Professor Njoroge, I'm looking at you directly. Thank you very much.
Wonderful. Thank you, F&S Scientific. If you have a neighbor next to you, tell them care without gaps. And now, ladies and gentlemen, we've come to the end of our day one. For all presenters that were missed on day one, we start tomorrow with you. Please be on standby. We start at 8 a.m. Please confirm that on your booklet. Please ensure you have the booklet of abstracts with you. And may you enjoy the cup of tea and refreshments as we conclude the day. Thank you for attending our day one of the second KUTRH Annual Scientific Conference. Care without gaps, holistic pathways to universal health care. Make sure you shake a hand, make sure you get a contact or two, an email or two, and make sure you fill the gap that you may have for networking. Do have yourselves a nice evening. Karibuni sana. Karibuni Kenya, karibuni KUTRH. Hakuna matata. DJ, over to you.